So this talk is called Deep Plane for Dummies. There's a series, you've probably seen it, of computing for dummies and driving for dummies. I was asked to give this talk back in Fort Lauderdale on how to improve your face-off results. Some of the reviews previously are it's not your average talk. The talk I wish I'd had as a dummy, shallow answers, some deeper questions, and it's really not that hard. We're going to go through some more esoteric concepts in deep plane surgeries on how to level up your results. It's broken into these chapters: how to be consistently better than average, left brain, right brain, think like a kid, avoid bad taste and deceit, what lies beneath, pick your patients wisely, the face will guide you if you let it, layers and deep holes, don't be a dummy, and at the end, I think we're going to skip the movie because Mike has asked me to give this lecture, which is about half an hour, and the orbicularis revectoring lecture, which is also half an hour, so I'm going to do my best and we'll see where we go. The first chapters are how to be consistently better than average and left brain, right brain. So this is an average faculty at these courses. Dummies, yet it appears not. So what makes them above average, and what do they all have in common? I was asked this last year during the opening session of the American meeting with Mike and Tim, and it took me a moment to think about it. As surgeons, we are selected, streamed, and measured by the powers of our left brains. Our logical, objective, rational, analytical brains are what test in boards, publications, interviews. Our right brains, however, become underdeveloped, and we fall into the see one, do one, teach one dogma that we've all been taught and grown up with. We stop thinking, and that quashes creativity. Our consulting rooms are the place for the left brain. We analyze the possible, the risks, the red flags. Our patients seek this for safety, and we need the left brain inhibition gate to keep the wrong patients out of our practices. The left brain, though, is a hindrance in the operating room. Time spent thinking about anatomy, planes, vectors, suture choice, these all mute creativity. And creativity of the whole is essential for consistently above average outcomes. The X factor, or the sparkle in patient results, comes from looking at the face as a whole and becoming subjectively artistic. And that is what all of these guys have in common. I'm very fortunate to spend a lot of time with a lot of faculty members all over the world, and I count them some of my greatest friends. And they all have highly developed bilateral hemispheres. They have good taste, exceptional dexterity and economy of movement. They think outside the box and are innovators. They question the status quo and dogma. We even have Neil Gordon sitting here at 8 o'clock on a Sunday morning. They're humble, generous, humorous, unfearful without being reckless. But more importantly, collaboration. And from that place comes innovation. There's no competition between us. There are enough patients for everybody, but as we all get better, as a specialty, all ships rise. Many of us open our practices to visitors, and that's improved global outcomes. To the point where, extraordinarily, in all of our absence, some of us were mentioned in IMCAS this year as the Rat Pack. It seems collegiality is infectious. Here's Mike. This is his Telegram group online, and that's had a huge part to play in this. If you take a picture of this, please join Mike's Telegram group, but don't post this link on social media. Don't invite non-clinicians in. But here you've got 24/7 access to global expert opinion to help with any difficult cases. Next chapter is think like a kid. Surgeons focus on what suture to use, like it's the secret behind our results, or how many centimeters past the zygomatic ligament to dissect to release the face, but this is all left brain thinking. There's a difference between seeing a face and looking at it and letting it reset back to its natural position. We don't have to correct everything. Natural imperfections are beautiful. The face will guide you if you let it, and we'll talk about this in the Cadaver lab later. This is my eldest son, Seb. He's now 18 and now an officer cadet in the British military, but when he was a little boy, I taught him suture. He was playing. He didn't overthink it. He enjoyed the right brain creativity. My other son, though, Luke, put it best. Years ago, after watching a 3-hour facelift as a little boy without an ounce of terror in his voice, he said two things. Firstly, he said my taste in music was shit. And secondly, Daddy, so basically you cut ugly people with a knife and tie them up with little bits of string to make them prettier. That's all we do. Next chapter, avoid bad taste and deceit. Humans are the most successful species in history, as we're collaborative and communicative. We're highly tuned to deception, though. And as a species, we don't like it. It threatens the whole tribe. Obvious facial surgery doesn't have to be grotesque like this to portray deception. Something as simple as poor technique leaving signs of surgery will elicit the same judgment from the observer. This lady sought help after a facelift elsewhere. Her friends asked her what she'd done as she looked strange. Poor vectors, iatrogenic tension, lid retraction, O-filled mid-face. Her face was deceptive, which led to quizzical and uncomfortable comments from others. By releasing brow tension, restoring upper eyelid shape, lower lid symmetry and support, removing her transferred fat, tensionless revector of her face and neck, she looked like herself again, or as I call it, genetically lucky. That's got to be our goal with natural facial rejuvenation. Next point, surgeons' interpretation should never trump nature's creation. Take Renee Zellweger, a face loved by a generation because of a movie. As she aged naturally and beautifully, she was pilloried in the media for an upper blepharoplasty. Was this bad surgery? No, surgeon's interpretation was. The clue is in her surname. Whilst now Texan, her heritage is Scandinavian, and all Scandinavians have a lower set brow. If anything, she needed a brow reset, not an upper blepharoplasty, and it wouldn't have made the news. We should respect natural flaws, asymmetries, and imperfections. We don't have to fix anything. Next chapter, Brave New World, What Lies Beneath? A paradigm shift has occurred recently in our facelift population. These days, faces are graveyards of previous non-surgical interventions. Fueled by the quest for filtered beauty on social media and fear of surgery, many of our patients will have surprises lurking beneath, which may complicate surgery further. From oceans of filler in the face, to non-absorbable barbs piercing facial nerve branches. This is granulomatous fibrosis from sculpture injections, caseating abscesses, or frank sterile pus. We literally don't know what we're going to find in faces when we operate on them, or how it will affect recovery. The game has changed, and there are more unknown unknowns in our patient demographic. I recently found this in a revision case. 10 points to anyone who can spot what's wrong here. This is all of the platysma I had to work with. Options were limited, but with level 4 complete release out to the modiolus, most submental descent is corrected with elevation of a pendulum midface. This is her neck and submental improvement a year out with no lateral platysmal work to work with. All of the lift, as I say, is from the central midface. Pick your patients wisely. I'm going to talk a little more on this later in the complications lecture if I have time. But these days, surgery doesn't raise my heart rate or blood pressure, but patients, their psychological baggage can. I've become forensic in my onboarding process, and the majority don't make the cut. This is my daughter Zara, showing you the red flags. I won't read them. Fortuitously for us all, I have a subspecialist interest in a prize collection of unhappy patients. So much so, I keep being invited back, last time by Neil to the American Academy, to air my dirty laundry. This was the 2023 meeting in Vegas, where I had my own stalker travel 3,000 miles just to attend. This was a difficult patient panel with armed guards at the door and at the back of the auditorium. So I have experience in the common patterns of torture we can all be put through, what works and what doesn't. Hopefully it will reassure you that this is part of a normal practice. To further credential my expertise in this area before I move on, as a seasoned veteran of online defamation, 1-star reviews, death threats, malicious criminal allegations, and police visits to my house, I've been stalked at home and conferences overseas. If you see cosmetic patients, you cannot not meet a few lunatics. This is normal. Like this one that set up an account just to compare me to various serial killers. You see the resemblance. On a more positive note, here's Zara again. These are great patients. These are unicorn patients. These are who you want to treat. The face will guide you if you let it, layers and deep holes. Don't fight natural topography. The face is built on layers and spaces, natural cleavage planes that allow safe passage with minimal trauma or resistance. If we respect natural surgical anatomy, the journey is stress-free and enjoyable. Which layer is cleaving here? Where is the natural glide plane, which is also the path of least resistance and allows tensionless redrape? Or where does the magic happen? When we pinch skin laxity in the head and neck, we're cleaving the subaponeurotic deep plane. So that is where we need to be. Stay in the right hole. It's a good rule for life. Level 4 is where the magic happens, so that's where we need to be. In the upper facial third, this is the subgaleal, subaponeurotic plane, or deep fascial plane. Call it what you want, it's a natural glide plane. In the midface, same thing. Level 4 is the subsmash subaponeurotic or deep plane. Call it what you want, it's a glide plane. And in the neck, it's the same thing. It's the subplatiform or deep fascial plane. That is the glide plane. So next section, probably the most important, don't be a dummy. It's important to be introspective and know your own confidence and ability. So literally this happened a few weeks back. I added this slide not long ago. I'm privileged to welcome observers from all over the world weekly to come and see surgery and hang with me. This surgeon arrived from a country, there's a clue on there, I won't say where, arrived and asked him what facelifts he was doing. He said he'd done 2, one smash and one deep plane. I said, that's impressive, your second lift you did a deep plane, how did it go? He said it was easy. I was like, interesting. So tell me how you do a deep plane. He then proceeds to tell me my technique, reading word for word what I've written in an article published last year. So I stop him, I say, no, tell me how you do your deep plane. And he goes again and he starts reciting my own paper. At this point I realized that I was going to spend a very, very long afternoon with someone who is highly overconfident and probably had an ability that didn't match that confidence. So uncharacteristically, I decided to make his afternoon absolute hell and took him to the Valley of Despair. But this was important. This was important. He thanked me for everything afterwards, and this is why. The Dunning-Kruger effect is a psychological phenomenon where those with the least expertise perceive their expertise to be higher than it is, leading to overconfidence, and in our field, real potential harm. After 1 or 2 facelifts without complication, you feel supreme competence atop Mount Stupid. Then something happens, either a complication or a public grilling, and your confidence plummets, but you've gained expertise. You're safer. You're higher up that slope of enlightenment. Your confidence will never reach the dizzy heights of Mount Stupid again, but you're a safe expert with a healthy respect for the inevitable complications. I would add the threshold of safety to this curve. The reality is you never master this art. This is called a masterclass. It always makes me laugh. People call me master. It's weird. All of us are only as good as our last facelift. This surgery can become routine and it can bite back if not respected. One mistake can be catastrophic and arrogance hinders improvement. Even today, thousands of facelifts behind me, comfortable, I think, on the plateau of sustainability, I finish every case having done my best with this one thought. Don't be a dummy. Sucking out all of the fat out of level 2, yanking, pulling, stretching are all really dumb things to do. My friend Subio made this for me, and it perfectly visualizes the see one, do one, teach one dogma. Leave the animals at the zoo. Fatty fox and cat eyes have no place in the gallery of either natural or tasteful facial rejuvenation. These outcomes are the bastard love children of one-night stands between dysmorphic surgeons and dysmorphic patients. Facts. Don't accept average. Avoid the comforting acceptance of average. Self-affirmations like these, we've all heard them from trainers and colleagues. They avoid evolution and learning curves. In the real world, techniques evolve, nuances are shared, and outcomes improve. I've sat on various panels where retiring surgeons mention at least half of these the reason not to evolve their 50-year-old technique. They openly accept their results are average. Some are happy to be so. That's not you guys, it's why you're here in Porto at 8 o'clock on a Sunday morning. Don't smash people up. The Instagram before and after will look good at 6 weeks. It's pretty topical that at the moment. Later on there will be signs of tension that you've placed, juxtaposition of central pendular laxity, scar migration, atrophy, sweeping, level 4 surgery, fix all of these. Another example of secondary deep plane for revision of a primary smash. You can see the same issues of juxtaposition of tension and laxity. 5 years after revision, there are no signs of late tensional failure. Arguably, she looks better at 6 months out than at 6 months out. She's 71 on the right there. Avoid the mini facelift trap. It's an easy sell, patients want them, and they've got fancy names like micro lift and mini lift. But after cutting corners, she kept her jowls and gained an atrophic scar. After a deep plane revision, this is 6 months out and 5-year follow-up. These lifts tend to age well and get better with time. So to summarize, Be brave, but not a dummy. This is a paper I published, I think, last year or the year before. It goes through in detail on how I approach and lift faces, including secondary and tertiary revision cases. You're welcome to photograph this QR code. It's a free link. Okay, I think we're going to skip the movie. I'm not sure I have time for orbicularis revectoring, but I think I've got 6 minutes. Is transconjunctival surgery necessary, orbicularis revectoring in the deep plane? I'm going to rattle through this. Mike, how's my time? Good? Will you just kick me off when you've had enough, all right? Okay, thanks. I have no disclosures. Please don't take photos of these patients. I haven't got permission from everybody for these. If they got disseminated, it would give the regulators yet another reason to come after me. They're on speed dial. So this is a classic case, aging face presenting for rejuvenation. Central facial volume deflation, descent leading to elongated lid-cheek junction, malar bags, jowls, and neck skin laxity. In the lower lid, she has lateral lid bowing, scleral show, bags, devolumization causing dark circles, and a mildly negative vector orbit. A common presentation for transconj surgery, in addition to facelift. This is orbicularis revectoring in the deep plane. She's had no eyelid intervention, no blepharoplasty or canthoplasty. This is yearly follow-up. This is 24-month follow-up. Another case with tired eyes, bags, lateral lid bowing. Classically, again, a good candidate for lower bleph. She's had no lower blepharoplasty here. Three-quarter view, you see the same thing. This is a complicated eye, post-blepharoplasty syndrome, lid retraction, chronic blepharitis, corneal exposure, 7 or 8 oculoplastic procedures. They'd given up, and she was referred to me to see if I could do anything. I didn't know, but I didn't do a blepharoplasty here. Her lid retraction is fixed by revectoring her orbicularis, and that is 2-year follow-up. So the question is transconj surgery always necessary for lower lid bags and aging face surgery to smooth the lid-cheek junction? How does the lower eyelid actually age, and how is it best restored? In this talk, I hope to have a look at that. My own approach to lower eyelid rejuvenation changed a few years ago when I noticed a significant improvement to all lower eyelid concerns by extending the deep plane procedure suborbicularis and revectoring it. The gravitational descent of the midface caused the eye bags and lower lid rounding, and once corrected, youthful anatomy was restored. We've debated this for a long time now, the cause of midface and lower eyelid complex aging. Is it devolumization, or is it descent, or is it both? Some are advocates for autologous fat, others mid-facelift, others both. The science aside, how do we restore natural unoperated beauty? NASA, of all people, have the answer. So this is a human centrifuge, and this astronaut is aging rapidly with gravity. She's not losing any volume. As she goes up to 7 Gs, all of the signs of facial aging become apparent. Why? Because of gravitational descent. As she returns to normal gravity, her face returns to youth. If we slow it right down, you can see as she starts spinning around, she starts developing little eye bags, she gets mid-face descent. Now the lateral lid is starting to round, she's starting to get jowls, the buccal fat pads herniating out. This is aging in seconds. So 2 seconds later, we go from an attractive 20-something to someone less attractive. I believe, therefore, that volume loss is overplayed. The volumes remain unchanged. And let's be honest, transferring fat from someone's butt to their face is not natural rejuvenation. This is a cadaveric study of the SOOF, an infraorbital soft tissue by Sandalescu, and it's helpful. It shows you how everything is put together. It's a 3D reconstruction of the infralateral side of the left orbit. The study concluded the SOOF in red is a 3D fibrotic meshwork of communicating spaces enveloping fat pads suspended in purple orbicularis oculi muscle and blue SMAS. Orbicularis contraction in smiling or facelift surgery will therefore elevate the SOOF as they are in continuity. In anatomical planes, the orbicularis sits in the same laminar plane as the SMAS and platysma. I'm going to scoot through all of this because it's just nonsense. It's all nonsense. Everything we discuss is nonsense, right? In 30 years, everyone will look back and go, what were those idiots talking about? It's facts. Superior extension of the flap to become an orbicularis mass platysma flap with suborbicularis dissection genital release of the orbicularis retaining ligament will allow reduction of the lid sheath junction, improvement of lower lid bowing, inferior scleral show. It will deherniate the fat pads and allow realmondization of a congenitally or post-blepharoplasty syndrome lower lid rounding. This is Mendelssohn's paper. It's a picture of the orbicularis retaining ligament. You can see it's a bilaminar structure. Innocenti did some work in 2020 demonstrating the innervation of orbicularis oculi post-blepharoplasty. Motor innervation comes from the buccal, zygomatic, and temporal branches as shown. There appears to be a safe no man's land at 8 o'clock on the right side where suborbicularis blunt section ligament release avoids the motor branches. If we superimpose a periorbital clock, we can therefore set curfews that allow safe and predictable release. These are pre-publication images. The paper is in print now and I'll make it available soon, that show the retaining ligament circles the periorbital adjacent to orbicularis oculi. You can see the position of the facial nerve branches and fat pad herniation. By tangentially dividing orbicularis and the retaining ligament, the orbicularis can hammock up the lower lid margin and elevate the midface. To avoid periorbital facial nerve branches, curfews can be set with a periorbital clock. 7 to 8 o'clock on the right side and 4 to 5 on the left are the key zones. I'll show you this in the cadaver later. The unsafe zones outside the curfews are marked. Orbicularis is then advanced as part of a SMAS orbicularis composite flap to deherniate the fat pads and improve all lower lid issues. This is a video of a facelift. You don't need to see that. We can look at it later. This is a video having raised a flap, just showing you what things look like. That's sailboat modification. Here's the SMAS cuff. How far do you release? The answer is no anatomical landmark, as far as you need. To ascertain that, I run my finger over it. If I feel guitar strings, I haven't released enough. There's the buccal fat pad. So suborbicularis space is there. That's the perimeter of the orbicularis, and it's been tangentially divided in the curfew 4 to 5 on the left side. And gently blunt spreading underneath. You can't cut anything if you blunt spread. It can bleed a little. You don't need to use bipolar, just finger pressure stops everything. You want to advance up until you feel the condensation. The ligament isn't a true ligament. No ligaments in the face are true ligaments. They're just condensations of thickening. So I keep feeling my finger until it feels completely released. I've got a Pittengi flap clamp on the distal orbicularis flap. And you can see as I put some tension on it, the lower lid margin comes up. You're not distorting the canthus, you're just improving lower eyelid position, and that's true mid-face capture. This is that patient. This is her recovery timeline from extended modified preservation or limited delamination, deep plane facelift, parotid and deep neck reductions, orbicularis revectoring, lateral brow lift and lip lift. She looks genetically lucky, not surgically operated, I think, a year out. 3/4 view, lower eyelid remains captured. If you get under orbicularis, you capture the midface, it doesn't come down. So all this BS from surgeons saying the deep plane can't capture the midface, they don't know what they don't know. It's embarrassing watching them talk. Midface has been tensionously reset. This case I shared earlier, 2 years before, she'd had a lower blepharoplasty, midface fat transfer, deep plane facelift. Her eyes looked really weird. In this video, I've got a Pittengi flap clamp on the released orbicularis. You can see how the lid margin comes up. If I stop revectoring, there's limited lid support, lid lag, and laxity. As orbicularis is revectored, lid support remains. And there's her outcome. How am I doing for time, Mike? 1 minute. All right, what should we talk about? Another case, we meet a lot of these cases. If you make subciliary incisions, I know that you all shown a subciliary incision yesterday, hands up, I didn't want to show you all how to do it because I wouldn't do it. I think you make subciliary incisions, you're going to create problems later on. So I'm glad you learned that yesterday, but honestly, don't do it. Transconjunctival approach, I think, is the right way of doing things in order of repositioning or subtraction and fat transfer. I've seen too many eyes like this from subciliary approach who are happy, but a few years later with a little bit of facial aging, a little bit of injectable magic from various people all over the world, the weight comes down, the eyes round. Thank you very much.
For those of you who don't know me, I'm Neil Gordon, and I'm going to talk about pearls and insights from 29 years of practicing in a deep plane facelift practice. And so I've been very involved in the deep plane. It was actually my fellowship thesis in 1996, and I published at the time the first long series to prove the deep plane was both safe and effective, and this led to changes that I made in the technique. Year 2000, I changed the entry point to the lateral entry point and some of the other advances. And then, I participated in the limited delamination paper with, Mike and Dominic and, Ben, which has created the concept that Mike brilliantly termed as the preservation facelift. My practice is here at the retreat at Split Rock, about an hour outside of Manhattan. It's essentially all surgical facial rejuvenation. At the retreat, we have a private hotel, surgery center, medi-spa, hyperbaric center, and all sorts of other fun stuff, including a scotch and cigar lounge for those who visit. So in conferences, we tend to focus on the technical aspects of the surgery, but an outcome is a combination of the aesthetic result and the process. The extent of the process is often the limiting aspect of a prospective patient from proceeding, and success in elective facial procedures occur when they're predictable, consistent, and reproducible. So since 2000, the evolution of my technique has been to maximize the outcome but minimize the process. And let's understand what our issues are, because patients are afraid and they have time restraints. They want the smallest possible procedure. They think less is more. They confuse the word natural with conservative. Remember that underdone surgery is actually one of the largest areas of dissatisfaction and causes of revision, and nobody ever complains to you that they look too good. So ultimately, we want to do large surgery because it's necessary, but we must make the process appear small, because ultimately, outcomes are the best marketing, in my view, of facial rejuvenation, although I think other people like Mike Nayak has proved that maybe I'm not so correct on that. But the process is a major part of the perceived outcome, and even if you have a patient that can tolerate a prolonged recovery, their referrals may not. So to have somebody say, gosh, I love my friend's result, but I don't have 6 weeks, doesn't effectively help you, because everybody's busy, whether they're celebrities or successful people. We must create the same outcome and get people back into their lives by 2 weeks. Predictability, consistent, and reproducibility. And since we can't really show any real people, this is what I call a pseudo-celebrity. This was a reality TV star. The point is that she had her show because her and her daughter were considered twins. Obviously received help in looking like her daughter. So what we want to do is be delicate with the tissues, dissect in the correct plane, no flap irregularities. Take time to make the details of your closure perfect. We use hypotensive anesthesia, tranexamic acid. I've never had any issues with TXA, and I avoid maneuvers that can add to the process as appropriate. And what we're lucky in is that complex flaps mature quickly. And then this point here is that I'm going to talk about I'm not criticizing the technique. These are great techniques, but they don't have predictable processes. Fat grafting, if your primary blepharoplasty requires a canthoplasty, you're asking for trouble. Subperiosteal dissections, and we'll talk about the issues with submandibular glands, because even in extreme cases, if we follow these concepts, we can do things like this in the next morning, and anybody who's a layperson who's looking at that outcome the next morning, they're encouraged to seek surgery rather than here. This is a very, very good surgeon, and this person, I'm sure, will eventually look fine. But that next morning when they look like that, that's not lining up with people saying, gosh, I want one of those. So the paper I published, this is one, I think this is a nice paper for you guys. I don't have the QR code like Dominic because I'm not as sophisticated as he is, but it's pearls and maximizing outcomes, and this is what we're going to talk about. The first change I made to the technique was changing the entry point to the original hammer, and it's called, I called it, I don't really name things, I'm not really good at any of that sort of stuff, there's no Gordon anything, but it's a lateral variable deep plane entry point, but it's variable, and it's based on the kind of tissue they have and where their hairlines are. Notice, and this is what Ben Tilley brilliantly called the sailboat at a later point in time, but I'm going to show you what the differences are. Now, unlike Dominic, who's an expert at revectoring, I don't delaminate the orbicularis over the orbicularis. There's nothing to lift there, and the reason why I don't is that this case was sent to me also by a terrific surgeon. So I'm showing these great surgeons because they're creating issues that I think will hamper their practice. Because this woman was 6 months out and she had persistent periorbital edema, and she was incredibly frustrated because those people see that in the mirror. So we don't dissect over the orbicularis, we don't delaminate that, which is part of the preservation concept that Mike brilliantly termed. What we release is based on the case. So in a case like this is the dissection. Notice the entry point is lateral. We're starting at the angle of the mandible. And now where I'm going superior is based on anatomical evidence of where the face is the strongest, which I won't get into in this lecture. I don't think it matters what instruments you use to do your dissection. I use a 10 blade. That's what I'm comfortable with, but whatever is comfortable in your hands. The safe spot to enter the deep plane is 2 centimeters superior to the angle of the mandible, where there's a defined floor of the masseter, a ceiling of platysma, and fibroareolar tissue. At the same time, I'm taking down some cervical ligaments. In this area here, you can be a little aggressive. And then once I see the plane, I'll use my fingers because I'm very used to feeling the tissue. And one of the things, if you'll notice I'm doing, if you watch quickly with my left hand, I'm always feeling the thickness of my flap. Because if you know the thickness of the face over the masseter muscle, you know the thickness of the face over the zygoma. And so in the areas that are more difficult to assess anatomically, you can go by the thickness of your flap over the masseter muscle to know if you're getting too deep or if you're too superficial. Now I'm taking down cervical ligaments. Now the amount of cervical ligaments I'm going to dissect below the angle of the mandible is based on my preoperative and intraoperative assessment of how that face will move, its compliance, how bad the neck is, how inferior the neck changes are. And so this also is not static. I will release a different amount in each patient. And then at this point, this shows the Q-tip is at the angle of the mandible. On this case, I released that amount. And this would lead me essentially to create this outcome. And for her, this was the amount of release in order to have a sustained outcome that both looked good quickly but held up over time. In talking about the neck, we have to separate the superficial neck from the deep neck because the causes and treatments are different. From the platysma to the skin, my view is that's all about your flap. That's all about the neck and the face are the same thing, where the deep neck is independent of facelift technique. And the mismanagement of this, because the superficial neck is very easy to access, so it tends to get overtreated. The deep neck is actually more complicated to access for many surgeons. It's undertreated, and that imbalance creates the cobra deformity. So we try to use actually a small submental incision, and we're very aggressive in moving that flap. I find this view is very helpful to delineate what is deep neck from superficial neck. The blue arrow is midline. That's your platysma, that's your flap, and your direct platysmal work. The yellow is paramedian. That's deep neck and has to be treated independently. So if we use these principles, here's a 75-year-old with 75-year-old changes, and this was her anatomy, and most of this is really superficial neck. So you can have faces that look awful, but actually if you do a very aggressive flap, because my view is the neck and the face are the same thing, we can see the angle of the mandible is in yellow and the extent of cervical release that we did. And we move so much soft tissue that we have to mark where the hair ends behind their head. because we actually could pop out there. And so we marked that limit because this is the amount of tissue that was mobilized, also inferior. So the ability to really radically mobilize tissue, and this was her 10 days later. She was irritated that we made her come and take these pictures because she was on the golf course. And you could see the amount of movement of soft tissue that was achieved, but yet still managed a recovery process that's consistent with a 75-year-old. My lessons in understanding the necessity of deep neck surgery came from a case like this very early in my career. If you notice that the red is medial, and that's going to essentially be the platysma, but paramedian, the blue, is actually more significant. And this is not in the time that we were treating these things. So although she had a nice result, if you notice, I left behind, and so if you see these bulges, paramedian, in the frontal view, your patient will. But they actually won't really see it once you get out lateral. So my criteria and how aggressive I am in the deep neck is whether I see this view in the frontal view, because they will see it afterwards. So if we take a similar case later on when we had more advanced techniques in deep neck work, we can see essentially the similar case. And here was the dissection that shows the buccal fat pad was treated in vivo. We're releasing the cervical ligaments. And then here's the dissection and shows how much cervical release. And there, in a similar case, we were able to more appropriately attack that frontal view and clean that up with a combination of aggressive flap work and deep neck work. And also the buccal fat pad treatment corrects the jowl, and we were able to create a nice gonial angle. So as far as the submandibular gland, because there's a lot of deep neck surgery, and this is, again, I'm not against anything. I'm not negative about this. I'm talking about what fits my practice model. So my issues are that I personally like, and I know Mike uses a submental incision, but most surgeons, they use a rather large incision between the hyoid and the submental crease, and it's really not a natural place for an incision. And I find it doesn't age well there. And we know it's vascular, that's not the issue, but what you do is you need exposure. It's all about exposure. And so you either have to close the capsule or leave drains in, and ultimately there tends to be leakiness of saliva. And it is very, very common to get temporary cervical nerve injuries. And then ultimately, I know Jerry O'Daniel is injecting 5-FU into the necks because they become boggy. So ultimately, so Andre Oswald gave me this video to show, and this is great access. I mean, not only can you do great deep neck work, you can take out the pancreas from that incision. So it's multiple functions. So what I find is I'm very pragmatic. I can chase all the deep neck work, and I can get glands when I want to, but a lot of times what I'll do is get digastric, and I look at the frontal view as my criteria of whether I chase it or not. There's a fine line between doing what they want and doing what they need. Remember, the patients are afraid. It's very easy to sell less. But the problem is partial results often lead to dissatisfaction and revisions. Everyone wants a conservative result until they get one. They all want it before, but go deliver it and see what that is. So I'll use analogies with them. For instance, let's say if a room needs 3 coats of paint, and you only put 1 coat of paint on it, does the room look a third better? Because it doesn't. So if you use the right analogies, if you have a pair of pants that are 4 sizes too big and you have conservative tailoring, you take off a size and a half. Are you wearing the pants? Because they're thinking they're mitigating the risk and not considering that they're creating the risk. This woman had a short scar facelift. It was all bunched and pleated. We converted it to a deep plane and did her forehead. And you can see by using much larger incisions, but making the incisions invisible, we were able to revise this face. Imbalanced procedures also, patients don't want their foreheads done. We do not use the word brow lift in our practice. It scares people, and to me, it's not about their eyebrows. It's their forehead should match their mid-face, their lower face, and their neck. And in the technique that I developed, it just recreates the eyebrow position without even trying to create that. I mean, this look here, I mean, this bunching and pleating, This is just a bad facelift. This isn't I look younger. This is I look weird, and this is on a celebrity.
I was with her 2 weekends ago.
Yeah.
She looks worse now.
Really?
She's swept. Yeah, the brow's the same. Her scars have migrated to the throat and pixies.
Right. So there you go. I thought you hung out with a better class of people, Dominic. So be careful about hypertreatment of the neck or an area without matching it. So this is a SMAS lift. It was done by a person who's getting a lot of press in New York City. And I'm sorry, this is awful. If you see the lower face has been treated, the neck was treated aggressively, but the whole mid-face is hanging over the lower face and nothing's been done to the forehead. So this, to me, is a half-painted room, and this is not a natural look. This is something that, to me, looks contrived. And ultimately treating something below and not above. And this is why we believe that the point of releasing is to move tissue. The point of dissection is to move tissue. And we're going to want to move tissue with tight sutures. And we can't just cut things below to move them above. And I find that a lot of the necessity of fat grafting is due to a lack of movement of the tissue, which creates the illusion of volume loss, which I published back about 10 years ago. So here we could see that with an aggressive approach and release and movement, we can recreate the volumization by just moving all that soft tissue back to where it started. And we do foreheads with everybody who lets me, which is about 95% of the women. So ultimately, optimizing outcomes is related to maximal lifting of the lower and the mid-face. And the greater the tissue movement, the more flap issues that we create. Ultimately, early in my career, I was having huge issues with all this soft tissue that we mobilized. And I would talk to people about this when nobody was doing deep planing, and they looked at me like the dog that heard the funny noise. Like, what are you talking about, all this tissue movement? And what we want to do is avoid delaminating to change vectors to manage transitions to the temporal area, because it defeats the biomechanics of why the deep plane work. And if you leave loose sutures for flap fixation, are your sneakers, do you leave your sneakers loose? Are your shoes loose? Or your belt loose? So ultimately, what it's suggesting is that you can't manage the flap. So otherwise, if we don't manage these things correctly, what we do is create this kind of issue where she's fine until she smiles and we see the temporal pleating that's occurring. And why does this occur? Well, let's look. So here's a case from a surgeon, and we can see here, you see that point of fixation? It's medial, it's naked, and there's no hair above it. So that point of fixation is going to create that pleat right over there. Now, that pleat will get better, but that pleat will never go away. So this, again, is a terrific surgeon, but this outcome is going to look like a facelift. So when I talk about facelifting to novices, they're all concerned about the dissection, and as Dominic brought out, what suture do we use? But when we talk about it with experts, it's all about managing the flap. At this stage in my career, my dissections are very quick, but I take longer to deal with my flap. So what we want to do is use laterally based deep sutures, and what we want to do, if you notice, is lift superiorly in the lower face where the face is strongest, because we've connected this to the neck. And then we want to extend our incisions, and notice we're going to arc our flap. And the only reason we could do this is because we have that lateral entry point. And it's not based on predetermined vectors. You have to look at where their hair is and where you could put the flap. And if you had the standard entry point, you'd never be able to layer the flap out like this. So ultimately, let's understand, because this is why even deep planes can fail. So a deep plane procedure, it gives you the ability to move tissue. But in this particular case, done by an outstanding surgeon, she had a deep plane radiodectomy, a lateral brow lift, lip lift, and a lower lid fat transposition. And the procedure failed. She was 7 months out at this point. Look at the mid-face. Look at the look of that face. It's dour. It's not just an older look. It's a negative look. Well, because of the standard entry point, the flap can only be fixated in a place that would cause temporal bunching. So what the surgeons did, and they leave the sutures loose, which doesn't lift the face. So now we're going to convert this. So this was the original entry point done by the first surgeon. I converted it to essentially what I've been doing for 25 years, which is lateral entry point. And now we were able to take that, and we did that, and we also did her forehead, because a lateral forehead does not lift the middle, and the middle is the expressive area. So when we converted it to my methodology, redoing a deep plane, we could see that the whole look, even the lip lift, looks better. And there's a much softer look that we're able to achieve because now we lifted the face. So the reason I don't believe in platysma myotomies is that if you saw where we were doing the flap, is that we want to keep continuity because the platysma and the SMAS are the same thing. And we can get a more vertical vector when the platysma is actually connected to essentially the lower face. Now, the situations where a platysma back cut is appropriate is either if you cannot lift the midface or you don't want to lift the midface. But here, this intraoperative photo or video here shows that with a large dissection, I'm going to lift where my first suture would be going. Look at the neck. See, the whole neck is coming up, but the lifting is done where the first suture of the face would be for the deep plane. And so that's why I state that failures of the neck are failures of lifting the lower and the mid face. And this is why if you're going to move that face aggressively, keep this as one flap, because we're going to treat the neck that way. So let's illustrate that in a case of a woman in her late 60s with fairly significant changes and not the most beautiful anatomy here. This is very predictive. So if you lift the lower face and you can flatten out the neck, that tells you that pretty much 90% of what you're seeing there is the flap. But look at what's going to happen. Look at the temporal area. So how are you going to manage the necessity of aggressively moving the tissue, but also the reality that you're going to end up with temporal bunching, and this is the amount of soft tissue redundancy that you really got to go after here. So if we did not have that lateral entry point, there would be no way I could layer the flap out like that. But here where I was able to be very aggressive with release movement, but still manage these areas. This was the outcome that we were able to produce from this case. This was the amount of soft tissue that was removed. We could have made a mini me out of her, but this was actually about 20% of what we directly removed from the neck. We really didn't have to do a lot of direct neck work. So if we go back to the lateral entry point, this is the end part of a dissection. The difference of how a sailboat is conceptualized versus a lateral entry point is this, is that one, we're going to enter based on an assessment of where that flap is going to move and where their hairlines are to get points of fixation right there using that tissue under the temporal hair tuft. But we're not going to fit the flap into the space. We're going to aggressively move the flap as much as we can, because as you'll see at the end of this video, if the deep plane part of the flap starts to cover the ear, you can just cut away the excess. So don't fit the flap into the space. Move the flap as much as possible. And then what you'll do is if you have extra deep plane, you just trim it away. So the point of why I developed the lateral entry point, which became essentially preservation facelifting, I just didn't know that that's a much better name, is to be able to do this. The recovery positives were a secondary gain. It was really to be able to manage the flap in an effective way. Because if you look right now, I'm going to go and just cut away the extra. See, this part of the deep plane could be fixation points. I don't need it anymore, and I'll do that the whole length. So you could put your flap anywhere you want because extra deep plane doesn't harm you. I'm going to quickly just talk about this, not about just ear defects in the sense of pixie ears. This patient I was doing for a publication, and I looked at the ear and it wasn't perfect. So my point was, if we look at this case here, there's a difference between the upright photo view of the earlobe versus intraoperatively. Look at the difference, notice the difference, match the intraoperative supine view, not their photo. So this is essentially what I did. This was the case. Notice that my intraoperative view looks more like my supine view, not the photo, and this would allow you to really control and make ears optimal. And this was just her outcome. So I'm just going to run quickly through a couple of cases. So here, if we look at somebody like this, a very recessed hairline, this is the entry point I'm going to use. It's based on that hairline to achieve this outcome. Here we're going to see lateral hooding. You have to get that lateral hooding out of the way to move your flap. She needs a forehead. She needed some deep neck work. But I think we can't lose the forest for trees. We can't overdo the deep neck when they have a long neck. It makes them look skeletal. Here on this, you can't always tell until you get inside on a particular patient. This is the outcome we're able to achieve using aggressive techniques, deep neck work, and aggressive flap fixation. This person's going to need a long cervical ligament release because she's got poor skin quality, and there's going to be extensive neck changes all the way down to the sternal notch to be able to get her to essentially achieve this harmonious level. This, again, significant aging changes. I also, as far as the gonial angle, I think we have to be careful about hypertreating that. I've carved out the gonial angle, which I'm going to show in the video for the OR, but I think if you get too excessive, it masculinizes them. So the reason why the lateral entry point started, and I'll finish with this case, I'll skip over some stuff, this pixie ear deformity. So when we see this and these kind of scars after 2 SMAS lifts, when we open this up, so this is where my entry point's going to be on her. Look how far lateral it is. The reason is because when I open her up, that's what's going to happen. Everything's going to pull away. So I'm literally going to enter right there, and that's what's going to allow me to move my flap to there, which was a necessity to be able to take the tension off the surface, move soft tissue, and revolumize her face by doing her third facelift. And then you can fix your ears only based on the amount of redundant soft tissue. So I'm going to just skip a couple here because I'm running out of time. One of this, you see that picture? She had a significant outcome, but the flash is making her open up her eyes too much. And you can see once we get there, her eyes don't look like that. She looks surprised, and her outcome wasn't surprised. Be careful how you take photos. Make sure their styling is also consistent. I can't use this before and after because she comes in looking like a Barbie doll afterwards, and everybody's going to tell me that it's her hair and makeup and dismiss the fact that we achieved this kind of result. And if you follow those things, this was a live surgery we did in Sao Paulo. This was her the morning afterwards. And I find that, your outcomes are your best marketing, and if you can achieve this in the morning, this is going to encourage people to want to do surgery. And the same here, this is one I just did a couple of months ago, also in Uberlandia. This was her the morning after also. And if you do it that way, in a way that you can control these things, not only will you make this woman look good over years, but what will happen is you're going to get all her friends that way. So, in conclusion, most patients think surgery is really, really scary. They want to avoid or minimize conservative underdone outcomes are a major cause of dissatisfactions, and the challenge is to nail both sides of it. And these are some of the changes that I made in order to achieve that. Thank you, Mike. Thanks for inviting me. The Burgers, thank you for inviting me. It's a pleasure, and we'll have fun with the cadaver later.
So I'm going to talk about lessons learned over 20 years and what we currently are calling preservation facelifting. So the disclosures I have, actually here. So we're talking about morning after. So this is morning after on this lady. And one of the things I'm most proud of about this patient is I did everything differently on this patient than I would have done 1 year before. And it made everything about her outcomes better. Her process, her final outcome, and it's from turning absolutely everything on its head. So the disclosure, obviously, This is the link to the Telegram group again. If you do join, you'll see our discussions going back 2 or 3 years. All the content's on there. It's like a fellowship that never ends. Please don't post this slide on social media, though, because I don't want a lot of patients and journalists and that kind of thing on there. One other thing that Andrew asked me to mention to you is that QMP is doing a fantastic job having professional videos done of this section, and he respectfully requests you don't take personal videos of it. You'll have immediate streaming access and ongoing streaming access until the internet stops. So, all right. This is a woman that came to me at this stage for a lower blepharoplasty. And as many of you know, I pretty much always do lower blepharoplasty through subtraction and then fat transfer to the midface. But she's super, super lean. And so I did a transposition lower blepharoplasty on this patient. And then she came back about 5 years later, and her transposition lower blepharoplasty looks pretty good, but she wants this addressed now. And to me, this is a very challenging neck. You can just see her soft tissue is very thin, her SMAS is incredibly thin. Here's the platysmal edge, super, super thin. You can see the bulk of her neck, super, super thin, weirdly draped SMAS. The key to her was unwrap, re-sculpt, so the lower face, the neck with sculpture, and then redraping the SMAS platysma as a composite unit, having almost no delamination at all. And in a previous style of lift where I would have raised a big skin flap and then maybe done a high SMAS or even a deep plane but entering very far anteriorly, this SMAS tissue would have been absolutely terrible. But by leaving the deep plane tissue together with the overlying skin, now it's like managing a tegaderm that's still got the backing on it. And you have integrity, you can move things around and have a completely different outcome than if we had delaminated these types of things. Again, the neck was sculptural, but this part's that preservation deep plane lift. So the neck is largely about deep subtraction, right? So it's all of the neck shape is created, in my opinion, by deep subtraction. And what is the neck? The neck is the foundational shapes, and then the lateral and vertical part of the neck. The submentum is face. Okay, and actually, Dominic kind of mentioned this earlier today, and so did Neil. Once you sculpt the foundation, controlling the laxity of the submental anterior neck has nothing to do with your transposition flap, has nothing to do with your lateral motion of the platysma. It has everything to do with the lifting of the face. As a matter of fact, if you take both of your fingers, both of your hands, and lift up at the masseters, you will feel your submentum tension, okay? And so the submental improvement is from facelift. And so a lot of people that want their submental neck done, they need a facelift. There's no degree of pulling laterally that improves the submental neck. Lateral pull gives you hyoid definition and gives you vertical neck improvement. But the horizontal submental neck, that is the face. And that, honestly, I didn't really understand that myself until about 2 years ago. So here's all the different things Neil has already told you. The traditional deep plane entry point from angle of mandible to lateral orbital rim. The laterally displaced deep plane entry point. The benefits of this are the tissue where the traditional deep plane entry point is, especially in the midface, is thinner and friable. As you displace the lateral deep plane entry point, almost to what a high SMAS entry point would look like, pretty close, that tissue is fibrous and tough, and it holds suture much better. The whole lift is done in layer 4 regardless, right? For those of you who are getting into deep plane surgery on this course, Neil also mentioned the best place to enter, the best place to start your lift is over the parotid and masseter, right? And when you enter at the traditional deep plane entry point, whether you continue it to traditional deep plane or do the laterally displaced, this inferior portion is the same and it overlies the parotid. So your incision overlies the tail of the parotid, and the facial nerve branches don't start coming out until a centimeter or so ahead of where this incision is. So it's a very safe place to enter because you have the parotid capsule and parotid parenchyma preserving you from where the marginal branch is. When I first started deep planes, I was really anxious about this part. I was like, my gosh, isn't this going to jeopardize the marginal branch? And it absolutely doesn't, because it's overlying the parotid. The marginal branch leaves anterior to the anterior border of parotid. So here's blue is the anterior border of parotid, red is where the actual incision is, and you have a good inch of safety margin, or a couple centimeters of safety margin before the nerves are exposed. Deep plane dissection, I do take the bottom edge, maybe the bottom centimeter of orbicularis up with me. I've gone both directions. When I first started, I was suborbicularis. Then for a few years, I went supraorbicularis because people were spooked out by suborbicularis. And now in the last few years, I've been back to suborbicularis. I just feel like this is a very natural plane. Finding the prezygomatic space, I think, is very natural. Obviously, the space between the masseter and platysma is very natural. Actually, Lissandro is going to go over this in detail here in the next presentation. But once we have these two spaces defined and we can then see the continuation of the fascia between these two spaces, to me, that's a very safe place to enter. We talked about it in my brow lift brief presentation yesterday, the temporal branch of the facial nerve crosses the zygoma at least 19 millimeters posterior to the orbital rim. So even if you take this deep plane entry point and retroplace it laterally, if you're within that first 19 millimeters or so, you could basically cut down to bone and not hit the temporal branch, okay? You can displace it all the way laterally, crossing Pitanguy's line, as long as you're taking that fascia immediately under the fascia layer, lifting it up, because the temporal branch is not only fairly far posterior. If you brought this over the temporal branch, as actually Neil showed in that one of the revision cases he just did, as long as you're not scooping down on the periosteum, this is a little more risky, but if you're just under the fascial layer, you can actually elevate this mass up off of the temporal branch. But if you want to be perfectly safe, and that's what I'd recommend for your first many, is just keep your lateral extension ahead of where Pitanguy's line is, or within the first 19 millimeters. And then even if your plane isn't perfect, you're ahead of the temporal branch, okay? When we do this, once we've found the suborbicularis space, or if you want to be supraorbicularis, that's fine, found the subplatysmal lower premasseteric space, we then want to connect the plane between those two spaces. If your assistant is retracting vertically with the retractors towards the ceiling, there is a lack of tension across the midface, and it becomes hard to follow a closed-lined plane, okay? If your assistant's doing what I'll call bunny ears retraction, and they're retracting in this diagonal fashion, that tensions the middle section of the flap, and it holds it more transversely, and it becomes a much more easy plane to follow. So I like the bunny ear style retraction on your assistant. The deep plane dissection, then of course we're releasing the ligamentous attachments in the face. I used to think of the ligamentous attachments in the face in terms of points. So there's the zygomatic ligament, masseteric ligaments, kind of point-like, platysma, auricular, mandibular. But the reality is, especially with the zygomatic ligament, there are ligamentous attachments that traverse the entire length of zygomaticus major all the way down to the modiolus. And when I first started doing subsmass, extended subsmass work, I believed in that you do this main portion of the zygomatic ligament, and then you go a centimeter or so down the zygomaticus major, and you kind of pull, and if you see the mouth elevate a little bit, you get a little smile, you see the upper lip move, then that's enough. I don't think that's enough anymore. So you really need to free, if you want the best mid-face motion, you really need to free the soft tissue off of the zygomaticus all the way down to modiolus to get the best passive mid-face translation and then hold it there, as opposed to having the midface being pulled up, bunching zygomaticus. It's not as pretty. So better ligamentous release is better midface mobility. So this is another lesson over 20 years. Now, a couple people have mentioned this preservation concept. What is it? So it's the main thing, honestly, is minimizing subcutaneous dissection. And this is, Dom influenced me on this. I need to put Neil on this, Ben on this, Mario Pelli with his lateral skin displacement, platysmoplasty. These are all variations of keeping the skin attached to the platysma or keeping the skin more attached to this mass and minimizing the subcutaneous dissection. We'll get that in a minute. That minimizes the sequela of delamination, so hematoma, seroma, telangiectasias, ischemia. Ironically, it gives you dramatically increased control of the skin of the lower neck. That's probably the most important sentence in this whole presentation. The less you delaminate the skin, the better you control the skin. And I'll get to that in a little bit. And again, it parallels preservation rhinoplasty. At the end of the surgery, because certain attachments are left, you see immediate redrape, and it looks really pretty immediately on the table. Similarly to when you preserve Pitanguy's ligament and the scroll ligaments, you have the supratip shadows defined, and the skin is draped at the immediate end of a preservation rhinoplasty. With this, you see the shadow at the hyoid angle, the shadow under the mandible on each side immediately. And so it's very similar. All right, so what are we doing? Traditional deep plane entry point, I used to undermine everything in yellow to get to the traditional deep plane entry point. I used to undermine the skin of the neck down below the last horizontal crease. If you watch QMP Volume 1, you'll see me say that that's important. Retroplacing the entry point, you can say approximating Pitanguy's line if you want to be safe. Now I only need to undermine just as far to reach the retroplaced or laterally displaced deep plane entry point. And in the segmentum, I'm only undermining far enough to go about 1 centimeter below the hyoid, so I can get in and do all my deep neck work and do my platysmal repair. And I'm not undermining the vertical neck practically at all, which is a tremendous difference from what I showed you on the slide before, right? So almost no undermining the vertical neck. And then this is not even contiguous between the segmental pocket and the lateral part. So this is a difference view. The yellow is what I used to undermine. The green is what I currently undermine. It's less than half of the skin undermining. All right, from the Telegram group 2 years ago, almost exactly 2 years ago, Mike Roskis said, I just wanted to share anecdotal evidence of late in hopes that it helps someone too. I thought I was going crazy, but my left neck results were superior to my right, sometimes substantially so. I also undermine the skin minimally in the neck a la Ben, but I would delaminate 1 to 2 centimeters above the border of the mandible just before inset. It occurred to me that I did this more often on the first side and sometimes would forget by the time I was at the left side finishing up. Turns out that was the difference. Having the skin just inferior to the gonial angle maintain attachment to the platysma allows me to create a deeper crevasse on that side. So top level reduction here, I don't delaminate above the mandible. I feel my neck results have dramatically improved. To me, the important piece here is having the skin inferior to the gonial angle maintain its attachment to the platysma. So what's that part? That's right here. Okay, having the skin not delaminated. So skin delaminated here, but just inferior to the gonial angle, leaving the skin attached to the platysma. So what does that get you? I want you to think of the control of the submental skin. If you're fully delaminated, the control of this submental skin is accomplished from your occipital inset. Okay? If your platysma is still attached through fibrostromal attachments to your skin here, the control of this skin is controlled by the platysmal tension right here. Okay, so think of a Hooke's Law kind of situation. You're cutting the distance in half or less than half of where the submental skin is controlled from compared to if you delaminate it all the way and try to inset it at your occiput. And that is incredibly powerful. It's one of the biggest changes that's happened in my facelift in the last 3 years. And I call it Roski's patch because when he put that on the Telegram, I said, that is absolutely genius. And so I was like, that's Roski's patch. Right, so this is one of the first ones I did in this fashion. And obviously these are 1 week post-ops, but I like them because they really show what happens. If you look at the sun damage, it's down here at her cricoid. After the lift, the sun damage has been expanded all the way up above her thyroid level. Can you see that? The poikiloderma, the redness? Or if you look at the white part of her neck here, the white part of her neck has been compressed into this tiny spot right here. Okay? So that the travel of the neck skin is dramatic. There's that redness, the 2 white lines. The redness has been expanded up over her thyroid level, and this whole white part has been compressed to almost the hyoid. right? It's really dramatic in my opinion. Again, this little red piece is stretched up all the way up her neck. So here's her 1 year. And you can still see those color changes as they were, right? Here's her 1 year. She was one of the very first that I did in this fashion, leaving Roski's patch attached, not delaminating anything below this level. I delaminated about 1 centimeter below the hyoid and leave all the rest of this attached to the platysma. This is one of the 6 months in after that. And so she just came back to my office. I rarely get people actually come back to the office at the 1 year mark because it's so many travelers. She came back to the office about 2 weeks ago. This is non-delaminated. I didn't delaminate anything below 1 centimeter below the hyoid. I left Roski's patch attached, did the lateral entry point, and did the full dissection from there. And to me, this is about as good as it gets. Non-delaminated the entire vertical neck. This is a 1 year follow-up. Pay attention to this spot here. I feel like Lissandro, pay attention. So the reason I say this is not that platysmal hammock. This was not a long cut along the inferior border of the mandible to get that definition. This is submandibular gland sculpture to get that definition, to reveal the kind of interface between the lateral mandible and the sternocleidomastoid. That's submandibular gland sculpture, not platysmal hammock, okay? And like Neil, I think the platysmal hammock's a bad idea because and I did it for about 1 year and I regret them all, because when you do this lifting up of the smashed platysmal unit, you feel the beautiful tension that's created in your submentum. Imagine you lift up, you leave your fingers there, and then immediately lyse the muscle just beneath your fingertips. That's what that long horizontal myotomy does, okay? And you lose control over the submentum. All right. I get this question all the time. Okay, great, that's wonderful, but that applies to young people with good skin, right? It doesn't apply to people with bad skin. For bad skin, you still need to delaminate their entire neck, right? So look at this. This is pretty bad skin. If you looked at this, it's thin, dermatoheliosis, real terrible dermis, real thin, old lady skin. Except it's not. That's my 37-year-old partner's neck. Okay? And I just compressed it forward. So what that shows you is when you compress the platysma forward, the skin looks like it's terrible skin. And it's perfect skin. So most of what we think of as terrible skin is the skin is being carried forward and compressed by the platysma, and it looks thin, and it's not. And this is hard to wrap your head around. So that's that lady. I did her for MCAS 24, right? This looks like terrible skin, and it is terrible skin, but it's not as terrible as you think. This is the delamination pattern I did in her. So the blue is the only subcutaneous undermining, just that cuff, and just the cementum enough to get in and do the deep neck work. I did not undermine anything in red. That's what I would have undermined 3 years ago. 3 years ago, I would have thought it was critical to undermine down here to get that skin freed. Here's her 1 day. There's her 1 day. You can see by leaving the skin attached to the platysma, it absolutely unfurled the skin in a vertical fashion and got this. Right? 1 day, 6 months. You never would have convinced me before I started doing this that you could improve this without actually touching the skin at all. There's been no resurfacing on this patient. She got a VI peel, which is an intraepidermal ambulatory peel. She got a VI peel for dyschromia, but other than that, there's been no resurfacing of this patient. No delamination of the skin any lower than this point. That was the lowest I worked on skin. All of this is just unloaded as the platysma lifted. Okay? So these are 6-month post-ops. I don't have longer-term post-ops on her, but they give you a sense of what's happening. To me, that's crazy. It's half the surgery and 10 times the result. All right, this is the lady I showed you her 1 day post-op. She had one spot resurfaced. She had the solar lentigo of her malar cheek resurfaced. That. TCA peel right there. Otherwise, no resurfacing. That was her 1 day. This is her 3 month. And it's the same thing. I didn't delaminate any of this. All of that's just being carried by the platysma. Same delamination pattern. Matter of fact, the delamination pattern's on this slide. That's her delamination pattern, no different than anyone else. 3 month. This is 1 year. So that's her 1 year result. There was no surgery on this area in any meaningful way. It was just carried by the platysma. Okay, 1 year, 1 year, 1 year. And it's affecting her down to her chest. So even in terrible skin types, to me, this is honestly, it's more important in terrible skin types. So Mariapelli's lateral skin displacement platysmoplasty, that was for terrible skin types, leaving the skin attached to the platysma 1 year. So lateral mandibular definition, again, Neil kind of mentioned this. The mid-body is from sculpting the submandibular gland. Anteriorly, it's from deep sculpture. And out here laterally, for me, it's the inside of the platysma and subcutaneous fat sculpting. But the subcutaneous fat sculpting happens after all of the lifting because you don't know where that is going to be until you've inset all your flaps. Okay? To platysmal myotomy, it's a double-edged sword. Bad idea. We already talked about why. This is one of my own cases going back in to redo her. There's that beautiful platysmal myotomy. You can see it. And it absolutely destroyed my submental quality. So I recommend against it. Now, starting dead space used to be what's in yellow. It's currently what's in green. When we then inset the SMAS, the ending dead space is teeny tiny. What I realized is the safest plane over a career. Initially feel like layer 2, subcutaneous is the safe plane because it's easy to see. The nerves are not there. What you realize as you get into your career, layer 2 is also the layer that creates ischemias, telangiectasias, seromas, hematomas, fibrosis. So your safest plane is layer 4, is deep to the SMAS, right? So you want to minimize that. But the ending dead space now is so small that I'm very comfortable treating the ending dead space with fibrin glue at this point. I used to use fibrin glue when I was doing mini lifts around 2007, and then I got to those huge skin displacement, skin delaminations and went to suction drains for years. And then when I started doing this again, the dead space is so small, fibrin glue is more than enough, and it does a great job. You can do a net if you don't have fibrin glue. So in summary, unwrapping the face, balancing the volumes, the neck is sculptural, refitting the SMAS after fully releasing it, and that includes the zygomatic ligamentous attachments all the way down to the modiolus to get the midface to move, limited undermining of the skin to only what's essential, only what you need to get to your SMAS and platysmal entries, and that's it. From there, the more you delaminate the skin, the worse your surgery becomes. It is absolutely the opposite of what I thought for 20 years. That's what I'm currently doing, and to me, it's the best category of results I've gotten in a long time. So thank you so much.
My name is Alessandro from Brazil. Let's go to do a brainstorm with this dissection. So here we can see the Pasquale, the laser point is here. The Pasquale incision on the orbicularis. Here, the deep plane dissection, you see. Be careful with this movement. Pay attention here. It's the worst thing that you can have in your dissection. Go under the zygomati. There is no chance, only one chance. If you cut this muscle, if you cut this nerve, there is no way. So the only one thing that you want to take care is the major muscle. If you do the dissection from this the middle face to the part of the orbicularis, is dangerous, not for the new experts. Pasquale is expert. Dominic Brake's expert. They can do anything. But us, as we are starting, You want to take care about this part. Pay attention on this. If you go home with this in your mind, I'm happy. Okay? That's the worst thing that you can have in a dissection of the facelift. Because of this, the direction of the dissection Pascali from the orbicularis to down, it's easy. Because you are walking in the muscle. If you go from the neck to the top, you can go under the muscle. That's the problem. Okay? Great. You see in the cadaver lab dissection. So let's go. Oh, I wanted to put, I wanted to check my time. Sorry. So let's go with the class, and you'll be able to do your dissection today. Another full view of the face. So, orbicularis, see about, thank Gordon, thank Nyack, it changed my result. And the neck. The neck, I go to the dissection, I do something a little more. I wanted to see the major muscle, auricular major muscle, I wanted to see the vein. So I'm totally comfortable with this. Endoscope is something that is common, but it's the last step of your life. You want to be pretty good with the open dissection of the deep plane, and then we go to the endoscope. Someone think that the endoscope is easier than the open. No. You wanted to know the anatomy. First, I learned the neck with Neil. I changed my life. I changed my life with the sea boat and the incision of the auricularis with Pascali. So this is a blend. So this is the endoscope. I will show fast. It's not easy for you, but the incision, as I tried to show for a partner yesterday, you go under the orbicularis, subcutaneous, you open the SMAS, you do the deep plane, the real deep plane, you can do the sea boat, and you can have a great result with endoscope. This is the view of the endoscope. It's not important. It's like a model, but you can do a small incision and have a great result in some cases, not all cases, okay? It's specific for some cases. You can see the orbicularis with endoscope. There I open the orbicularis. As I told you yesterday, I'm using the Etibond. I prefer, it's much easier to suture than comparing with a nylon, but doesn't matter, the result's the same. You can see crystal clear the muscle, the major muscle. That's the point that I want your attention today, okay? Let's go. Look the power of the endoscope. You can work until the neck with the platysma. Thank my father, Davis and Patrocínio, they start my life. I start my first deep plane with Giacomo 15 years ago, and then I met this guy that changed my life, Neil Gordon. And here, Pascali and Neil in my deep plane Brazil, thanks to be there, they changed and here, between the biggest guy in the world, of course, Neil put me here in the top of the world. So let's go. How to go from this result and to have this result. This is, I named it total facelift. Eye performance. My frontoplast, rhinoplast, chin advancement, facelift the plane, neck lift the plane, upper, lower blepharoplast, and nanofat that change the color, change the quality of the skin. From this case to this case, the total facelift. So let's go. Skin, eye performance, TCA peeling, Morpheus, nanofat, the incision, and skin dissection. Let's go. TCA peeling, it's easy. You want to know the quality of the skin. I think that Nyack, where are you? Nyack's not here. I think Nyack is using the TCA peeling too. I'm not sure. And it's easy, but the problem is the post-op. You want to have the control of the skin, the quality of the skin, and the shape of the skin is like this after the peeling. And another machine that I normally use when it's not available to use TCA is Morpheus or CO2 laser. You have CO2, yes? Erbium, better. But we want to take care about the skin care. It's very important. It's the last part of the cake. And nano-fat, my opinion, is the gold. It's something that changes the quality of the skin. Even in the Morpheus, even in the TCA, I use nano-fat. This is a blend of nano-fat with vitamin C, low cross-link hyaluronic acid, and Botox. So you change the quality of your skin with this blend. And I do this previously to open the deep plane, okay? And in the end of the surgery, I use in our place that I open the face. Incision, I changed my incision. I did this in the past in the hair. You did this, O'Neill, in the past, the incision into the hair, or no? No, never. So I hate this. So now I do the incision as I did a mistake, you told me in the past, and I changed my incision after Neil. Neil told me the correct way to do the incision. And now I have no problem with the bumps here because of this 1 centimeter more incision. Change my life. And this is very important. For the man, I wanted to check the shape of the hair. It's very important. And I talk for the man that the mustache will become here. It's impossible, but there is no other way to do this incision. Skin dissection. Now I change it, and I'm in love. I have the sea boat here, and now I'm doing a small sea boat in the neck, only to have less dead space here. It changed the quality of my result, the quality of the skin. It's very important, this step. So pay attention with this paper. And now in the past, I did a huge dissection of the skin, as you can see here. Yes? So nowadays, I preserve this part. I do the section only in the front. And this is the sea boat. And now I will show you how I'm performing. This is the deep plane part, as you can see. The skin dissection, deep plane part, deep plane part. I try to go until the sulcus, real deep plane. Nowadays, I'm doing like this, okay? I dissection only the part until the hyoid or a little more if it's necessary, but the deep part of the neck, I do a huge dissection. And I have no problems with the doll, the muscle. In the past, as I learned with Giacomo, I did this straight incision. Now I'm doing the incision on the deep part, the enter point, like a sea boat, as I learned with Nyack in Brazil 2 years ago. And here, the result of the neck, no dead space, no dead space, no dead space. Skin with its mass. So the quality of the skin, you can see here, the quality of the skin. Here only skin, here is a composite flap with platysma and the skin. And now, understanding the anatomy is very important. This part is very important, hydrodissection, as I showed yesterday for the students. The fame I'm not using anymore. Caves technique only to be easy. It's not for Neil, not for Dominic Braid, not for Pasquale. It's for you that's starting to become easy, the dissection. I had problems when I started. I had no confidence like this when I started the plane, so I learned it alone. Let's go to understand the anatomy. This is the video most important for you. You wanted to see this anatomy. It's very important. Let's go to understand. So, this is a cadaver lab dissection, of course. This is the nerve. So the nerve is under the fascia. And let's go to see the relationship with the zygoma nerve, with the orbicularis and the muscle. Look, this is the muscle. Yes, the major muscle. Orbiculary muscle. Thank Pasquale. So the nerve is under the muscle. That's the problem if when you start, you do the dissection from here to that. Because of this, come here, do the dissection from the orbicularis above the zygoma, so you have no problem with the nerve. You are safe. Okay? Understand? Crystal clear? So I'm happy. I can stop my class right now. That's my intention with this class. Another nerve let's go to put more problems here for you. This is the nerve that I told you. The most part in the past of the doctors think that the problem with the doll was with a mandibular nerve. It's not true. The problem with the doll was with this cervical branch, close from the platysma. So the dissection on the neck is very important because this of the article of Nyack is amazing to preserve some part in the neck. So I have no problems more with this nerve, okay? So this dissection I will show in the cadaver lab is very important. You wanted to see the platysma. So I did this in the past application. Probably I started with the platysma, and here it's not working the video. So the sea boat, it's amazing, and I use the sea boat in our paper. The caves technique. I show you hydrodissection. It's very important. Here we have a real space between the fascia and the muscle. So I start my dissection in front of the muscle, the ungular mem. Ungular. I do a small incision. It's very important for you with a cauterium, only to mark the place that you cut. It's like when you in the airplane and you see the sea and the sky. You can't see the difference. It's only one view. So because of this, I do this mark. It's important for you, not for Neil, for Nyack, for the student that is starting. Huh? Finish my time? Ah, why are you looking at me? You love me. Thank you so much. Beautiful guy. The caves technique. Let's go. I did in the past the fame. What's the problem with the fame in my hands? I had problems with swelling and edema a long 1 year, 8 months. It's terrible for me. I stopped this. So I do no more this fame. Caves technique. Let's go to understand something. Pay attention. Here, in the yellow part, my floor, I'm walking on the fascia. Under the fascia is the nerve. My hoof. Who is my hoof here? I'm looking for this mass. This green part, the neck. Who is my floor? Brazilian, do you know who is my floor here? On the neck, the correct place. Superficial deep neck fascia. Here is mass under the paroto-mesentérico fascia. Superficial deep fascia, okay? My hoof, who is my hoof here? It's red, platysma. In Brazil, we have the Amazon River, 2 colors. Here we have Amazon River. Red, platysma, yellow is mass. Sometimes you can see red and yellow together, okay? So I do this. Now I stop and I come here, Pascali, I open the orbicularis. Here, my hoof, orbicularis. My floor, terrible, the muscle. Be careful. So I do this dissection, a tunnel. I was in Lebanon, we decide the name in a caves about this paper, a tunnel here, and then I do this connection of this tunnel with this. I do the connection of this tunnel with this, and then I open. Easy, easy. Only to avoid problems. Only to avoid problems. I had problems in the past. Because of this, I change. So let's go. Open this. So, caves maneuver. I open the red part, the paroto-mesentérico fascia. You see the Amazon River, red part. I go until the vein, as you can see here. Look, crystal clear. You can see the muscle, you can see the nerve like a snake walking under the fascia. Easy. And then I do a tunnel for the neck. I know I'm above the fascia. I do this movement as I told you yesterday. I don't know where's your partner. I never cut. And now I open the neck. I see the mastoid, and the mastoid is showing me where is the nerve. I will find the major nerve here. Why I'm looking for the nerve? Because if I found the nerve, I'm exactly in the correct plane, the superficial deep neck fascia. So I do the connection with this superficial neck fascia with the red part. Now I can cut this, no problem. Easy, okay? Easy. And you can see here, the jugular and the major nerve close. Look, crystal clear. And I will never suture this nerve because I'm seeing the nerve while I suture it. So I have no pain on the ear. Some patients said, oh, I can touch in my ear. The problem is this nerve. And now I do the dissection until the vein, as you can see here. I never cut something here because the nerve is elastic. The ligament is strong. The ligament you can romp. The nerve you can't romp. So because of this, I never cut there. I do only dissection like this. I avoid to cut. You can cut, expert. If you see the dissection of you, it's blah, 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 blah. But it's totally comfortable with this. Now, I go to the Pascali part. I open the orbicularis. I will walk, and I will see the major zygomatic muscle. I have no problem because the nerve is under the muscle. I'm totally safe, okay? Perfect. And then I do the union of the purple tunnel with red tunnel. This is the stronger ligament in the face. It's very strong. If you don't release this ligament, you have no results. And here we have an arteria. The only place that you can have problems is here in this ligament. And look, I can do this dissection, and I am, look, ligament. If you push strong, you can cut. If you push, it's strong, it's ligament, you can cut. Okay? So, and another thing that you want to have in your mind, 3 vectors, 1 vectors, 2 vectors, and the hand of my assistant there. Because when you pull, the ligament became more visible for you. And look, my movement. Look, my hand. I'm doing the movement. Look, the muscle. Great. Easy. Crystal clear. So let's go to show you more anatomy. This is a view of the muscle. I never go under this muscle. Okay? I'm pretty happy if you have in your mind this. This is the dissection of the cadaver lab, exactly as we see. The fascia, under the fascia, the nerves, and the neck, the jugular and the auricular major nerve, the sternocleidomastoid muscle. Here you see the muscle. Look, the muscle, the major zygomatic muscle. Under this is dangerous. Okay? So it's a great view. Have in your mind this, so it's easy. The deep plane, it's easy. Something that is dangerous. If you go more in the neck, you can hurt this nerve. Yes, this nerve, the accessory nerve, is a problem with the shoulder. It's difficult, but something that can happen if you are aggressive here in the neck. Let's go to see and to be crystal clear your mind with the caves technique. So, orbicularis, see about, major muscle, fascia, parotomy sectorial cutaneous fascia, ligaments. Look, the orbiculary muscle, let's go to the neck. The union of the fascia, parotomy sectorial cutaneous fascia, with a superficial deep neck fascia, major muscle, and jugular vein. Very deep dissection, great results in the neck. You want to work hard on the neck. So that's my view of the dissection. So I show you some cases here. Post-op early, post-op early, post-op 6 months, post-op 6 months, recorded view, post-op 18 days for radial reduction, chin augmentation, face lift the plane, neck lift the plane, 2 months. This is a very hard nose, quaternary rhinoplasty, three-quarter view with face lift the plane, rhinoplast and frontoplast. Base view, three-quarter view, upper lower blepharoplast, chin augmentation, face lift the plane, neck lift the plane. And this last case, a hard neck, as you show, Nayak. You want to work hard on the neck. It's very important Thank you so much to pay attention.
Thank you again for the invitation, Mike, organizers. And thank you, Alessandro. You're introducing some concept that I use in my daily practice. And I try to explain to you in 20 minutes my philosophy today in the total facial rejuvenation. First of all, I want to focalize your attention on the complexity of the aging process in the face, because patients think that the problem is just only the skin. But our goal is to obtain long-lasting results and to restore the correct shape, the correct volume. So we have to address the deeper layers in the face. So this is the reason for which I prefer deep plane and extended deep plane approach to obtain the best results. One of the first questions is how long a facelifting lasts. This is probably one of the first questions patients ask when they come to me to have a facelifting. So we have to obtain good results, but we have to obtain also long-lasting results. So we have to do the best way, the best surgeries in order to obtain. So look at this kind of patient. In this patient, it's not sufficient to address the middle and the lower and the neck, because look at the situation in the eyebrow. Look the position eyebrow. You imagine to perform just only a upper blepharoplasty in this patient without the positioning the eyebrow. Look at the situation in the lip-cheek junction, in the malar area. So it's mandatory in case like this, I think, to address also the upper tier of the face in order to obtain natural results, long-lasting results. And the question is the vectors, and the question is the dissection of the orbicularis muscle, not only the dissection of this muscle and the platysmas muscle, to obtain this kind of results. But these results is just 1 year after. The question is to obtain and to maintain the results after 7 years. So the secret, in my opinion, is to the position in the correct way along the correct vectors, the deeper layers, the muscle, the orbicularis, I repeat again, this muscle and the platysmas muscle. Look at the situation in the lateral view, just 1 year after. It's almost easy to obtain this kind of results, but it's most difficult to obtain these results after, to maintain the results after several years of our surgery. So look at several years, 7 years after surgery, this is the situation. So my philosophy in facelifting. Thank you again for the father of the facelifting. You recognize this man is Hamra, and I had the pleasure to talk with him, to analyze the situation. Probably it was the last dissection course which he attended several years ago. And it was very important. In our career, we have to have some teacher, because teachers like this changed my life, changed my approach in the facial rejuvenation. So it's very, very important to focalize our attention on the importance of the total deep layers of the position in this mass, platysma and orbicularis muscle. In this article, I resume my concept, the concept of the relationship between the time and the facelifting, the correct timing, the healing process, how long does a facelift last? So it's very, very important. This is my first approach, it's the common approach. My friend Giacomo was a milestone in the deep plane. He made popular facelifting, the extended deep plane facelifting for 20 years probably. And this is the common approach. So we open this mask between the fixed and the mobilis mask. Here we extend the incision in the neck, myotomy, non-myotomy, the different treatments on the neck. Mike Nayak and other friends of mine, they are teachers in the management of the deep layers in the neck. But now I changed something, and Alessandro introduces my techniques, my total mask technique, because I think that sometimes in some patients, our goal is to extend our job also in the upper tier of the face. So the option is to make an incision here and to perform a deep temporal lift or brow lift. Okay, I have performed this for several years, but I think that focalize our attention on the orbicularis muscle. It's the goal to obtain the best results in this area. So it's my daily practice. I combine, first of all, an orbicularis muscle repositioning. It's very, very important because when patients come to us, the first thing is they say, I want this, doctor. In order to obtain this, the key is to reposition the orbicularis muscle along a 45-degree vectors. It's not possible also with the ice mask techniques, because with the ice mask techniques, this is the limit. We want to obtain this. And in my hands, it's not the same to approach with a deep dissection between the superficial and the deep temporal fascia. The secret is to the tension of the orbicularis muscle I showed yesterday. So I combine the orbicularis muscle repositioning with a standard mass and platysma reposition with the different techniques that you know. So in this way, we can address in the correct way the upper, the middle, and the lower third of the face in order to obtain a total, natural, and harmonious rejuvenation. So repeat the anatomy. Alessandro also focalize your attention on the anatomy. The anatomy is very important. You have to know the anatomy. Again, in the upper third, the orbicularis muscle, and you can see the orbital rim and the zygomatic major. So in the middle portion, it's very interesting because you can appreciate the stenodox. The stenodox is deep. If you see the stenodox during your dissection, pay attention because you are deeper. So it's important to know this anatomy. Also, in the lower portion of the face, the relationship between the marginal branch and the facial artery. So the common trunk with the parotid glands. So the marginalis branch, this is the reason for which we limit the dissection this muscle in the gonial angle here. Can you see the fascia of the masseteris muscle? And look again, Alessandro repeated before, the relationship between the zygomatic major and the zygomatic branch. The zygomatic branch is deeper. This is the reason for which we can dissect up to the zygomatic major. And also the frontal branch. You remember that is a terminal branch. So if we cut this branch, we have a lot of problems. The distance between the orbicularis opening here in the orbital rim and the frontal branch. This is the small portion of the zygomatic branch here. So it's very, very important to keep in our mind this anatomy when we dissect our orbicularis mass and platysma plane. Again, where I open the orbicularis mass and the platysma, between the fixed and the mobilis mass, is in my hands is the best way in order to obtain the correct retention and the deep tissue in the face. Again, orbital rim, the zygomatic space here, zygomatic major, the buccal branch, and the fascia of the muscle. And here you can appreciate in blue the deep dissection. My goal here is to release the retaining ligaments. Without releasing the retaining ligaments, we can achieve a good mobilization. Sometimes the stronger one is the zygomatic. When we arrive up to the zygomatic without releasing ligaments, the flap is fixed. We can mobilize the flaps in the correct way. When we cut the zygomatic, we shift 2-3 centimeters the entire soft tissues in the face in a superolateral direction. So it's very important to release this ligament. This is a revision. Look at the situation. Look at the position eyebrow. This fold here, it means that our goal is to lift along this direction. In my opinion, deep approach is not enough because I have performed this for several years, but the results after 2 years, 3 years, I'm not satisfied about this. So for this reason, I shift my interest in the orbicularis muscle. So look again, orbicularis muscle, the middle portion of it is mass, and the lower portion is the platysma. So I dissect a complete flap, orbicularis, mass, and platysma. Again, the first vector in a superolateral vector, The middle one sometimes more horizontal, and the last one is horizontal. The platysma, I fix the platysma to the sternocleidos muscle along almost horizontal vectors. So different vectors, more vertical in the upper third, horizontal in the lower third, in order to obtain this kind of results. So look at the situation here, eyebrow, temporal area with a temporal laxity. Mid-face, restoring of the volume here. Key of success sometimes is to restore the coded volume in this part. And then the neck and the cervical angle. Okay, we know several techniques. So before and after. Again, is 49 patients. So with this situation, you imagine to perform a standard D-plane middle, lower, without addressing this part. Look at the hollow appearance here in the Lichik junction. We have to restore the coded volume. The coded way in this case is not inject a huge amount of fat. The coded way is to retention the soft tissues, to retention the muscle. So for this reason, look at the proprietary planing. I do this planing with the patient in upright position in front of me in order to decide the correct vectors. The patient on table at the hand. I love these results, this volume at the hand of my surgeries. Just one day. This is the situation. I use the net just only in the lateral portion because my goal is to close the dead space. And when I reposition the orbicularis and the SMAS and the platysma, my dead space is just 1.5 centimeters in front of the skin incision, no more. So why to extend my net in the mid-face? This is another advantage of this new preservation facelifting, because our dead space is limited here in front of the skin incision, sometimes 0.5 centimeters. I extend the net here in the infraorbital ear area, because sometimes we can have a blood collection just 2 days after. I remove the net after 2 days, and my hematoma rate is 0. Because our goal is to close this dead space after our job. This is the patient just 1 year after. So the rejuvenation upper third is very, very important. Also in male patient, it's very important sometimes. We focalize our attention on the middle and the lower. I know the lower neck, it's a very challenging area. Many techniques, submandibular gland, digastric muscle. But another important area is the upper third in facial rejuvenation. Our patient, I perform 40% of my facelifting revisions. And there are 2 challenging areas. The first one is this, Lichik junction, malar area, eyebrow, and the second the neck. So it's very important to prevent than to treat in a revision. So this is the different picture. Another man, similar. It's mandatory to open the neck, to perform a good job in the deep layers, to remove the submandibular gland. We are teacher with us in this course. But also it's important to focalize our attention on the periorbital area. Another very, very interesting case is a total facial rejuvenation. I combine also with lip lifting, with liposuction in the lower portion of the face, in order to restore the correct shape, the correct volume, the correct jawline definition. So sometimes it's very, very important to extend our job also in this part. Look, I love this part because we have to correct also the temporal laxity. The only way is to address the orbicularis muscle, because with a deep approach, it's not possible sometimes to achieve good results. Another chapter is the combine the lateral canthal tilt lifting and cantoplasty, cantopexy without opening the eyelids. She had a previous permanent filler injection, previous attempts to perform a cantopexy. This is the results. So face lifting with total SMAS technique, lip lifting, and you can appreciate the situation. My approach in the lateral Orbicularis dissection is a common dissection for me. I open the orbicularis muscle, I remove the previous stitches that are positioned in order to obtain cantopexy. And so in this case, I perform a cantoplasty. So we can release the tendon by means of a lateral approach without opening the iris. So it's a very, very important advantage. And then I fix the new tendon in the periosteum. In this case, the periosteum was with the correct thickness. And then we reposition the orbicularis muscle, because the correct reposition and retention of the orbicularis muscle represents a good support in the lower eyelid. So we maintain the position over the time. Then the deep plane and with the opening of this muscle and the platysma, and this is the situation in the right side. I perform my surgery and the hand, and just 1 year after surgery. So we obtain good results also in the lateral canthal T repositioning, and the face and the neck and the laxity of the neck. Another patient, the same approach. I perform a cantoplasty by means of a lateral way in order to reposition the lateral canthals and the totas mass technique, jawline and the neck. In this case, I approach the submandibular gland, and I perform a medial application in the anterior belly of the platysma muscle. The same, look at the situation. Sometimes patients want to obtain this cantopexy effect. So instead of opening the eyelids when we have no necessity to remove the skin, why open the eyelids? We can perform by means of a lateral approach. Then this is the results. Look at the situation here. When we release the orbicularis muscle here, the orbicularis retaining ligaments is the key of success. We can correct this deep leaching junction and this deflection in the malar area in this way, in this case without filling. So only by means of a soft tissue repositioning. So look at this patient. She came to me and she said, I have this sad aspect. I want to improve. I want to correct my defects in my eyes. So you imagine to perform a standard deplane in this face without addressing this part. This is the results after 3 years. So we reposition the lateral canthal, we correct the soft tissues sagging here in the mid-face area, and also in the lower portion of the face and the neck by means of a totas mass technique. This is the results. I perform a rhinoplastic at the hand, and this is before and after. So by addressing the different portion of the face, we can change completely the face of our patient. Let me show you my results with fat grafting. Sometimes fat grafting is a powerful tool in order to obtain the best results. Look at these patients. This is my article that I published several years ago on PRS Journal with my friend Giovanni Botti, and we reported the results in the fat grafting injection in the face. It's very interesting because there are many areas in the face, in particular the periorbital area, where the survival rate sometimes is 100%. So don't over-inject fat in the lower and upper eyes. It's very interesting to know the experience of Guy Masseri and other surgeons, because sometimes the patient came to me, they had a hollow appearance, they had a filler or fat injection, and I have to remove the excess of the fat. So pay attention, because in the lower eye and in the upper eye, I suggested to you, don't over-inject. In other area of the face, like cheeks, like lips, nasolabial fold, jawline, you can. But in the lower eye, pay attention, as said my friends, Alessandro Martins. And the different filter I use 0.2, 0.5, 0.6 in order to create different sides of the fat. Depends on the area where I inject the filler. Two interesting cases. She had a huge amount of filler, hyaluronic acid. Sometimes when you inject hyaluronic acid, this is the results. It will be very interesting to study the effect of hyaluronic acid. Because sometimes I have to treat patients like this So you imagine to perform a facelifting without addressing this part, without repositioning the soft tissues in the mid-face area. So this is a patient before surgery. When you have hypertonic bands like this, it's mandatory to open the neck to address the hypertonic bands. There are many techniques, you know, but your tension here in the lower eyelid and in the lymphatic junction in the malar area. And finally, the second step was fat grafting. So the first step, total mass and fat grafting, and I repeat the fat grafting after 6 months and sometimes after a year after surgery. And you can perform under local anesthesia. I perform this in my office because my goal is to restore the correct volume in the mid-face compartments. Do you know that there is an interesting article Wolfram Rolich, I think, 2015 OPS journal. He described many fat compartments, superficial and deeper in the mid-face area. It's very important if we want to obtain this kind of results. So 2 years after surgery. So in this case, by combining lifting and filling, we can achieve this kind of results. Restoring of the correct volume, restoring of the position of the lymphatic junction, jawline and neck. So it's mandatory to combine, in this case, filling in the mid-face area. You can appreciate in lateral view the situation here. So rhinoplasty was like the ice on the cake at the end, because sometimes they want to change also the shape of the nose to harmonize the nose with a new face, because we are talking about new face in this patient, and this is the patient. Another case, the same. Huge amount of filler in this part, because sometimes our patient, we represent the last step. They try to correct the aging defects with the filling procedures, and they come to us, okay, you are the last chance. So we have to remove the filler. If we are fortunate, it's a reabsorbable filler. Sometimes it's a permanent filler, silicone filler. And this is the situation before. So you look, the thickness of the soft tissues is few millimeters. We have to restore the correct volume. So the preparative planing with the total mass approach, you can appreciate the orbicularis repositioning here, upper, lower eyelids, and then the area where I have to inject, I prefer inject fat at the end after the soft tissue repositioning, because sometimes change the position of the area where we really need to inject, and lip lifting was mandatory. In this case, I performed a gliding lip lifting. Yesterday, I think Francisco Gomez introduced the Daniel techniques. It's a very, very effective technique because we can put a net in the lateral portion of the upper lip in order to address also the corner of the lip, and without opening the corner. So it could be an alternative. And the fat grafting at the end, 2 years after, the same, I repeat, the fat grafting after 6 months, and you can appreciate the results. I think that is good results, and patient satisfied, I'm satisfied. So another patient, the same, I perform rhinoplasty at the same time. Sometimes it could be very, very interesting to address also the shape of the nose in order to obtain harmonious results. Interesting patients. Many problems to address at the same time. Look at the position, the eyes, the mid-face area, the neck. Look at the projection of the neck. We can do a good job in the neck, but our problem is less of projection. Prosthesis implants or bone repositioning is the only way. I had the pleasure to host my friends Giacomo in New Frontiers 2023, and this is my patients. I show you my approach. And in this case, you can appreciate also not only the orbicularity position by means of a lateral approach, but also by means of lower extended blepharoplasty. Lip lifting to start our surgery. I use sometimes a reabsorbable suture 6O monocryl. In this case, subciliary incision, suborbicularity dissection, dynamic antopexy by means of a direct approach. I use the periosteum in this case because it was a primary case. Open the neck, address the anterior belly of the muscle is mandatory when you have hypertonic bands. I want to focalize your attention on the genioplasty. I use, for several years, I use a Medport implants, so PIC implants with silicone. It's very easy. In 2 minutes, you prepare a cover pocket, you put the implants, 2 sutures, and you close. And finally, look at the vectoring of the orbicularis muscle. 4 days, 13 days. I followed this because it was a patient of my course, so I showed him the next time. 5 months, just 1 year after, and you can appreciate in the different area of the face the results, also the neck, but look at in the lateral view. We recreate a correct projection by means of the combination of platysma repositioning and prosthesis implants. Consider the prosthesis implants because sometimes the problem is the loss of projection of the neck. Again, this is my patient. Look at the situation. It's a complex case. Good. Remember this patient. Thank you again for Mike and Guy to coming this year. And this is my patient. And this is the patient just a year after surgery. In this case, total mass approach with fat grafting, lip lifting, and neck lifting. And you can appreciate the position on the lateral control, the restoring on the volume here, the position eyebrow, and in the lateral view also the jawline and the neck, patient before and after. So in conclusion, I think that total mass technique in my hands could represent a key of success in order to obtain natural, harmonious, and long-lasting results in our patients. Sometimes fat grafting represents a powerful tool. Thank you again for your kind attention.
There's some great talks there. It was a very varied morning, and congratulations everyone on some excellent results. This is an open forum on facelift surgery. This afternoon we're going to go through all the dissections and we're all going to show you absolutely everything you want to see, but are there any questions from any of that? Yes, up the top.
With this subaricularis dissection, how far medial do you go, how high, concerned with the suborbital edema postoperatively?
Yeah, so 2 of us are doing suborbicularis dissection. This all started years ago when Hamra did a subciliary approach and had a load of problems with tear pump mechanism and prolonged malar edema and, as you say, prolonged swelling under the eyes. That was my experience with significant suborbicularis space dissection, which is, so in my technique, what I do is just transect orbicularis and don't really go beyond that curfew that I talked about. But I know Michele will go under the orbicularis a lot further and delaminate it. Do you see much malar edema or?
See that could be a particular case. Also, when you don't open the lower eyelid, I use again. And I maintain these tapes for 2-3 days. And the edema reduce 70-80%.
What kind of tapes, Michele?
It's 3M foam I use for the liposuction.
Yeah.
And I cut in the correct shape. I create, it's like a compression, slight compression. It's could be very useful. And I use also when I perform a pinch, because with the sector orbicularis muscle deep, we maintain, but sometimes there is a edema in the deeper layers.
I think the
polyurethane.
The other thing one has to be aware of is everybody has filler these days. So, if you're not aware of filler, no one admits to having filler. Even if they've had filler, they've completely forgotten because it was 20 years ago and they were told by their injector it would go within 3 months. It's gone from their brain. So if you see post-operative malar edema, you can't get your head around why it's not going. It's filler till proven otherwise. There was another question up there, another hand. Yes?
Yeah, so Thank you so much for an incredible course. I'm a young plastic surgeon. I completed an aesthetic fellowship with a relatively well-respected facelift surgeon. This course, though, has really challenged a lot of the dogma that I was trained in. I was wondering if you could recommend, for someone early in practice like myself, how you would safely begin incorporating deep plane techniques and working towards achieving outcomes like you have achieved for your patients. I literally had a patient in my clinic, Dr. Nyack, last week, pull up your Instagram page and said, "This is what I want." And I said, I'm happy to try to achieve your results, but I do not have 25 years of deep plane facelift experience. I think I can safely get you an improved outcome, but I certainly am not trying to do anything that's outside of my safety wheelhouse, and also not wanting to deliver results that I would be really unhappy with. So just advice for young plastic surgeons like myself. How do you do this? You guys have obviously had 20, 25 years of experience to address, reassess. I think it's really incredible how thoughtful of surgeons you are all have been, and criticizing your results and collaborating and so on and so forth. But how does someone like me, 3 years after training, do this?
I think we all have good things to think. So I did my fellowship with Mark Glassgold, who is one of our contemporaries. And when I did my fellowship with him in 2003 to 2004, he was doing what was at that point a deep plane facelift. So a deep plane facelift is not the same as it was 20 years ago. His sublatissimal in the lower face and would kind of transition in the mid cheek to subcutaneous. And really, the upper face was just a subcutaneous lift. Lower face was sublatissimal. Even despite the fact that I probably saw him do 100 facelifts that year, and I was head and neck trained, when I got out into practice, I did all SMAS plications. My first many years, I did SMAS plications, and specifically purse string SMAS plications. And I developed soft tissue skills and developed interpersonal kind of handling skills, and made people really happy for a couple years before around 2007, I started going back into deep plane lifting, then took a detour into high SMAS and came back to deep plane. But even then, I'd say 2017, 18, what I was doing for a deep plane facelift, the sublatissimal lower face, anterior, great. In the upper face, I was only releasing, I would get a suborbicularis, release what I was describing earlier, the major, most fibrotic part of the zygomatic ligament at the origin of zygomaticus major, and basically stop. So if you look at my QMP Volume 1 videos, that's what I was doing for a deep plane facelift. Pretty well in the lower face, the tightest spot of the zygomatic ligament, a little bit on zygomaticus major, stop, and that's what I called a deep plane facelift, even like 6-7 years ago. So if I were to make a recommendation to you, is look at my Volume 1 video. There's a great SMAS plication on it, and I put it on there specifically for that purpose. It's a longer skin flap. It's a plication from the malar eminence to the angle of mandible on a couple layers. It's technically easy to execute. You'll get 80% of the result of a deep plane facelift, and you'll be comfortable, and you'll develop soft tissue skills. Once you've done enough of those that you're comfortable with it, do what I call the deep plane facelift on that volume. It's not the anterior mid-face dissection, it's the easier parts. You'll get 90% of the result. And then when you've had enough of that, then finish the extended mid-face dissection. Same thing with the neck. Don't sculpt aggressively initially. Get oblique necks that are still nicer, and then start sculpting the deeper structures. That would be my advice.
So, I came out of the gate because my thesis was the deep plane in 1996. And there were a couple of key points. So I've always done deep plane, and I changed the entry point in the year 2000 for flap management. But the keys to safety is that 2 centimeters superior to the angle of the mandible, there's very, very defined anatomy, and there's no nerve there. So you have a floor that's the masseter. You have a ceiling that's the platysma, and Lissandro was walking that out over here, and you have fiber areolar tissue. Even if you err, if you're too deep, there's nothing there, there's no nerve there, and you would see masseter. And also, the way you know that you're in the plane is if you get your finger in there, you'll feel muscle as the ceiling. It's smooth versus fat, which is actually irregular. So even for me in the days where there's radius and energy devices, I still use my hands to feel that. And you can start to develop the plane, but that spot is safe, and you just work from that spot. The second key point is that will now tell you, once you develop that over the masseter, the thickness of the face. And that will guide you in the areas where the anatomy is more obscure, like by the zygomaticus cutaneous ligament, because there's really no plane there, there's a fusion plane there. So if you know the thickness of the face over the masseter, and I'm always constantly have my hands in the face to make sure my flap is even, but that reference is both for good or for bad, meaning that if over the zygomaticus major, where the anatomy can be more obscured, if all of a sudden you make a sweep with your instrument, whatever you're cutting with, and your flap gets a little bit too thick, you back off, look where you are, and then get a little more superficial. And when you go over the zygomaticus cutaneous ligament, and if you've never done much deep plane lifting, it's okay if it's thinner, meaning you don't get the degree of tissue dissection that you would from the experienced surgeons in the room, because releasing the ligament and having the lower face dissected as one flap is such a powerful procedure that even if you lose 10% because you were a little superficial over the zygomaticus major, you're safe there. You're safe. But use the thickness of the face as your guide, because it's going to help you more than actually looking at anatomy that may be confusing at first. Because the strength of the face, and I show this in my paper that's coming out called the Evolutionary Embryologic and Anatomic Evidence that supports the deep plane, providing a precise definition, that the force of the face is the strongest essentially by the angle of the mantle, the cervical area, in an area called the fusion zone. And once you've connected that flap, the whole face will move at that point, and so will the neck, and you'll be able to feel comfortable and develop your comfort level of doing deep planes, and then you can get more advanced from there.
So I've got a more esoteric answer, as always. Firstly, I commend the way you phrased your question. You know, you did it with humility, with insight, with some trepidation and fear. And I feel really sorry for the young guys and girls who are just starting out in facelift surgery now. To be honest with you, when we started out, it was easy. Why? The outcome measure was a straight jawline and a slightly improved neck. There was no social media. There was no global comparisons to be made. If your patient looked a little bit better, even though 90% of people had pixie ears and atrophic scars, it was normal. Facelift surgery had a bad rep, but people went for it. These days, with the visibility of social media and surgeons who have, done the hard graft, created some terrible results along the way, have learnt, in the trenches doing some older techniques and have now perfected it, are able to show the results of 20, 30 years of hard work, and you guys are being asked to recreate the same thing. That's not fair, right? So introspection, I think, is really important. We can teach you technically how to do a deep plane lift, but I think Mike's advice is very apt in that, you want to cut your teeth on simpler lifts. You need to learn basic facelift management, how you get these people through, the psychological management of patients. And I'm going to talk about physical complications. I'm going to air my dirty laundry. I've had some horrific results, and I'm going to show them to you all with pride, not some trepidation.
Wait, that wasn't your complication talk you just gave?
I've got a worse one.
Oh.
Yeah.
That's all looks like complications on that talk. It was
So I think, number one, stay safe. I talked about the Dunning-Kruger effect. Have introspection. If you don't feel comfortable doing something, don't give it a go. And just build your confidence in that way. Don't look at these results and promise the world. The reason people will come to you, what your benefit is, you're not old and jaded and gray like us. You've got energy and you're hungry to learn, all right? Well, there is that as well. And there's definitely, the market slims the more expensive people become. So you've got a huge market out there. You don't need to, none of us need to compete for patients.
One last thought I'll give you, because I have a junior partner that started with me right now, and I tell him this over and over again. There are people out there that don't, like that patient may not be your patient, frankly, right? There are patients out there that don't want dramatic change, and there are patients out there that are proud to be one of the first patients of a junior surgeon, and they like wearing that mantle. I had faith in you and no one else did. I was one of the first ones. And so that patient may not be your patient. Like these other people will build you.
Correct.
Yeah. All right. Let's do our coffee break. Oh, we have another question?
One question at the top there.
Sorry, I'm so sorry.
Do you see any role in microliposuction of the jowl with heavy faces?
No role at all. Did you see the Subio picture? That's my answer.
No, I don't believe that it's a liposuction issue.
I'll give the other answer. I do that in heavy faces. As a matter of fact, I'll sometimes make a stab mid-cheek, microliposuction, and just turn the cannula 10 degrees and replant into the pre-gel sulcus, just without even moving that cannula out of the face. So I do sometimes do that in heavy faces.
My presentation now is going to we're going to focus now on the neck, and it's going to be about my technique that I want to share with you today, that it's called dual plane deep reduction neck lift with the 3D Z-plasty platysma management. Okay, so I have no conflict of interest. It's not really a conflict of interest, maybe, but I do want to share with you that I encourage you to publish in ASJ. I'm a senior international editor for ASJ and a section editor for facial surgery. So I know that here, from what I've been talking around in the dissection yesterday, there's very, very advanced surgeons in this audience. So I do encourage you that you send us your work to ASJ. It's definitely the best way to get the highest visibility of any journal focused on aesthetic plastic surgery. So I'm just going to start with the importance of the neck in facial surgery, because this is a study by Reha Yavuzur and colleagues from Istanbul. They just studied what was the area of a face of in this case females, that bothered them the most throughout their lifetime. So when they're young, the area that bothers them the most is the nose, right? The nose. As they're in their 30s, it's still the nose. When they reach their 40s, it's the periorbital region. And starting with their 50s, the area that bothers them the most is the jawline, right? And when we think of the jawline, some people have to understand the importance of how a jawline is defined. And when you look at a picture of an artist and you imagine that they want to portray beauty and attractiveness and youthfulness, you think they draw a profile picture like this. And of course, like I'm sure many of you have background in art, they would never do that, right? So a true artist, when they try to portray beauty and attractiveness, they would do this. And you think there's, that's not a big difference. Well, that's a huge difference, okay? So that little extended segmental line is the key to having jawline definition, okay? And you achieve that jawline definition by having a separation between that lateral face and the neck. because that's how shadows are formed, right? So in this case, an artist trying to portray the beauty, a photographer who are also artists, they play with lights and shadows, they're trying to portray the beauty and attractiveness and youthfulness of these models, and what they're really doing is trying to showcase that shadow underneath the full length of the jawline. So it's not about pulling in the face to define a jawline. It's about creating that separation between all the length of the jaw with the face. And if you do that in a model like this, where one has that shadow and the other one doesn't, you need to understand how you can create that shadow. So most people are very focused in the anterior submental cervical angle, right? Which, should be around 100 degrees. And that is important. That is helpful. And you can achieve that separation between your chin and your neck anteriorly very easily. Probably just by putting a chin implant and maybe a little liposuction of zone 1 anteriorly, right? And that's better, okay? You got that separation, that's better. But, the big difference is not that. The big difference for jawline definition is getting to that, okay? Now, that is jawline definition, all right? It's not about pulling, it's creating that separation, right? So how do you achieve that? You achieve that by modifying the angle laterally and posteriorly. And those are the lateral submandibular cervical angle and the posterior submandibular cervical angles. And you cannot see those angles in the profile view or in the front view, right? You can only see them in an oblique, anterocaudal, or posterior cranial view to see the angle, all right? And those angles translate into shadows, right? Because when I'm seeing that angle from a posterior cranial three-quarter view on the table, I see that I modify it. But when I put the patient on profile, the only thing I'm seeing is the submental cervical angle, the anterior submandibular cervical angle, and the rest I see a shadow. Because again, shadows and lights is the way we understand shapes, right? So what are my objectives in neck lift surgery? So definitely trying to get that shadow underneath the full length of the mandible, by addressing the lateral submandibular cervical angle and posterior one, of course. So I first published my first series of deep neck work and in PRS in 2013. This was the first series of both parotid and submandibular glands reduced at the time of a face and neck lift. And then I published my work on reduction neck lift in 2018 in Clinics and Plastic Surgery. Basically what I proposed was an algorithm of dividing the submandibular region in 3 zones and identifying or describing the structures that needed to be addressed in order to get that maximal reduction in the submandibular region. But thinking back about that publication, and we all should think about our publications and how we contributed to our specialty, I think the most important contribution was really the definition of these lateral and posterior submandibular cervical angles, which again are very important for neck attractiveness and facial attractiveness, because again, jawline definition is facial attractiveness, but it comes from the neck. So again, the only angle that was defined up to that moment was the Ellen Bogan's from 1980 submental cervical angle, right? So my approach to neck lift surgery is address the deep structures with a deep work, and then do skin muscle redraping with my superficial work. And both are very important, and they should be addressed independently from each other, right? So you see a lot of videos and surgeons that will tell you that they can pull on these very heavy, thick flaps, and they will have an impact. Look at how he's putting the forceps there to show the impact that there's in the neck. And that doesn't last. That doesn't work if there's volume underneath. It might work on the table. It might work for a few months initially, but it's like trying to do this, No matter how tight you put that thin shirt on you, it's not going to fix the problems of volume that you have underneath, no matter how tight you do it. The first one to demonstrate, and to showcase, his disappointment with what they're called Jampapa, suspension sutures or any kind of, pulling on the platysma to try to address the neck was Fodnahai in his 2004 paper where, he mentioned that over-operating on the superficial planes to try to improve deeper problems did not give long-lasting results. And he actually showed that, these were not long-lasting results, or that there was some result initially and that it was really worse long-term. I would even, argue that even initially, the result oftentimes is not that important, right? And actually, this, comes back again. It's sort of like going back and try to talk and see if there's a possibility. It comes like waves sometimes, history. So when we thought that it was important to reduce the deeper structures, I actually was asked to review this paper by UCLA. It was a good paper on age-related changes where they, Jason Rustanian from UCLA did a study on whether there's ptosis of the gland or there's enlargement of the gland with aging. And which by the fact, it's not really relevant, because he was actually showing in that paper that his management was by reducing it, because all other managements that try to bring that gland into the base of the tongue do not work. It's not like a ptosis where you can just lift like a breast. Lifting that gland in there, if you know the anatomy, there's no space for that gland to go into the floor of the mouth, okay? Especially with flexion of the neck, right? Because we need to understand the dynamic anatomy of the neck. And when you do, and I encourage you to do that, since we're going to the lab in just a few moments, when you remove the skin and the platysma of a specimen and you flex the neck, you'll see how that gland just protrudes outwardly incredibly when you flex the neck. And when you remove that gland, you will see that the anterior belly of the digastric muscle also protrudes incredibly when you flex the neck, right? And then you might say, Francisco, that's not exactly right. You're cheating because you're doing a cadaver and that's not in vivo, and then you're removing the skin and the platysma. Everything is going to protrude down. You're right. So I did this in person. So I did I did a parasagittal MRI on individuals, and you can see the structure that you see there is the gland, the submandibular gland. And what I did is I took it a step further, and I did what is called the dynamic MRI. The orthopedic surgeons use it to understand herniation of the disc in certain positions that they're not shown in the normal MRIs when you flex the neck. So what I did is showed that how low that submandibular gland travels when you flex your neck down. And look how thin that platysma is on the image, right? So it's really a thin muscle there, right? Over here. And look how far down that gland shifts when you flex the neck. It goes all the way down, practically to your cricoid, okay? And that thin muscle over there, okay? So it's sort of like, squeezing a ball and everything just pushes downwards, because there's no space for that volume to go upwards into the floor of the mouth. And we need to understand also the surface aesthetics of the attractive flexed neck. Okay, because again, we have to have that extended submental line we talked about all the way through the posterior mandible, and we have to have what I called a single creased neck, not a double creased neck. And this is interesting and important because you can have, I had a little discussion with my good friend Mario Pelliceravolo because he talked about C-necks and V-necks, and he was totally right. He was arguing that you can have a very beautiful and young, attractive neck without having to be a sharp angle between the mandible and the neck. And that's totally correct. But one thing is important, that every C-neck, meaning every neck that's not sharp on the profile view, always converts into a V-neck if that's an attractive and young individual. Always. That's just the dynamic anatomy of the flexed neck. And they always have a single creased neck. The problem is that when you try to recreate a soft C-neck, by not addressing the deeper volume of the neck, you might have a good result in the profile view, but look what happens when you flex the neck. You have a double creased neck, and this is a giveaway that the patient had surgery, okay? This is sort of like an inverted V deformity or alar notching or a poly V deformity or problems that are caused by surgery, okay? And again, we need to understand how the superficial tissues redrape in zones of flexion. So this is the Hogarth. This is sort of like the Bible for artists to drawing drapery, right? So if you see here, you have what's called bend wrinkles. And if you look at the skin, when there's volume, look at your hand, the PIP joint has a lot of volume going through it. It has the volar plate, which is very thick there, and 2 tendons going through it. So when you flex it, it's a double crease joint. The DIP joint has only 1 tendon, and it's a single crease joint. So definitely volume affects how your skin redrapes, and that's why we get double crease deformities when we don't address the deeper structures of the neck. So let me just go briefly on what I do for my deep work. And again, when you look at a patient that has a lot of volume and you might say, okay, just a little fat reduction, that's not really going to help because all of that volume laterally is the submandibular gland. Most of the volume laterally and even heavy thick necks are occupied by that volume by the gland. So you have to address first the deeper tissues anteriorly, which is the subplatysmal fat. And you can gauge how much you remove. Males I will remove more to give them more of what's called a sexual dimorphism, because males that have a big Adam's apple look more attractive because they look more masculine. Females I will definitely leave more fat over that pre-hired area. And then once you remove the subplatysmal fat, you need to address that structure laterally, which is the submandibular gland. And once you do that, then you will have bulging of your anterior belly of the digastric muscle, and you need to reduce that. So that's the gland there. And this is normally the specimens that I remove. Notice how most of that volume is just the digastric muscles and the glands, and very little fat removed. So the importance, again, of deep reduction in facial rejuvenation surgery is not only to enhance jawline definition, like we mentioned about the shadow submandibularly, but definitely to avoid inadequate and unnatural results with neck flexion. This is a second cause that you might think it's not relevant, but it is. Because if you guys have one of these with you, and probably you all do, you will eventually look down during the day, okay? And you will probably do so in public. So it's no use to have a beautiful looking neck or face in the profile view, and then, all the magic disappears when you look down at a menu or your phone, okay? So I call that the Cinderella deformity. At midnight, the fairy tale disappears, all the magic goes away. You're in this great place with all these great looking people. They look down and the neck looks horrible. So again, you notice that they've had something done and not well managed around the neck. So again, this is the strategy to address all of those deeper volumes. And when you look at that, I divided that in zone 1, 2, and 3. And now I do have a modification of the gland, because now I'm removing larger portions of what I like to call, and it's also defined in some anatomy books, not all of them, the tail of the submandibular gland, which goes all the way back almost to the angle of the mandible. So I divided my zone 3 and zone 3A, which is a horizontal portion, and zone 3B, which is the vertical portion of that angle of the mandible. And that submandibular gland also affects the shadow in zone 3A. And again, that's the difference in a patient like this, that you might say, okay, why do anything on the gland? I don't see any difference by you removing the gland between the before and after. I mean, why go through that surgery? It looks exactly the same. She had a previous facelift, by the way. Look at the difference as she moves down her neck and as she keeps moving down her neck. That's a big difference for these people. Okay? It is. It's so rejuvenating when you address that. And when you have that separation all the way back here, which allows you to avoid all of these problems. Look at that redraping with all those wrinkles, and now you have a single crease and nice and deep all the way back to the jawline. Vascular anatomy of the submandibular gland, we'll talk about it during our presentation. Basically, there are 1 millimeter vessels that come off of the submental artery, and the 2 main ones come off of the facial artery. When you're removing so posteriorly, you're going to be very careful with the most posterior pedicle, which comes right off directly of the facial artery. Here you can see both of those pedicles right there, and smaller ones that come of the submental artery. And again, those are 1 millimeter vessels. They've been studied in anatomy publications that they're very small vessels, although of course they bleed a lot because they're coming directly off of the facial artery, coming directly off of the external carotid, okay? So again, indications for this surgery, definitely thick, heavy, full necks. You need to address these patients. You can see the gland right there. You can see it, without even having to palpate or anything, and how you get that definition all around that jawline and the neck with the canal view as well, flexing your neck. Again, addressing that lateral submandibular cervical angle. Patients that are heavy and full necks like this, you need to address all of these structures. in order to get some results in these very heavy, difficult necks. Male patients, I published this also, my technique for male patients. And again, some heavy full necks you can do a lot of times with just an anterior only approach without having to do any lateral approach in some of these individuals. And again, in males, you can get away with it better because with the hair follicles, the skin redrapes better. It's thicker skin. And sometimes, you can get away with even older patients with just an anterior approach, like in these individuals. Oftentimes, I will go also laterally in order to get even more definition by addressing those angles and getting that nice Adam's apples in males, which is very important, and that shadow all the way back. And you can see that posterior oblique view, how I address that angle, and that's how I achieve the shadow there. Again, all of these individuals in their mid-50s, males, they really are in shape. They work a lot. They look great, but the neck is often their biggest problem. So you need to give them a nice Adam's apple that improves their attractiveness and nice shadow all the way around their jawline. Younger patients are also a good group because oftentimes they just have morphological issues with their deeper structures. So you just do a little incision submentally and you can get that nice shadow all the way down to the edge of the posterior mandible. Even in 25-year-olds, 22-year-old, just do a little incision there and you can solve their issues without any chin implants that they proposed. Surgeons will propose them to put them a chin implant. And definitely even individuals in their mid-30s, you can get much improvement of that lateral submandibular vertical angle and good canal views by doing deep neck work with them. And again, patient in the 30s, you can get a good jawline definition. And even this patient, look at her. She is really a right angle. So she would be a V-neck by Mario Pelli's concept. But it's not only about V-neck. Look at that shadow. Look at that youthfulness just by addressing that volume that she had here, which is the deeper structure, right? So again, this is my youngest patient, a teenager that came also for a chin implant. And again, going the other way, you cannot imagine how much definition and exposure of that mandible and jawline you can get. And finally, thin deflated necks, you might think, okay, these necks just need a little pulling from lateral, but I think you need to also address the deeper structures in order for that skin to redrape better with these patients that you might think it's only, superficial redraping. It's not. These patients have volume, and when you address that volume here, you can get a better result. This is 2 years post-op, and the neck is very long. This is 7 years post-op. Once you get the neck right, you're pretty sure you're not going to have to go back in there. Again, 75-year-old, 7 years post-op, 7 years post-op. And again, these patients that you might think it's only skin and nothing more, you definitely want to try to also address that deeper structure to get a good redraping of the skin, like in this individuals that, again, they don't have much issue. You might think just pull on that and it'll bring everything back, but if you reduce it, you get all that definition of the jawline all the way back there. And again, with that nice shadow going all the full length of the mandible in patients that are very thin, but good redraping of the skin afterwards. So I'm going to include more of my superficial work, bear with me, because Dr. Nayak asked me to, he's going to give his part on the demonstration. So I'm just going to talk a little bit about my superficial work, which I think is very important. Okay, I call it a dual plane neck lift with skin muscle redraping. I published this in 2022. Okay, it was in an issue of Clinicing Plastic Surgery dealing with men. But Tim Martin wrote the chapter on the face, which was actually very good. And they asked me to do the one on the neck. And again, most of these concepts also apply, of course, for females. Basically, this is what I do. I'm going to go quickly through some of these maneuvers, and we'll probably have more time in the demonstration to showcase them. Definitely, the first maneuver to get your superficial work right is to reduce the deep volume. And you might say, why? Because it affects the result on the superficial work if you reduce the deep work. If you do a very nice superficial work, but you leave the deep structures, when you flex the neck 100 times a day or more, you're going to make that fail. it's not going to work. So one of the key points of getting your superficial work right is to definitely address all of the problems with the deeper work. The second part that I want to maybe talk a little more about is my 3D Z-plasty platysmoplasty concept. Okay, so basically the anatomy of the platysma is quite interesting and complex if you think about it geometrically, because you have a right angle that you're trying to achieve, at least interiorly, and the structure of the platysma is really like a drape. It's like a cloth. And when you try to make that geometry match, it doesn't. It doesn't match. So if you do that experiment at home and you put a book vertically on a table and you put a little cloth on it and you try to push that cloth, like if it were the platysma, against that angle, what's going to happen? It's going to bowstring. It's going to bowstring. That's the way geometry works, right? So it will not work very well just by pushing or plicating the platysma. So what I do is an opposing vector platysmoplasty, 3D Z-plasty. Because if you think about it, when you have a band, the best way to avoid it from coming back is to break the band. What's called traditionally in reconstructive surgery a Z-plasty. And what it basically means, that concept, is separation the edges of that band as far away geometrically as possible. And that is a Z-plasty, okay? And that's how you separate and make a band not come back, right? So what I do is I transect the platysma, full length, full thickness. I bring the cranial portion medially, and I bring the caudal portion laterally. And I bring it laterally with all of the skin attached to it so that it all comes laterally and pushes on it, okay? And that way I get a Z-plasty in the three vectors of space, the Y, the X, and the Z, okay? And again, this is the idea. By separating that band, you will avoid or minimize the effect of recurrent platysma bands, which, as you all know, and it has also been very well showcased by Mario Pelliceravolo, it is a big issue in neck lift surgery, recurrent platysma bands. Next thing I do is what I call a triple vector cranial platysma plication. So that platysma I will bring very strongly with a double vector anteriorly. One is horizontal, very strongly. I will fix that to my pre-hired area, and then I will do another vector purely vertical or anteriorly. And what happens with that is that I will very well flatten the platysma, and I get, of course, an excess. I get a dog ear anteriorly, and I just correct that dog ear by a little, inverted T on that edge of the platysma. And then I use my third vector, which is oblique from the lateral approach. Okay, and that will really give me a very nice and tight platysma cranially in order to correct platysma bands. And these are some examples of very complex platysma bands to correct with very thick muscles that I was able to address with this 3D Z-plasty concept in order to avoid any recurrence of any band at all, because it's completely broken. It can't sort of come back and reattach that anterior band. There's no way it can come back when you do that. The next thing I do, I call the caudal cervical thick composite subfascial flap. So basically I published this again. This is from my publication in 2022. I presented it first in 2019 in the American Aesthetic Society meeting in New Orleans. And this is a concept of non-delaminating the skin from the platysma and leaving it attached, as proposed initially by Tort Skoog in the 70s. The idea was left behind, and Raul Gonzalez brought it back in 2009, and then Mario Pelliceravolo also expanded on that idea with his lateral skin platysma displacement. So I published it, and my contribution was that they were all doing that to avoid a submental incision, and I described this and published this in 2022 to leave all of those attachments and go deep with a thick flap of the neck, while at the same time getting the advantage of that medial strong plication from that subplatysmal approach. And of course, addressing better the deeper structures from the submental approach. And again, all of that area in blue is not detached, and all of that skin is preserved, but also leaving also the deep cervical fascia attached. This is from a publication we're going to come out with Brian Mendelssohn's book, where I'm leaving all of that attached, but also going in a subfascial fascial dissection to get an even thicker flap. So again, this is basically an illustration of how the flap is. I have the cranial segment will be in a biplanar dissection, superficial and deep, and everything caudal, what I call the submandibular cervical line, is deep to the deep cervical fascia. And again, in this way, you can get very good results in patients like these with very thin necks, very complex, to get natural results. And you can improve their recovery times. And again, get much more natural results in these very thin necks, 2.5 years post-op. These are long-lasting results, 3 years post-op with this, non-delamination techniques. And again, patients with very thin skin, because we do have very thin skin lower on the neck, although they might look like obtuse, heavy necks. Look at that skin over here that you might think, okay, so it's not that, it's a full heavy neck. It's not that really that problem. But most of the patients have very, very thin skin here, even if they have, larger necks. And again, patient like this, that you might think, okay, it's just a heavy neck. Look at the thickness of that skin here. It's very thin, and you need to do a deep, composite flap in that dual plane approach to address those patients. And again, you might say again, Francisco, this is not such an outstanding result. It looks pretty normal. Look what happens when they flex the neck. Just a little flexion. So we need to think of neck flexion because there's a dynamic anatomy of the neck. And of course, this looks good, but look at the difference when they flex the neck. And this is the way to understand what we're doing in the neck, if it's working or not. Another patient with very thin tissues, but again, by using those thick flaps, you can redrape much better. Patients like these that you might think, I'm going to remove a lot of skin in this patient. Oftentimes, this patient like this with a very nice angle and with good, demarcation of the Adam's apple, when you look at them, I did not remove any skin. This patient is bald, and I cannot place any scar around here because it'll be visible. So I just stopped there, and I was able to just by working my deeper structures of the neck, getting that result. And of course, there's no good face or neck lift if you can see a scar. You should understand that very carefully. All their friends and people will look at them so carefully and just try to examine them up close. Friends are, I was going to say bad people. No, but some good friends can be, very bad for gossiping. Oh, she had some work done. And you need to understand that you need to help these patients that no one notices that they had any surgery at all, okay? And again, with dose definition laterally. And finally, this is the last step of my work on the superficial layers, is what I called a caudal platysma weakening, because I'm trying to injure the second branch or the caudal branch of the cervical branch of the facial nerve, which innervates the caudal platysma. I want the cranial platysma to be innervated because that's important to have tone so that those deeper structures do not bulge whatever I leave as stumps. And also because that platysma cranially is a depressor of the lip. But you need to address the dynamic wrinkles of the neck horizontally to injure that. That nerve is not easy to injure because it runs on the deep cervical fascia. In fact, this paper by Zeno and Thorne showed that most techniques on the neck that just go underneath the platysma will not injure the cervical branch of the facial nerve. So you need to go underneath the deep cervical fascia. And I'm showing here, when you go underneath that fascia where that nerve runs, you're going to get that effect on the caudal platysma. And when you transect that, and I published this with the Australian group in Brian Mendelsohn and Minelli on this impact on surgical rejuvenation of the neck by partially denervating it, you can get a weakening. You cannot completely call it denervation because we all know the platysma very easily reinnervates by just branches even from the cervical plexus. But you can definitely show that the platysma is weakening, and just by weakening that caudal platysma, you can get these sort of results in patients like these with no skin treatment on the neck. And look at those, wrinkles, horizontal wrinkles, which are, dynamic wrinkles. It's like a flat muscle. The platysma is a flat muscle with very thin skin attached to it. Where do we find another muscle like that? The frontalis, right? And you get wrinkles that are perpendicular to the fibers of the muscle. So that's why a lot of wrinkles on the neck are caused by that platysma tone, and that's why facial palsy patients do not have wrinkles on their paralyzed neck, right? So again, by doing that, this patient also had a lip lift we showed yesterday. And again, a lip lift with difference. Look at that. You only see the lower incisors, and after the lip lift, you see the upper incisors, okay? And a corner lip lift as well. And then Again, showcasing that effect on the skin without any skin treatment, and the result on the jawline, on the neck, with that deep composite cervical flap, and that result with canal view. Again, another patient noticed the improvement on those wrinkles on the neck, on the wrinkles on the neck, without any treatment of the skin, and again with the canal view, with a good Adam's apple and good definition of the neck. This is a patient 2 years post-op with no skin treatment, 2 years post-op, and this is a patient 7 years post-op without any difference. So again, just to finish off, I think that this was a great review by James Stuzen on the paper from Derek and Tell, that due to the success of a lot of the treatments that we're providing our patients with in terms of non-surgical, most of the patients coming to a plastic surgeon, they are doing so to improve their neck, because that's the area that just doesn't work with non-surgical, right? So I think we need to understand that we need to provide these patient results. And even though this was published in that paper from Stuzen was in 2016, very recent. Again, I was saying how history kind of repeats itself, because all the way back with Jose Guerrero Santos, who is one of the pioneers of our specialty, he already said that any surgeon trying to improve the results of their patients should have an optimum result around the neck. In order to do any kind of facelift, okay? So again, this was the landmark by Joel Feldman, his book Neck Lift, and I was fortunate to spend some time in Boston with Joel Feldman, and I was always coming, because he was doing deep plane all the way back in the early 2000s, and probably even before, but I was always expecting for him to publish the second volume called Facelift, because his volume was Neck Lift, and he never did so. And I think he never did so because I think that in facial rejuvenation surgery, not surgical, in surgery, I think the face is overrated, except the skin. And I was talking with Tiago yesterday night in the dinner that the skin is very important. We need to address the skin. I do recommend cotton oil peels. I'm a good friend of Richard Benjamin and do his formulations. But definitely the skin is very important for our patients as well. But surgically, what you need to think about is really the neck. And I do think that the neck lift is the new facelift. Thank you so much for your attention. Thank you.
So what I'm going to do is I'm going to give you my pieces of kind of the steps of my anterior neck lift. I'm just going to give them to you now, so that when you go downstairs, Dr. Bravo will do his live pro section, and you'll get immediately into the lab that way. So we'll try to optimize your lab time. Okay. So these are my steps of my anterior neck lift. So I'm going to show them to you just bit by bit. It'll take like 10 minutes. Dominic will give his complications talk, which may be the single most important talk in this meeting, and then we'll go have lunch. Francisco will do his open live dissection of the neck, and then you'll get a big block of dissection time. So that's the goal, okay? So this is how I do 100% of my anterior necks now. First thing is I open the platysma vertically. So I'm not taking a pair of scissors and a pickups and taking the anterior edge off the platysma. The reason for this is it takes more platysma to invest the neck than you think it does. So when you do all the deep neck sculpture, it creates a lot of surface area that needs to be invested. So if you start the neck by opening the platysma with a pickup and a pair of scissors and take a ½ centimeter or a centimeter of each platysma on block, later, when you've done all the sculpture and you need to bring the neck back together, you can have inadequate left-right platysmal length, and you're setting yourself up for a failure later. So always just start by vertically opening the platysma. So always just start by vertically opening the platysma, and then just undermine the platysma. And not every platysma anatomy comes together and decussates in the middle, but there is always a fascial plane, even in the middle, in a widely separated platysma that you can follow. So open that fascial plane, undermine it on both sides. All right, so this is what it looks like. We put the hook in and undermine. I use the cautery. I'm usually at about 35. There are cervical branches here, but I've actually never created a lower lip weakness from an isolated neck lift. All my lower lip weaknesses are from the lateral approach. So first, undermine. And when I first started doing facelifting, I was doing it wrong. I would take a big chunk out of the platysma in the middle as my first step, right? So first, undermine. I love this long, it's a malleable retractor. It's an inch wide, and I like this inch wide malleable because it holds the incision open anterior, posterior. And then I have it bent so it's about 10 centimeters worth of length going into the wound. So 2.5 centimeters wide, bent so it's about 10 centimeters long, and that way the end of that can get all the way down into the posterior pole of the submandibular gland capsule when it's time, and the width of it holds the incision open. It's such a valuable thing, and I learned that from Tim Martin. And when people come to my office, they're always like, oh, what's that instrument? It looks like a fancy special instrument. It's just a malleable, but wide and long, right? Once we have that undermined, then I will do the deep fat on one side. And the floor of that dissection is the anterior belly of the digastric. The base of that dissection is the hyoid. And then the lateral extent is overlapping where the digastric tendon will be and where the anterior pole of the submandibular gland will be. And this anatomy is always consistent. If you follow the anterior pole, follow the anterior belly digastric, where it turns at the digastric tendon, that's where you'll find the anterior pole of the submandibular gland. So if you're in the lab and you can't find it, that should be your road, that should be your map. Digastric at the tendon is where you find the anterior pole of the gland. So we sculpt the deep fat. If you are sculpting deep fat, you must be comfortable taking the gland, because what will happen is if you sculpt the deep fat and expose the gland's contour, it makes the problem worse. And you get a hole here and gland fullness. So be very conservative in sculpting the deep fat unless you're ready to debulk the gland as a next step. So here's sculpting the deep fat. The ideal, for me, the ideal contour here is that nothing is sitting below the axial plane. Tim talks about body mandible to ipsilateral digastric, or he says ipsilateral digastric, or hyoid. Honestly, to me, if you think of an axial cut right at the mandible, everything inferior to that axial plane is what goes, right? So it's the overhanging portions of the submandibular gland, it's the overhanging portions of the digastric. Francisco said it very well, there's no space to put this, so I have prominent submandibular glands. If I take them and I hide them entirely inside the body of my mandible, there's no room for me to talk anymore. These are incompressible structures, there's just not enough volume there. There's no way my platysma is going to hold those glands up. And the idea is you don't want anything escaping the confines of the mandible. So I tell my patients it's like having a scoop a cup of flour out of the bag, and they go, how much gland do you remove? You level off the cup. I don't want to see anything bulging out of the cup. It's just upside down in this analogy, right? So gland, it's whatever is hanging below the level of the body of the mandible. And to me, a really good tip is when I'm doing the gland, if I'm constantly trying to push that digastric out of the way and I'm looking over the belly of the digastric, I'm having a hard time seeing the gland, that tells me that a gastric needs to go too, that the digastric is too full, right? So again, your landmark is digastric. Where the tendon turns, that's where you're going to find the anterior pole. And the safest place to enter that capsule, because the entire gland debulking is done intracapsular, is on the anterior surface, is where you enter it, and then you can unzip the capsule all the way along its inferior border. In the lab today, if you don't see your gland, I will promise you, you've taken your retractor and put it under the gland, right? So if you don't see your gland today, it's because you followed the digastric so well, you elevated the gland with the platysma, and it's under your retractor. So keep that in mind, both in the lab today and in real life. All right, so again, we open the capsule, we open it here, unzip it inferiorly. The marginal branch is on the lateral surface, extracapsular. So if you open the capsule broadly here, starting at the anterior pole, inferiorly, this is very safe. And before you start actually debulking the gland, you want to expand the ephemeral tissue, the potential space inside the capsule, and really get it free. You can debulk it with a Bovie. This is an injected specimen, and it just shows you how vascular these glands are. So I prefer the ligature, as many of you know. I don't have any disclosure. But I really like it because once we get the gland fully exposed, you can clamp around it. It's an impedance-controlled bipolar. It seals the tissues. It doesn't overcoagulate the tissues. And then when you take them, there's no char left on the gland. So this is kind of what it looks like. This is the right gland opening the capsule at its anterior pole. And ideally, the fewer times you touch and release the gland, the better, because each time you touch and release it, the parenchyma can bleed a little bit. So, Q-tips are great. You have them on your kit in the lab downstairs, or the lab or across the hall. I get the cautery, get the plane started. Anywhere I feel like I can do some blunt dissection, I'll take either the suction tip or the Q-tip and bluntly dissect. And the idea is you really don't start removing pieces of the gland until you have panoramic exposure of it, until it's free, so you can control anything that needs to be controlled. Again, there's that 1-inch malleable, bent to about 10 centimeters, so it's all the way, you can reach that posterior pole of the gland. This is a Viterbo. You can use your Trepsat. Really, once you're in the capsule, blunt dissection is your friend. Do as much as you possibly can through blunt dissection. So suction, Viterbo, Q-tips, whatever works. Then you get to a little sticky spot. We touch it with a cautery and then start brushing again. I'm going to go to the ligature on the other side because I have a better view. So here's the other side. You can use the bipolar, you can use the monopolar, you can use the ligature. Again, I love the ligature because the chance of rebleed is really low. It seals the vessels but doesn't overcoagulate them. And then once it's sealed, you pull your little trigger and it cuts along the seal. There are other devices too, Sonicision. I think they're fairly substantially equivalent. And then if you look at the actual tissue, it's not black and necrotic. And it's the same thing on the live side. It's sealed, but it's not ready to fall off in a few days. All right. Platysmal toolbox. These are all the different things I've done to the platysma. This is the one I still do. So once we have the foundation set, then we want to address the platysma. And I don't have this on the video, on the slides here, but you have the two platysmal edges ready for you, right? You want to measure the excess platysma. Okay, so if you don't measure the excess platysma appropriately, when you close it and lift the lateral face, you'll still have submental looseness. Okay, so what you do is after you've done all the deep sculpture, now you actually know how much platysma you need left, right. You take one platysma, bring it across midline, and just paint the line right down midline and trim the excess platysma on one side. Then you take the other platysma, bring it across midline, and paint the excess right down. You use scissors or a bovie or whatever you want, because then in the end you have the correct amount of platysma on each side, and that automatically takes into account when you have one platysmal band that's longer than the other, or one side of the neck that's looser than the other. Once you've set the foundation, you know exactly how much you need to invest your foundation. Then you bring it across midline, trim the excess, and you'll automatically get the right amount from each side. Okay. And then this is all I do to the platysma anymore. 3 X sutures or 3 mattress sutures. There's the hyoid level. So it usually only takes 2 or 3 to get to the hyoid. Beyond the hyoid, I put a couple simples in and then do a back cut. Okay. The reason we do it here is when you do your facelift, the platysma advances pretty significantly in a vertical direction. I showed you all those skin changes, how the skin moved up and everything else with it. So you want your back cut at least a centimeter below the hyoid, so that when you do your facelift, the hyoid is not exposed. You don't do your back cut here and then have diverging platysma and open fascia over the hyoid. You have a little bit of closed platysma over the hyoid to keep that softness and that modesty to the hyoid, and that's it. Literally, that's all I'm doing anymore to my platysma. You don't want to close vertically down here, because when you close vertically down here, it limits your facelift. This submental part, if you've only measured out the excess and closed it, it does not limit your facelift. And literally that's it. So that's what I want you guys doing in the cadaver today. At least one consideration. Open the platysma, elevate, fat sculpture, gland sculpture, plus or minus digastric. Digastric sculpture is just planing it off. It's real straightforward. Measure your excess platysma, close. That's my 99% neck lifts. Whether it's an isolated neck lift or with a facelift, I'm doing the same thing. The isolated neck lift is the same foundation as a facelift. The only difference is with an isolated neck lift, I undermine much more broadly because we've got to accommodate all that skin. You're not having any lateral translocation to take up on that skin. All right, so that was my lab piece, so you have more time to dissect free in the lab.
Okay, so thank you very much again to big thanks to QMP and Mike Nyack for this event and organizing this. It's been a great day and a half already, and we have the whole evening. So there's two ways of doing this demonstrations for cadavers. There's a closed approach, meaning you do it exactly the same as you would do it in surgery, and just do an incision, submental incision, and do all your dissection as if you were really performing, surgery. And then the other way is to just lift the skin and be able to better understand the anatomy and what's going on. So I'm going to try and do a mix of this today. First things, I might get a little fluid as well. Your cadavers are well hydrated already, but when you're doing deep neck, I would also suggest putting some right on the base of the tongue to get those deeper structures also nice and hydrated. And I know that the specimens have also been hydrated already for you. Then I will start with my markings. So the first thing I mark is what I call the SC junction line, the submandibular cervical junction line. That is where the submandibular segment of the neck meets the cervical segment of the neck. Anatomically and anteriorly, it coincides with the hyoid. Of course, right? That's where all of the muscles meet from the submandibular region to the cervical segment. So the way to draw that line for me is to have the patient flex a little bit their neck to see how that volume sort of protrudes. And then with two fingers, I will tighten that neck laterally. And where that sort of crease forms, that's the anterior part of my submandibular cervical junction line. And once I have that, I will just follow with a horizontal line on both sides, okay? So that is a very important landmark for me. And normally when the patient, of course, when you're not doing this maneuver, that line is quite low, especially in patients that have a full neck or that have a lot of laxity. So the way of doing that maneuver is just pressing on them, having them flex a little bit. You find that central point and then you go laterally, okay? The next one marking I'm going to do is my incision. So you have different options for your incision. So first, you have to understand where your submental crease is, okay? And once you have that, you have different options. One option is to go very low, okay, at the level of that, almost of that SC junction line. So make an incision down here. That incision gives you a very good access to the deep neck work because the gland is going to be right here. And you can make it longer to have even easier access. The downside, of course, is that it's much more visible. The other way is to use incisions very close to that crease. I would never put the incision in the crease because then you just will accentuate it more. Ideally, I put it like 2-3 millimeters below the crease. There's different options. I've done several approaches here. You can go above the crease, which also works very well, and I've done a lot of cases that way. This this skin is a bit thicker. It heals very nicely, and the scar is quite not visible. That approach is really liked by some surgeons. For example, Chachikeo, he likes to go anterior to the submental crease with a very. The problem with that is that you have to make a very small incision because, of course, when you pull on the face, that scar can go into your face. So again, that's the downside of having such a small incision. And of course, it's much more complex because you're farther away from the glands. Normally, 2-3 millimeters. It's what I like to do. Some other surgeons, like Timothy Martin, will like to go a centimeter and a half down here. I normally don't like to go midway here because oftentimes it's really hard to get a nice flat surface in the submental region when you go a little bit farther back. When they flex the neck, you get a little kind of indentation there, which is quite hard. So once we have that, what we'll do is we're going to make our incision, and we'll go directly, again, just 2-3 millimeters below that. The first thing we're going to do is also, with a double skin hook, we will release also the submental crease. And I might talk a little bit about that afterwards also. When you release a crease like this, like the submental crease, if you don't do something and put something in between, it's going to get stuck again. So normally at the end, we'll try and show that I put a free graft there so that there's no submental crease again. So you think you release something and then, oh, I release this crease, this ligament. The skin is so thin there that it doesn't matter if you released it. You're going to put it back, it's going to get stuck again, and it's going to form the crease again. Once I'm here, I'm going to go and get a nice and thick flap here. Notice that you're going to see in your specimen, there's a difference in the submental fat, superficial subcutaneous fat here. You see there's a little plane you're going to see here. That's the deep and superficial submental fat, okay? You're going to notice when you do this in your specimen and just pull down, nibble down a little bit, you're going to see that difference in fat. This is the superficial subcutaneous fat, and that's the deep subcutaneous fat. And it's quite I mean, you can learn to see that plane. Initially, it's not that easy to see, but you will be able to identify it very easily, either with cautery or with scissors. But notice how thick I leave this flap. This is very important. Subcutaneous fat is very, very important because it's sort of like a thin skin nose and a thick skin nose. If you have a thin skin nose, everything is going to be visible afterwards, and you're going to have a hard time disguising things. So you need a good thickness here in your subcutaneous dissection. So again, I identified that little plane of dissection between the superficial and deep subcutaneous fat, and I will go all the way down to my SC junction line. That SC junction line is a very important landmark because it separates my superficial dissection from my deep dissection, right? So again, notice that separation between that superficial subcutaneous fat and that deep subcutaneous fat. Okay, so I will go all the way down. Normally I do this with electrocautery monopolar and go all the way, and combination with scissors like this. So once I'm all the way down here, okay, all right, then I will go a little bit laterally. Can I have that? Exactly, thank you so much. And then the fat, the platysma here, you're going to identify it better a little bit laterally, of course, because centrally there's no platysma, right? So you see, right, I see the platysma fibers right there. You got to be very careful here because some of these patients, the platysma is very, flimsy, thin. You might think you're over the platysma, and inadvertently you might elevate the platysma, especially if you're going with cautery. But when you go laterally here, that's the perfect way to identify where the platysma is, right there, okay? Once I have that, then I will grab a skin hook, thank you, and my assistant, I got great help with all the NAIAC people. Big round of applause for that. Yeah, thanks so much, all this NAIAC staff. Thank you. And I will detach the mandibular osteocutaneous ligament here. this is the thinnest area of the skin aside from the eyelids, okay? You got to go very superficial here. You know that the marginal mandibular branch comes very close to that mandibular osteocutaneous ligament, so you want to make sure you're superficial. Once I got that there, you might see a submental artery bleeding there, so just use your loupes, identify it, cauterize it. Don't burn all the time there because you're going to injure the marginal mandibular branch there. So just pack it if it's bleeding, and then come back later when it stops a little bit. Once I have that a little bit done, I will take that out and I will just go directly with a forward nibble, getting that lateral neck dissected. So this is a very fast maneuver to get all of that undermined laterally. And then I normally will take a look and all of that is dissected out, okay? And then when we look here, again with that retractor, when we look here, we got a nice and thick subcutaneous flap. Again, this is crucial for having a natural result in your submandibular segment. And then we have the deep subcutaneous fat, which as you can see, is mainly anteriorly. And what I will do is I would remove this initially. I'm going to now I'm going to show you everything here so that it's more visible. But of course I would do this without having this incision. So I'm going to go right ahead. I'm going to open over here. I might, I'm going to open just a little bit on this side and then go all the way around. And we already dissected this from the submental incision, but I just want to get it out of our way so you can see what I do on the deep neck. All right. Thank you. Yeah, that's great. Great counter traction. Perfect. Okay. So once I have that, what I would do, yep, we can go back to center. Now we see everything. So you can see how little fat there is. Even in like we chose like one of the fullest necks that there are here. Look how little fat there is really in a big, heavy neck like this, right? So you have to leave a nice subcutaneous padding here, generous. But look, I mean, there's plenty of studies, Cadaver studies and anatomic studies showing how little fat there is, or it's a great paper by, for example, the Cleveland team with James Zins. It's called the Clinically Relevant Fat Compartments of the Neck. I recommend that paper. But you can see there's very little fat. So I would do this with cautery. I would start removing all around this with cautery, just seeing a nice fresh platysma, because I know that I have a lot of fat on my flap. Another way of doing it, some surgeons like to leave all of this flap with a dissection and then just with scissors remove the excess from the flap. But I'd rather, I always start off, having my nice thickness of my flap and then just removing what's underneath and what I left behind. So again, this is all deep subcutaneous fat in order to free and see nice the edges of the platysma. Good, no? Okay, good. So we're going to keep that fat around. Thank you. So again, we see the edge of the platysma, and this is the subplatysmal fat. So the next thing I do is open the platysma. An important thing to do here is to leave a little bit of the subplatysmal fat attached to the undersurface of my platysma. Why? Because the platysma muscle is a very thin muscle. If you can make it thicker artificially by leaving some of that fat with my flap, it's going to have less a risk of cheese wiring when we put our sutures, okay? So again, now we're seeing the anterior belly of the digastric muscle right here, okay? And we're just going to continue. You might encounter some veins. I would always coagulate those veins with monopolar and go right through. So once I'm over here, again, leaving a little bit of that subplatysmal fat on the undersurface of my flap, I will get normally a vertebral retractor or a Trebsat. Oh, we have one? Wonderful. Wonderful. And then, venga, perfect. And then I will go underneath here. Great. And the way to find the gland is search for the way to see the gland is to go to the tendon of the digastric. So I'm on the digastric here, anterior belly. If you follow that muscle towards the tendon, here's the gland right there, right? So there's the submandibular gland, and you can see how low it goes. You see how far down, much more down. People think submandibular gland, oh, it's below the mandible. They will go this way, and that's an error. You got to go down, caudal and lateral, towards the tendon. It's always on top of the tendon of the digastrics. So once I have that, I will get the retractor. Very nice. Okay, and then once I have that, scissors. Thank you. I will go around the gland. All around the gland, free it very well. Be careful not to leave a segment of the gland attached, because sometimes it gets stuck to the capsule. And again, the capsule really is the thickening, is the deep cervical fascia that invests the gland. So regarding safety, of course, that marginal mandibular and the first branch of the cervical branch of the facial nerve run on that deep cervical fascia over the submandibular gland. So that's why there's a permanent risk of permanent injury to the depressors of the lip. For example, in tumor resections of the gland, because normally you would go directly through the platysma, through the deep cervical fascia to expose the gland in a tumor case. And of course, the literature shows quite a number of permanent injuries. But if you're going from this approach, you're approaching the gland from the posterior sheet of the cervical deep fascia. So there's no risk of injuring that nerve because we have the nerve above us, right? So again, no risk of injuring the nerve. So once you have that and you bring it all around, normally there's a lymph node here, I also like to remove, anterior to the gland. And again, you will remove that. Once you have it all nice and freed, I'm going to run a little bit more here. You start and everything is nice and free. Look how large this gland is. All the way down here. Once I have that, I would be tempted to start removing it, but remember, I'm doing all of this from a little small incision here, so I need more space, especially patients that have large glands. So what I'm going to do, skin hook, is I'm going to do my deep dissection, thank you, of the cervical segment of the neck. So I will start anteriorly and try to go deep, and I will try and reach the strap muscles, the thyrohyoid and omohyoid muscle. And once I'm there, you can see right there, I see the fibers of those muscles, the tarsal muscles, and that's why I know I'm subfascial. If I see fresh fibers, I know I'm below the deep cervical fascia. And then I go with a Trepsat, thank you, and I can go underneath here and dissect deep, nice and deep all around. Okay, so again, this is a deep plane below the deep cervical fascia of the neck. And a knife, and I will go all around here, scissors, and I will free and have a nice exposure. And this is a very thick, deep flap, you see? Very thick, deep flap, subfascial, leaving all nice and thick cervical segment of the neck because this skin is very thin. You want a lot of thickness there. Okay, so once I have all of that, now I have a nice exposure here. I have so much space that I can remove the gland very safely and see everything very well. Okay, so now I'm going to go ahead and remove the gland. I'm going to get, sorry about that. I'm going to try and get in here. Yeah, can you grab that? So I'm going to just go ahead and the gland I will start with monopolar. Normally go slowly here and you're going to see a little cleft opening on the gland. You see that it opens up like a little book. That's where the main pedicle goes, okay, right there. So I will just, again, these are 1 millimeter vessels. You just have to use loops. I use 2.5 loops to just see them nice and well. And once you're just more or less through there, you can go back here. This is all with cautery. And then once you see that
main pedicle there, some people, you can use a little clip and just clip it with a vascular clip. Timothy Martin likes to put a tie on that. I just grab it with the monopolar or just a forceps and just use bipolar or monopolar. Once you pass that, most surgeons just remove this part and just remove that enterocaudal segment. I like to go a little bit further. The only issue is that when you go further, there's again that normally there's you see that little pedicle too. So we would remove that one too, okay? And then you just have to be careful back here because there's some second pedicle coming from behind. That's often the most dangerous because you're already wanting to finish, but it's coming right behind here. You see that? Right here, that little pedicle there, and that's coming off of the facial artery directly. So you got to be very careful if you're going to remove more volume of gland back here, okay? And then we remove that, and that's off, okay? So once we have that, you're going to see that there's excess digastric here, okay? Because I'm going to do this maneuver of pressing on the mouth just to imitate a flexion, and you see that it bulges down here. Where it bulges is more posterior and lateral, not anterior here. So what I'll do here now is remove the subplatysmal fat, right? And again, we're going to be careful on not removing too much, not removing interdigastric fat. And even look at this patient that had, a very heavy full neck also didn't have too much subplatysmal fat. This is from this side, okay? And then we're going to just remove, by doing this maneuver, that caudal part of the digastric, the anterior belly of the digastric, okay? One more like that. This is just the fat there, and the anterior belly of the digastric, removing it there. Okay, and I often remove a little bit of the tendon. Okay, so once we have that, the next step we're going to do is we're going to do our transection of the platysma. Again, full thickness for length. We're going to start off, like that. You can remove since we can see it. Just going to go like that, and then I'm going to go ahead and I would do it with cautery, and just transecting all of this, but also transecting this, which is the deep cervical fascia, okay? All right. And some fat that there's underneath. You got to be careful sometimes with veins. Of course, all the superficial veins, the anterior jugular, external jugular, and communicating external anterior will be running on that deep cervical fascia. So if you see a vein, normally if it's an anterior vein or communicating branch, I will just buzz it. Of course, I always keep the external jugular. So once I have that, I'm going to do I normally transect 2/3 of the platysma. I'm going to show you the lateral. I think we have time to do the lateral as well. And so I'm going to transect that. Okay. Once I have that, I'm going to start with my fixation. So thank you. So the first thing I'm going to do is going to assess how much excess platysma I have horizontally. Knife. And I will remove it. So when I pull hard here, you can do a vest over pants, but I like to always remove excess here. This patient doesn't have too much excess, but some patients have a lot of horizontal excess. Of course, you don't want to remove too much because you don't want to have a cobra neck deformity, having too little volume centrally, but I will remove a lot. So once I have that, now this is a key part. So I'm going to have, this is my hyoid here, okay, and I'm going to fix my platysma to the hyoid, okay? So every maneuver I'm trying to do here is to avoid cheese wiring, which is the big enemy for every one of us with all what we do. So I do 3 ovicerals on a non-cutting blunt needle. I use the thickness of the platysma with the fat to give it more sturdiness, and I fix the platysma independently from each other, just directly to my prehyoid fascia, okay? And I grab that, so my assistant will hold under tension the forceps, thank you. No, not the bone. Just the fascia. That's a good question. That's a good question because some patients that have come to visit me, they told me that they had problems going through the bone, and I said, no, it's not through the bone, but just to that deep cervical fascia, and I will again tie this. So that gives me reassurance that I'm not suturing a flimsy muscle to a flimsy muscle, and then of course it fails, right? So I normally put 3 sutures here, 1, 2, and 3, and again my assistant always holds that there, and I can have it there, making sure it's a very strong horizontal vector here. I think that Dominique said it very well in his talk. I did for a while use a lot of braided permanent Etaban, and once you have just one patient that is a nightmare that it's extruded, then you're not going to do it again. Again, I just use this vicryl here. Now, when I have that, I'm going to start plicating this with the other platysma. I don't want to open this side because it's going to be used as specimen for a facelift demonstration. So we're going to leave that there. But imagine I have the other edge of the platysma here, okay? And I'm suturing. So then I will start suturing from bottom to top, right, to the edge, just individual stitches to the bottom to top, okay? And I'm pulling, when I'm suturing my medial plication, I'm pulling with a vertical vector anterior, you see? I'm pulling anteriorly, okay? And at the end, when you're pulling anteriorly so much, like this, again, I'm going one side to the other, you're going to have a nice flat submental segment anteriorly, but what you're going to have is cut. Yeah, thank you. And a scissor. What you're going to have is that you're going to have a dog ear here, you see? Because you're going to have excess muscle. So what I do is I cut this here, and then normally I can remove that, or some patients that have a big submental crease, I will put it, as we mentioned before, so that crease doesn't get stuck again and produce a submental crease again, right? So I will put it up here, and that way I can avoid that submental crease, and I can have that nice and straight, okay? Right below the crease, okay? And then, of course, I will put a little suture here on that kind of triangle here, and I'm finished with my neck. I'm not finished with everything because now I have another little maneuver that I want to share with you, which is that DCF, deep cervical fascia hyoid suspension. So the problem now is that you've got, again, patients with thin skin here, and you have, exposure here of all the muscles. This is the larynx here. So I need a nice and soft contour on the prehyoid area. So in order to achieve that, I want to have a nice and thick flap overriding the deepest area of the neck, which is the prehyoid area, in order to avoid what I like to call, skin webbing. A lot of what's called recurrent bands is not really recurrent bands. It's just thin skin. When you have a concave surface, look at your first commissure of your hand. If you have a thin surface of skin that doesn't have subcutaneous tissue, like your first commissure, and it's a deep concave area, you're going to have a web, like a duck, skin webbing, okay? So when you, same with a female with a tight shirt in her cleavage, between the two tension points of the breast, there will always have vertical, lines in the shirt. So the same thing happens with the skin. If you have thin skin on a concave area between two tension points, you will get vertical bands. So in order to avoid that, you need thickness. So this is a little bit counterintuitive because you're doing reduction, but it's deep reduction, and you want thickness superficially. So you want thickness superficially and reduction deep. So again, I have that DCF hyoid suspension will bring up all of this thick flap that I did not delaminate and put it right over the hyoid, which is the most problematic area, the most mobile area of the neck, and it's very complex. So now we're going to move. Normally I would finish my neck work like that, and then I would start my facelift and start my lateral neck approach. I'm going to do just 5 minutes and then I'll let you do your work now. Nice, thank you. So what I do here, again, thank you. Te da tiempo. No, si Mike no va a venir. Que sí, venga, perfecto. Venga. So now what I want to do is try to expose my deep neck work here. Oh, perfect. So what I will normally do, again, I would elevate my flap as you normally do for a facelift behind the ear, go back here, and then once I've done my face, this patient, for example, I would probably do a parotid reduction, so I would go up here, you can also explore the parotid. We're coming up with a study with the depth of the facial nerve here. I published, again in 2013, the first series of parotid reductions simultaneous with facelifting. And then in 2018, I did a classification of parotid reduction in the facelift setting in my paper in clinics. But basically, you can remove a portion of the parotid gland here as long as you're not going beyond the parotid gland caudally, and you stay behind the ramus. So again, everything that's underneath here, you could remove there's a parotid gland you see there. So as long as you don't go further caudal, because that's where the branches are coming off from the tail of the parotid gland, can you hold this with a skin hook, maybe? Thank you. Once you're there, you can get a good exposure. And normally here, again, this is the facial nerve we know goes very deep, so you can grab a portion of that gland here and just very safely with monopolar and blindly remove that. And that's going to improve your zone 3B, which is the vertical segment of your gonial angle, okay? And then you can remove that with cautery again, as long as you're about, it runs 2 centimeters deep here, the facial nerve. So once you do that, the important thing is to set back your flap here so that you don't get Frey syndrome, where they sweat when they're chewing, okay, which is important. Okay, so the next thing here is to go, what I normally do is I complete my dissection here superficial, which is only the submandibular segment. And then I will go into my deep axis to the neck here. So the first thing I do is I go with a scissor in the origin of the sternocleidomastoid muscle. I palpate it there. That's the origin of the muscle. And then I will go nice and deep, nice and deep, nice and deep. Here you got to be careful, of course, with the great auricular. So you're going to go here a little bit more superficial lateral here, so you don't get the nerve. And I suggest you try and find the nerve, of course, in your specimen. But once you're there, I go nice and deep here. So probably we're going to see it here. Okay, so I'm nice and deep. Probably here is where the nerve is. So the next structure you're going to be very careful here is going to be the external jugular vein, which is right there. Okay, I'm going to open up a little bit more. Like here. So this is the external jugular right there. And of course I want to always keep that, so you got to be careful when you're going in here. But once I go there, I know I'm safe. I'm seeing the fibers of the sternocleidomastoid muscle, the turbo or trepsat. And now I know that I'm on a deep plane below the deep cervical fascia. And of course you can go right over here and you're deep. You see how deep I am? I'm right over the fibers of the sternocleidomastoid muscle, and now I can separate this. And right, that's a good point, Lisandro. So now what I'm going to try and do here, once I elevate this and I'm transecting here, not only through the muscle, because again, when you go through the muscle, you're not going to have an impact on that denervation or weakening of the platysma. But once you're there, and of course you keep that external jugular vein, you keep the great auricular nerve, which is right here, okay? Then you're below here, and I want to show you the cervical retaining ligament, because, of course, and it's true, Kabil said it very well the first day yesterday, that these are not really ligaments, because they're not bone to bone, but they're definitely thickening of that deep cervical fascia that avoid your neck to move up. So I always release all around this. Look at that. You see how that's, you see how thick that is? Notice on your specimen how thick that tissue is. And that's not going to really allow you to pull under no tension your flap. So as you know, Neil was saying also about the importance of this release in order to get movement. It's not good just to cut off retaining ligaments. You need to understand why. In this case, it's because I want nice movement of my whole thick flap. This is a thick flap. And I want that to move over laterally. So once I have that, I'm going to show you 2 final maneuvers, and then you can get off with your dissection. Again, this is all deep, deep. You might have a little, again, veins here from the external to anterior jugular. I normally cauterize those. But now I have complete movement. I will go underneath all the way down practically to the clavicle. But it's a very thick, sturdy flap. All of this is preserved. All of this is preserved upwards. So now what I have here is that I'm going to, again, I have all of this nice and thick flap. I'm going to elevate this a little bit more so it shifts upwards. But I'm going to do then 2 things. Vicryl, thank you. So first thing I'm going to do is I'm going to do a cranial platysma plication. Okay, let me get this here. So what I'm going to do here, let me just close this if we didn't do the gland here, okay? Or we removed the gland, but I already closed this, okay? I do a vest over pants closure when I remove parotid, meaning I will cover over this and with a 3-0 Vicryl and then put a running 4-0 PDS. So once I have this covered, I have my platysma completely transected, full thickness, full length. I have a cranial segment and I have a caudal segment, which is attached to all my skin and flap, okay? So the cranial platysma, I will do a cranial platysma plication. So I will grab a suture here. This will be anteriorly, and I will do a what I called an interlocking stitch, which also avoids cheese wiring. It's sort of like a hemostatic stitch. So this will avoid cheese wiring, okay? And then I will place it to plicate. This will not work, and I go to the mastoid. This will not work, of course, if you did not reduce the volume there. Because it will look like it works. It's like doing an abdominoplasty in a big globulous abdomen with application of the rectus. It looks like it works, but it's going to fail. But the reason why it works is because we reduce the volume here. So can you hold that suture with your fingers? You can grab it. No, both of them. Just, yeah, like that. From below, from the knot. Yeah, there we go. There we go. And then... No, so then what I do here is once I have that, I will again put sutures. I normally, before that, I will, scissors, I remove a little bit of more of this fat laterally that there's over the platysma, okay? So you see there's a little subcutaneous fat there, superficial. I like to remove it underneath here. So this is all nice and removed. So normally I put 2 sutures there, diagonal, so that's a 3-vector, 1 horizontal, 1 vertical, and 1 oblique laterally. So this cranial platysma is very tight. I don't need to close the capsule because that's sort of like airtight here, okay? And then what I do here for my vertical segment, or zone 3B, is I do a vertical plication. So I grab the deep cervical fascia here, and I will go underneath here. And normally, most of the times, the gland is flexible. You can push it down, the parotid gland here. If it's not, I will remove the gland. But then I will go all the way down to the ear canal here, or to the cartilage there, and do a vertical segment. Okay? And that gives me the definition of that vertical retromandibular shadow and get a nice shadow here. Once I've done that, then I do a caudal platysma suspension, not plication. This was plication. Now I'm going to do suspension. I'm going to grab, I'm over, yeah. I'm going to grab the platysma. This is the final step of the whole neck, okay? I'm going to grab the platysma. I'm going to do an interlocking suture so it doesn't cheese wire. And then I'm going to bring the whole neck laterally like that. It's going to shift everything up, and I'm going to tie it to the mastoid. And normally I use 2 sutures for this, again, making sure that this suture is very important and that everything is nice and tight. You see, it brings the whole neck upwards, and I get a nice definition of my submandibular cervical angle. And then, of course, I will redrape all of this excess skin dog ear all the way back around, okay? And then once we have that, you can see that nice definition of the jawline on the full length of it, with that reduction and that dual plane management of the platysma. Thank you so much for your attention, guys. Thank you very much. Okay.
Okay, so I'm going to show you a basic deep plane flap. Guys, have we pre-hydrated all of this? Yeah, fantastic. So the way I do it is this. I always mark my patient not sitting up. I like to get them down, sedated, and then I want to feel the face. Some faces are more vertically orientated, some are more posteriorly orientated. This one's kind of in between, and that's relevant for where you're going to make your markings with entry. So first thing I'm going to do is just make an incision. You come round the temporal tuft. There are different incisions you can make. I pretty much always come anteriorly over the incisura, round, up round the lobule, up round the back of the ear. I come straight back and then down the hairline. Preauricular management really depends if there's a preauricular crease. If there's a preauricular crease, I just bring it straight over. If there's not, I make a paratragal incision, which isn't retrotragal or pretragal. Pretragal, I think you can see. Retrotragal, I think, creates almost like a thumbprint tragus that is pretty obvious they've had anything done. You then want to mark Pitanguy's line. As Mike was saying earlier, it's about 19 millimeters back from the supraorbital ridge, and I head down towards the incisura. So I'm going to mark that like that. You then come in front, and that is your classic deep plane entry, which is really just from the lateral canthus to the gonial angle. I don't know if you guys want me to show you orbicularis revectoring, but if I was doing that, I'd mark an orbicularis clock. So on the left side, that's 6 o'clock, that is 9 o'clock, 7 o'clock, 8 o'clock. This is a no-go zone, this is a no-go zone, but anything here is fine. You then want to feel the face. It's got a little bit of posterior movement, it's got a lot of vertical movement. So I'm going to bring that limb down here. That limb's going to come this way to here and around. So that's going to be my deep plane entry here and here. I do a mastoid crevasse, but I'll show you both techniques. I'll show you a mastoid onlay and a crevasse. I want to feel the crevasse, which is there. You can see it kind of indents, and that happens in life as well. The sternomastoid is pretty much missing in this patient, but I would bring a tail back this way and bring that down to there. So that is going to be my deep plane entry here. When you're doing this, I probably do a concurrent brow lift and adjunctive brow lift in about 90% of patients because of the vertical elevation. If you're going to be revectoring orbicularis, you have to do that to accommodate the excess skin. Perfect. Can I take a knife, please? Have you guys got a view here? So what I want to do is put my finger into the conchal bowl, pull back, use my other finger that way, and I make a little nick there anteriorly along the incisura. Next, I'm going to go along the lobule, hold the lobule, pull it up and around this way. We're going to come straight back, bevel and down. This side, you want a firm bevel going around. You want to preserve the temporal tuft. You can either make a point here, depending on the anatomy, or you can make a little nick here. Come around the helix. And then, as I say, I'm going to do a paratragal incision, which is like that. So I'm leaving 1 millimeter of tragus here. Take an AdSense, please, Joni. Thank you very much. So with this, that's tooth. Yeah, great. What you want to do is peel now. All right? There's little branches of the superficial temporal. This should peel. If you start sharp dissecting there, it's going to bleed. So you peel it away, and it no longer bleeds. I've got my bevel up like this. I want to hold this. Do we have a toothed AdSense, or this is the only one we got? As you come over the tragus, you want your bevel to be up like this so you can't cut the tragus. I use a really fine, almost micro tooth AdSense for this. This is almost like a cartilage holding forceps. And you just want to brush it along like this. I don't use a knife for much of the dissection. I just take it out to here, like that. Now, have we got a Pitangui flat clamp or a clip or an Alice or anything that's going to grip tissues? That will do. So I'm going to hold that. I'm going to hold this on here using a needle holder. What I want you to do, Megan, is with your fingers like this, I want you to tent the skin for me. Do you have a Metz scissor or a... Okay, I'll take this. Yeah, Metz is better. Okay, I'll use a facelift scissor. I don't like using a Case Stevens facelift scissor for this because it's sharp at the edge and it's very easy to traumatize the dermis. I prefer either a Mackendo or a Metzenbaum. Okay, you then want a tunnel. There are different ways of lifting skin. You can lift it up, put a light through. People always talk about skin thickness. It doesn't really matter. What I like to do is pull towards me. Megan, if you just give me some counter traction, that's fantastic. And I'm just going to run my scissors along here. So I'm just tunneling like this. All right? It's really, really atraumatic. That's all you need to do. You then put your finger in, and that's done. In life, what I would do is get a swab, put it in there, leave it. But we don't need to do that because the risk of hematoma is fairly low in this patient. Okay, we're now going to do the same this side. Megan's providing counter traction. I'm pulling towards myself, and I'm running the tips along the dermis. So I'm feeling it, and this is how you dissect the skin flap. It's really atraumatic. You don't have to dissect very much. Okay, we're going to leave this little patch here. Mike mentioned Roski's patch. We're going to leave that. So we're going to leave that like that. And that's it. Again, I would put a swab in here and a swab in here. We'll then take, have we got a bear claw or something like that? A bear claw or anything that's going to hold the pinner back for me. We'll use the malleable retractor. Yeah, that will do it. So I'll take the knife back, Joni, and then Adson's again. Awesome. Skin flap elevation here. It's not rocket science. Again, we want to bevel up like this. And we're just going along here. Here you don't want to go too deep. Very, very easy to go through the fascia. You want to look out for the postauricular muscle. And you just want to release down there. You want to release the lobule. This can bleed a little. You just leave it to bleed. And there. So you can continue to dissect with a blade, but actually we're going to do the same thing. So if we take that needle holder, again, you can use an Alice. You can use, I like the Pittingy flap clamp, I use them a lot. We're going to do exactly the same thing. So I'm pulling towards myself. My capable and beautiful assistant, Megan, is lifting the pinner backwards. I'm pulling this towards myself, and I'm tenting the skin. I'm running this, my tips along here, okay, and that's safe. The only thing you want to make sure is that you're superficial, because you can prang the accessory, or if you're really lucky, the great auricular. You want to create a little pocket here that I can then slip my index finger into. Then I can provide the counter traction. And then you just want to keep nibbling. This can be pretty tough. But I'm just going to go through it. Nibble, nibble, nibble. And I'm using my finger to counter-tract. What I was saying earlier in the dummies lecture is a lot of this surgery is left-brained, okay? I'm not thinking where I am, I'm feeling the tissues. They're telling me what depth I need to be. Yeah, that's pretty tough in there. So we're just going to release all of that. Good. And we're going to go there. I'll take that off you, Joni. Elevate here. And you want to join the pockets up now. So you've got this little prelobular pocket, and then you've got this pocket in the neck. The only thing you need to be thinking about here is the great auricular nerve. You want to stay superficial. And if you're worried, you turn your scissors vertically and you start spreading. Bad workman blames their tools, but I'm having to nibble this 55 times to get through. So we're just dissecting that out. You want to go a little bit lower. You're going as far as the sternomastoid muscle. You don't need to go much further than that. And then we're just going to release this. So that's the skin flap elevation. If I take that off, that's the amount of elevated skin. Really not much. Right, I'll take, the Army Navies. Do you have a pen? So, like the bunny ears Mike mentioned earlier, we're just going to lift that up. I like to then mark my deep plane entry. I don't know whether you can see under there, but I'm going to mark my deep plane entry here. If you hold that for me, Megan, thank you. And I'm going to mark this deep plane entry here. We're going to come back, and we're going to come down here. I like to use a Colorado needle for this. I'll use a knife. Colorado needle's best for this because it's hemostatic and it dissects beautifully. But again, this is all about counter tension. The right hand, or my dominant hand, is doing very little. Through here. And we're just developing this plane. Again, I like the Colorado needle for this, if you hold that for me. Thank you. And we're going through here. So you want to dissect. If you start seeing parotid fascia, that's where you want to be. This is totally safe. You can't damage anything here. Just stay superficial. It's called deep plane, which is kind of a misnomer because it's not actually that deep. But you need to just be aware of the structures beneath you. So this is all very, very safe around here. You want to come back here. Here I go down as far as the parotid capsule, which is the cervical retaining ligament, and I want to see a little bit of parotid here. I don't mind seeing parotid. If I've got that and I've got the parotid capsule, it means I've got the cervical retaining ligament, which is going to provide strength to my flap. Hold that for me. I will take this, and now I'm just going to elevate. Now, to get into the deep plane, this is your safe zone here. This is level 4. Underneath me is the prosauricular fascia. I'm heading into the premasteric space here. And you can see the tissue becomes alveolar. There's a little bit of parotid there. I'm just on top of it. In life, this literally looks like tissue paper, little alveolar plane. So I'll take the facelift scissors, the K. Stevens. So once I'm in there, this is super safe. We're entering the pre-masseteric space. So I'm in, and I'm just releasing. This is blunt spreads, and I'm creating little tunnels. You can see how this is just an avascular, neat little plane here. Underneath me is the master muscle. My roof is the SMAS. Inferiorly, there's no boundary. This is the road to the platysma. There's nothing here because the platysma and SMAS are continuous. If I head up in anteriorly, I'm heading towards the masseteric cutaneous ligaments, which aren't actually ligaments, they're just condensations of fascia. You think they're a kind of punctate, well-defined ligament, but they're not. They're just condensations. So I'm just releasing, just spreading, and it should come apart fairly easily. So if you head up this way, we're heading towards the buccinator space, which is where you'll find the buccal fat pad. So this is the pre-masseteric space now dissected. You can put your finger in, and it's pretty released. I'm out here towards the modiolus. Now I want to release the platysma, so I'm going to head inferiorly. This is the cervical retaining ligament, which is parotid capsule. You can see there's a little bit of parotid. I don't mind revealing a little bit of parotid. And you can just dissect. The key under here is the cervical branches. If you cut under here, you're going to divide cervical branches, and then you're going to have a sleepy lip for a little while. It's got good collateral, it will come back. You can use a Trepsat dissector if you want, or you can Viterbo, you can use your finger. I like the flat Trepsat, I'll show you why in a second, but I'm going to make do with these curved ones. And you're just gently elevating here. So now your pre-masseteric space and your subplatysma space is dissected out and free. This is a natural glide plane. So that's pretty free. We're now going to head south this way, and I'm going to release this just a little bit more. You want to release the lateral platysma entirely off the sternomastoid because what you want is vertical elevation of the platysma, which looks pretty good. I'll put my finger in there. I use my finger so I can feel that under here, you can see here is a little ligament here. So it feels like if you're ever worried about anything, I'll show you in the prezygomatic space in a minute. If you're worried about a nerve, what you do is you put the tines of your scissors behind it, turn it towards you and open. You look at it, if it breaks, it's a ligament. If it's got a little red line down it, a vena nerosum, it's a nerve. So that is now completely free. Come out with that for me, Megan. So here is my little platysma cuff. So that is what's going to come up here. I don't know if you can see the jawline and the neck, but that is now freely mobile. I'm feeling it rather than looking at it. At no stage yet have I looked at my jawline, but that's pretty free. So I've got a free pre-masseteric space, I've got a free subplatysma space. The next is prezygomatic space entry. Most people, this takes about 45 minutes to get into. I'm going to show you how to get into it in 4 seconds. What you want to do is take a pen. I don't do this normally, but for demonstration purposes, I want to feel the zygoma. This is the zygoma here, in a lake of This is a tattooed zygoma. I'll take the scissors. To get into the pre-zygomatic space, the key is not, Alessandro referred to this earlier, you don't want to go sub-zygomatic. You go sub-zygomatic, you're going to roger the nerve, and then you're in all kinds of troubles. So everyone spends forever going into this and creates malar edema and lots of trauma. This is how you get into it in 5 seconds. You want to feel the zygoma. You want to create a little pocket, okay, like this. The action is this. We're going to go in, 10 degrees up, 10 degrees up, open, push, pop. All right? So again, in, 10 degrees, open, push, pop. But I can do that with a trepsat, which is like this. A straight trepsat is better than a curved one because that's dangerous. That's going to take me more than 10 degrees down. So I'm going to guess that it's straight. In fact, I'm going to straighten it up this way. So you want to go in, whoops, 10 degrees, open, push, pop. I then put my finger on here and I push and I'm in. Do you see? So that's pre-zygomatic space dissected. I'm gone all the way out to the modiolus. I'm going to come up to the mid-face. This is not easy with this one. So we don't have any instrument companies here. I receive no money for this. I have no disclosures, but the black and black trepsat is the best. Why? Because a lot of trepsat dissectors are sharp in their posterior aspects. As you pull them through, they snag things as they come out. So that's completely free, out to the modiolus, out to the mid-face, and I'm free. So I'm out. We'll go back in with these. This is Mike's bunny ears he was talking about. Bunny ears are cute. You can do whatever, or we'll take a little skin hook. Megan, you do whatever you want. Okay. Nice. Good. So now we've dissected the pre-masteric space, we've dissected subplatysmally, we've dissected the pre-zygomatic space, okay? And I could get my finger all the way into there if my finger was smaller. You can use a knife, you can use a blade, or you can use a knife, or you can use a Colorado needle. I'll take some forceps again. Have you got something a little longer? Yeah, that'll do. No, that's good. So you're going to just come across here now. I use a Colorado needle. I have my assistant look at the face, and I'm looking for any stimulation of the nerve branches. As you come through here, you can meet with some bleeding. That's the transverse facial vessel. If we get some better light on here, we'll see whether I can find the transverse facial vessel. The transverse facial lets you know you're in the right place, and we're just going to come through it. I can feel it scratching against my blade here. This feels very ligamentous. And I'm just countertracting, and my right hand is literally just going backwards and forwards. I'd usually use a Colorado needle for this, as I say. It's really neat. So you can go through. You're pretty safe here, and I'm well above zygomaticus major. So we're just heading forward that way. So, and I'm using my left hand to provide further counter tension. So really the only action with this hand is doing this, right? Anyone can do it. All of the work is done with the left hand, and I'm feeling here. I'll take the scissors now. So when you start to bottle it, you can get some scissors, you put it in, and you open and spread. And it just opens up in front of you, just like this. And the movement, I don't do vertical spreads like this. I turn my scissors just a little bit. Why? The kinetic energy that I deliver vertically is higher than if I turn my scissors this way. If I'm going to press against a nerve, I'm going to disappear off it much quicker if I turn around this way. And you can see how it just all opens up. I'm going to head this way. Now I've got the zygomaticus beneath me. You can see it coming into view. Ah, light, now I can see. So you can see a little bit of a pink of zygomaticus here. You don't want to skeletonize zygomaticus. Very, very easy to do so, and all the books say you've got to identify zygomaticus and go along it. That is a dumb thing to do. If you skeletonize zygomaticus, it's going to potentially scar on the SMAS flap afterwards and cause a smile block. So you want to leave as much fat on zygomaticus as possible. You don't need to identify it, you just need to make sure you're above it. So here's zygomaticus coming into view, and I'm pushing it down. So I'm just continuing to extend my dissection,
Sometimes this bleeds a little bit. If it bleeds, you just put some pressure on it. There's no big vessels here. So you look at this and you're like, is that a nerve or is it a ligament? I'm going to put my scissors through it, open it up, have a look through loops. If it breaks, it's not a nerve. So we're almost finished the deep plane dissection now. Here I'm heading towards the buccal fat pad and buccinator space, and that will be down in here. We've got a little bit holding up here. Yeah. How's that? Are we good? So, this is my deep plane dissection. People say, how far do you go? I've been through the zygomatic ligament. I've identified the pre-masteric space, and I've gone subplatismally. There's not an anatomical landmark. It's all feel. So I'm putting my finger in. If I feel guitar strings, I don't want the guitar strings. So I'm just going to continue to release them until there's absolutely nothing stopping that face from repositioning. So now we're pretty good. Right. Now what you want to do is develop your SMAS cuff, and I'm going to show you the orbicularis extension should you wish to do so. I suggest if you don't rush into orbicularis revectoring until you're comfortable in the deep plane. So all I'm doing now is just developing this SMAS cuff. The reason I mark it with a pen is this is now giving me a guide as to where I'm developing my cuff. Let's take that out. Let's take those. You got some DeBakey's? Wow, they're huge. These are so big I could use them from the hotel. Awesome. Have we? That's excellent. It's always good. So, that's basically a basic deep plane facelift. Have you got a clamp or a needle holder or something that's not going to wreck? So I'm going to put this on this cuff here. I'll take another one. Here. So this needle holder is on the platysma, this is on the SMAS, and this should be a completely released face. Do you see, if you zoom out a little bit, guys? Yeah? How's that? Is that a little better? So this, that way, yeah, great. So what I'm doing now, I'm not even looking, I don't know whether you've noticed, but I've actually turned away to not look at anything. I've now got my eyes closed. I can't see what's happening with the face, but what I'm doing is feeling that it's completely released. There's nothing in my way there. As I said earlier, this is right brain surgery. My left brain's going to get in the way if I look towards the face and go, oh, that's a beautiful jawline, maybe I need to do that. I want to feel that that is completely released, and that feels pretty good to me. That's nicely released. Okay? Now, if you have a look under the eyelid, you'll see the mid-face elevation. Okay? It's pretty good. It's coming up. Have you got that on screen? I don't know whether you can see. Yeah, turn it around that way. That's great. So if I put some pressure on there, the mid-face comes up, but it does nothing to the lower lid. Do you see the lower lid? Laxity. Have you got that on camera? Okay, come down. I'll tell you what, I'll come towards you and we'll try and do that. So if I am to elevate this flap and pull on the cheek, do you see lid lag? I don't know where that comes across. Yeah? How's that? Okay, that's better. Good. So that's the elevation here, okay? But we're not elevating this. If you want to do orbicularis revectoring, this is what you do. This is SMAS in continuity with platysma here, okay? The orbicularis is here. If I go on the right side between 7 and 8 o'clock, I'm going to miss all nerves, so I'm going suborbicularis now. This is a blunt dissection. Heading up this way, I'm not cutting anything at all. You can feel, sometimes you can actually feel the orbicularis retaining ligaments, a bilaminar structure. If you look at Mendelssohn's paper, it's got an outer thinner lamina and a thicker inner lamina. So I'm just releasing it just a little bit this way. Now, Joni, if you give me a needle holder again, or actually no, I'll use this one. So instead of holding that clamp there, I'm now going to hold orbicularis and try not to tear it. It needs to be released a little bit more. Take the scissors. So we're going to come up here, and I'm just going to release the ligament a little bit more. And I'm staying within the curfews here. I'm having to do this by feel just because of the lighting and cameras. I can't do my usual looking at it directly. So if I now place the clamp on orbicularis, and I realize this is a little more advanced, I don't know whether you can see the movement of the lower eyelid there. So the midface is completely captured here. If I'm to pull this down, I don't know whether before you could see there was lid lag. Now this lid is completely supported. I haven't revectored orbicularis. There's the lid, yeah? Now I have revectored orbicularis. Do you see there's no lid lag? Do you see the lid support that's created? Yeah? So I've let go of orbicularis. There's the lower eyelid. No tensioning of orbicularis. Yeah? You see the lid bowing, lid lag, and scleral show. If I revector orbicularis, do you see how it's no longer pulling down? Yes, good. So that is the flap elevated. You now want to think about flap inset. This is what I do. Just give me any string, guys. Whatever string it is, it doesn't matter. I meant it earlier. When people say, is that a 2-0, 3-0 cutting? It really doesn't matter. You need rope, okay? What you want to do is you want to come through the facial aspect of the sailboat. Take a, what's the word in Italian? Bambini. Testiculi. It's not testiculi. Where's Alessandro? Is he here? Alessandro. Alessandro. No.
Wake up.
Wake up, everybody. All right. This is what I do to inset the flap. If you hold that back for me. So I put one through posteriorly and one through superiorly. And what I'm going to do is let the face tell me where it wants to inset. This limb is going to be pulled backwards. This limb is going to be pulled cranially at the same time. And I'm going to look away from the patient because I want the face to decide, not me. So I'm just pulling on it and it will tell me. If I'm looking at it, I want to put that in there because that would be really clever. All right, so I'm just going to go towards me and above, and I've got my eyes closed. You guys can't see this, but this should be arriving in the same place every time, which is there. So that's where I want to inset it. So I'm going to throw a figure of 8 stitch around here, pull it through like this. It doesn't even need holding because it locks. It's a figure of 8 stitch. Done. Cut for me. Thank you so much. So that's a key stitch. That shows me where it wants to be. The next bite I will take is posteriorly, usually by the incisura, which is about here. And I'm going to take some of this. And I'm going to do the same thing. I'm going to hold and I'm going to feel. We don't have a body attached to this head, so it feels rather different. But I'm pulling up, and that's where it wants to sit. And it usually sits just in front of the tragus. So I'm going to take that bite that way. You want this to be free. If you go through the perichondrium, you're going to have an everted tragus. What does tragus mean, Mike? A pea goat. A male goat. There you are. So it's complete education today. Thank you so much. So that's that inset there. I'm then going to go between. There's no tension on these. These are literally just being inset where they need to be set. I'm going to come through here. Again, figure of 8 stitch. This looks like a vicryl, which I use a 2-0 vicryl. You can use whatever you want. It really doesn't matter. That's that. So that's the SMAS flap inserted. Now I want to set the lower eyelid. This is a little bit tricky to do from a technical perspective because I've got to get under a little dark hole, but we'll try and do it in the dark. Let's try it. Let's have a Army Navy. I like to use an Alfric retractor. It's just smaller and thinner. But what I want to do is this. I want to go through under here, hold orbicularis, bring my needle through. I'm in the dark here, so I'm doing this all by feel. That comes through. I then want to mount my needle like this. I'm going to bring that up there. Thank you, Megan. I'm going to hold orbicularis. I'm going to slide this long orbicularis and come down and through. So that is now through the anterior tangential limb of orbicularis. I'm now going to overlay orbicularis on itself. So I'm not stretching orbicularis. This is literally just a little advancement, muscular advancement flap where I'm going to overlay the two. So I've got a good bite of orbicularis. I'm going to feel it and tension it. My endpoint is not tension, but just comfortable apposition. So that's where I want it to be. I don't have any light, but I'm going to just guess. I want to grab orbicularis on the other side, and then I'm pulling towards myself like this. So my needle is engaging orbicularis, my forceps are on the other side, and I think that's where the needle is. And I'm going to pull that through that way. This can literally be an air stitch. It doesn't have to be tight. We're onlaying orbicularis over each other, and it's just going to provide some support. Scissors, please. Thank you. Now we're going to just place one more stitch, and then the face is done, and then we're going to inset the neck, and then you guys can play to your heart's content. So we're going to go through there. We're going to go through here. And I'm just going to insert that here. Good. Cut, please. Scissor. Oh, I got it here. Right, that's the deep plane lift. We're now just going to manage lateral platysma. There's different ways of doing this. You can do jump papa stitches if you're silly, or you could do it properly. Let's take a... Okay, so you want to feel the mastoid, which is here. I like the mastoid crevasse. I know Mike decided he didn't like it and he just gets better results than all of us, so maybe ignore what I'm doing now. This is the cuff here. The principle behind it, if I take another needle holder, guys. The principle behind it is we want to onlay this lateral edge of platysma on the anterior mastoid. The reason for the anterior, not the... So you can just onlay it here onto the mastoid. Stitch it there, go home, we're all done. Okay, and that's what I used to do. What I like about the mastoid crevasse is it creates three-dimensional X, Y, Z depth. It's anatomically superior because you're insetting the platysma back in the same laminar plane it's meant to be. You're creating gonial angle ramus definition, but you're also creating inframandibular depth, and that's what's attractive. Especially if you've done Francisco's done a deep neck reduction here. We now want to bring everything in under here. So the way through the mastoid crevasse, which I think's erroneously named, it should be called Tally's Valley. Let's have a pen, please. I don't know what I want, Joni. I literally don't know what I want. So I'm going to feel the mastoid. The mastoid is kind of here. All right? With a crevasse, you want to come up higher than you think. I would then inject it normally with some epi and some local. And I'm going to take a knife, please, Joni. I use a Colorado needle. And what you want to do is head straight down onto the mastoid, but then you want to head anteriorly. So I'm heading straight down. If you see sternomastoid, you've gone too far inferior. We're just going to head down. You want to come up much higher than you think. So you want to come up to the contral ball. So here I'm reflecting the parotid capsule forward, and you can see this is a avascular plane. Yeah, so I can put my finger in here. That's the anterior mastoid here. I'm going to come up higher. That is the contral ball here. All right. If you're seeing sternomastoid, you're going too far inferiorly. If you want to do a parotid reduction, you can do that here. What you would do is you'd elevate the superficial cervical fascia. You'd come anteriorly this way, and I'm now in parotid gland. I can head underneath here. The greater auricular nerve is going to be within the fascia that's being retracted away, and I can keep enucleating. I'm going to do it anyway. Why not? We're here. We've come all this way. You can just reduce a chunk of parotid here. Yeah, you do it with a Colorado needle, it stops it bleeding. If you're going to do this, I would put Dysport, I'd put 10 Dysport units or 3 Botox units into here, and it certainly helps. And that you do if you've got a big bulging gonial angle and you want to reduce it. But we'll pretend we haven't done that. So now I'm going to take one of those. We're going to inset. You got me another one. You're too kind. Thank you so much. Spoil me. So this is the platysma I developed earlier. Okay? It's got a tiny little bit of parotid and parotid capsule. I repeat, the reason I want that is I want the strength within the muscle. I'm going to come up and through. Wow, it's that strong, it's popped it out. I'm going to come up and through. I'm going to turn my needle around. I'm going to go back through. There, and then I'm going to whip it. Whip it in, whip it out, and wipe it. Huh? Good. Right, so now I've got a good bite of this. I want to turn this into more of a C. You want to be deep and high here. There's no point just putting it here. There's no point going through all of this without doing it. So you want to be deep on the mastoid periosteum and high. High. Okay, good. And then we're going to bring it through like this. Then we're just going to throw this stitch, pull it through, and then you want to kind of trampoline it in. Come out with that for me. So I'm putting my fingers down at the level of the mastoid and pulling apart, and I'm just insetting this where it wants to be. It's pulled through. Sod's law. So it's crappy tissues or a crappy surgeon. It's one of the two. Probably a crappy surgeon. Oh, I forgot I've got a mic on me. Right. It happens a lot. So we're coming through here. And then we're just going to insert this like this. You get a non-tooth forceps and pinch that for me. This is the only place where tension is actually put. Yeah, pinch that for me, Joni. Amazing. And away. Beautiful. So I then put in another couple of stitches and we're done. That is it. Any questions? Well, we can answer questions as we go around. Do you guys want me to show anything more? Mike, you're the boss.
Let's have Neil do his thing and set these guys loose to operate all day.
Sounds awesome. Thank you very much. It's been emotional.
Good afternoon, everybody, and I want to applaud Dominic Bray's great dissection. So we're gonna look at how I approach the deep plane and how I've evolved over the years. So to save some time, I've done some pre-dissection, and you'll see certain similarities and certain differences in both philosophy and concept. So the incision I use is a hairline incision, and in the video that I made, which maybe we'll just run afterwards, I'm actually, one of the key points is you can't be exactly on the edge of the hairline. You have to be a couple of hairs in. My criteria is once the hair gets thicker, that's where I put this incision. And since you're really not resecting much of this tissue here, this more moves up, I can get hair to be on both sides of the incision, because there are random hairs on the temporal side here that you could never duplicate surgery, and it minimizes your chance of having a sharp edge. I won't open this all up right away, but this vector here is because the flap will move so much, I will need a horizontal component, as you'll see. Although this is a male, I'm treating this as a female, so this should parallel here on the helix, edge of the tragus on a female. The other thing that's very important is take a look at the placement of the lobe. Look at whether it has creases. Matter of fact, this lobe had creases in it until I dissected. So if I didn't take note of that, I would think the lobe should look like this, and it won't show up in your photograph, and that was part of my lecture. Then I will follow, I don't go on, you don't have to go onto the concha with the deep plane because there's no tension. Another important point is we haven't really done anything yet, but the vector of the face and the vector of the neck skin are different. And I like this whole flap to be homogeneously smooth without, points of radical tension that are visible externally. So here, the superior part of my incision is not based on a standard to parallel this. I feel this face, I feel the kind of soft tissue it is, how compliant it is, how much soft tissue redundancy there is, and I predict where this flap is going to move back here, and I want this incision. What I don't want to have to do is rotate this up to close this later, so we'll be fine. But if you notice the way the skin wants to go here, and part of the reason we can really treat the inferior neck is because we're actually using all of this. That's why I have to mark the back of the head. Then, based on the hairlines, the amount of redundancy, and the soft tissue type, Dominic and I were talking about, soft tissue type matters so much in how the face will behave, and get used to feeling faces. It's going to be so predictive in how this face will behave. So this is the lateral entry point, or you can also, like I said, this is Ben's sailboat. So I started doing this in the year 2000. As you'll see, it's going to be really for flap management. And it's not standard. There's certain faces, if they have good hair, it could be a little bit more medial. And if they're revisions and they have a really bad hairline in the temporal area, it'll be much more lateral. But that's a calculation I'm making. Also, you can't err by being lateral because you can cut away the underbelly of the flap. You can err by being too medial because what limits the facelifts is when you get fixation points that are naked in the temporal area without being able to layer them out above. So what I want is my flap design that I get a fixation point underneath the temporal hair tuft, and that's how I'm designing this. So it's standard where I'm starting right by the angle of the mandible. This is also consistent anatomically where this is the only area of smaz. There is no smaz here. And this is the only area where the lateral band of septae that span from the dermis actually connect to the smaz, and I call this diffusion zone. And this has been biomechanically tested to be the strongest area of your face, and this can undertake the most force and tension without distorting. And it's why my first sutures are going to be here when we lift the flap. Now, there's debate about how much you delaminate in the neck. I think there's reasons. The septae go to here. I think if you have to do a lot of fat contouring, you do need to delaminate. If you don't have to, you don't have to delaminate. And one of the areas that doesn't get discussed about delaminating is over here, essentially from the hyoid body and inferior, because this area is very poorly vascularized. So if you're going to get contour irregularities, it actually tends to be here, and they're visible. So I think there is value in making that decision. So we've pre-dissected, and we're essentially at where we would have the deep plane entry point. So then the next step, what we're going to do is we're going to define the edge of the orbicularis. So let's see what instruments. So I'll use this, and you're going to pull here, and I'll take a scissor. So I'm just going to make a pathway. Notice my finger is behind, feeling my flap. Not at all. You can just grab that, sure. So I'm going to come over here, and I used to do, the typical fame dissection, and I found that not everybody, but in the patients that you got persistent periorbital edema, they were miserable because it was there for months and months and months, and this was even before the filler age. So you could see the curve of the orbicularis, and I don't find there's anything really to lift here. So what's the point of delaminating this, which is different than what Dominic is doing, because Dominic is suborbicular orbicularis for a different purpose. I find as a general concept, you need just a little traction there. Yeah, sure, great, thank you, perfect. And I'll see the orbicularis, its curved fibers, and once I identify it, I'm actually done because I'm just using it as a reference point. So I don't see value in delaminating this area. I do understand what Dominic is doing because I do think it has a different purpose, and I think that's fine. It just takes a lot of finesse. So the orbicularis is right here, and you can see its fibers are basically semicircular. So now I will just finish off right through here, the subcutaneous portion here, and now we're ready to go deep. So a couple of people asked for me to go slow at this point. Yeah, just take that out for a second. We can always put it back. So the area that's the safest, can I have a marking pen, please? So we mark the angle of the mandible. This is where I'm going to enter based on my calculation of how that's going to move to get it under the temporal hair tuft. This is essentially your safe spot right here. So essentially about 2 centimeters cephalad to the angle of the mandible, and that's the place that if you haven't done it or you need to be a little aggressive, you can be, because there's really going to be nothing there. Remember, your marginal is coming over here, and your buccal branches are really coming through here. So that's a safe zone. So utilize that to get comfortable in finding the plane. And then you could develop it from that point, and remember what I had said is use the thickness of the face. So I use a 10 blade, similar, I don't really, and you can actually retract the skin. Yeah, and a 10 blade, please. Thank you so much. Okay. And then you countertract, right. Now I'm gonna show you one little trick for real life. So one of the things that we do with my assistant is they have their hand evenly across the face, and they don't drag their fingers on the face when we're doing this. We've had instances earlier where the traction of the fingers creates friction along the dermis, and they can get little, almost little swelling and blistering. Not a frank blister, but marks on their face. So one of the reasons why we can make the faces look good quick is that we make sure the assistants are handling their side correctly, so it's nice, even, wide retraction. I don't want them stopping and moving to follow me. I want them to take a big, wide area and hold steady so I can move and they just stay in one place. And if they have to move, they'll tell me. But for today, I think this patient will look fine tomorrow no matter what. So I think we can do whatever we want. So here's the angle. So I will take the blade and I will just mark my whole length of my incision here. Now, when you tent up the tissue, you can often see the fibroareolar plane. So let's say, you see how you see this tissue here? You see when I'm going up and down with it? It makes me see exactly where my plane is. And then, just giving myself a little more room for the camera, I will also, yeah, if you can lift that neck skin. Another thing I'll do at this point is I'll go like this and you can see the platysma tenting up. So I'll follow this and already start some of my cervical ligament release. Now, my plane should be right. So let's say you do this and everything is stuck down. It's not opening up. Your immediate thought should be, you're still on parotid. There is no plane over the parotid. So, and if you encounter that, just keep on moving anterior. And let's see. And this is sometimes I just do this to give myself a little bit of room. And then, hold that please. Just this, the knife please, thank you so much. I'm feeling right away. So what should I feel? if I'm in the plane, I should be under the platysma, and the platysma is muscle, so it's smooth. So if I feel smoothness, I'm under the platysma. And the reason why that's important is when you're first starting out, most surgeons are so worried about getting too deep that you actually may get too superficial and be over the platysma and not realize it. What that would feel like is feeling like fat, which is irregular. Muscle is smooth. So you just do that, please? Thank you. See, I'm letting that dance a little bit. I'm just having a little trouble. That's not you. You guys are doing great. But you see also what I'm doing here? If you're not sure, I can use the knife bluntly or very sharply, depending how comfortable I am. Take that, please. So I'm here, and then what I'll do is, let me have some sort of retractor, right angle. Yes, this one is fine. So here, if I'm in the plane, okay. So if I'm in the plane, I could just run my finger, and I don't mind being aggressive with my finger, but you see I'm feeling my flap. And my flap is perfectly smooth. And these are some of the little nuances that differentiate the people that look good in a very limited amount of time versus flap irregularities. So, without much work already, I don't know if you can see in the hole here. Can you see in the hole? Okay. You could see here, this is going to be a protomesenteric fascia. You could feel muscle, which tells us we're in the plane. Now we're just going to keep on, let me go back to the rake. Thank you. And a knife. Thank you. And using that as the reference, keep on developing the plane here. Not sure a little bit, so just push a little bit with the knife. I will also angulate the knife. If I can make it really sharp, I can make it a little blunt. But I don't think it's really important what instrument you use. You have to use whatever you're comfortable with. This is why Dominic was talking about sutures. You know, whatever suture works for you. Now, this is not going to be an obvious plane. Now, I'm lateral, so I'm behind the nerve, behind Patengi's line, but I'm just sort of filleting this area. And I'm just moving forward. Because what I'm just doing is I'm preventing being in a hole. Then I'll stop and I'll feel how thick this is. And if this is thick and even, I'm happy. So now let's continue here in the face. And I'm a little gooey. And this area is less well defined. And as Dominic said, you run into branch of the transverse facial. And the issue with that is the nerve is near it, so it's easy to stimulate the nerve right there. Now I want my orbicularis down, and I'm going to essentially, and I agree with dissecting from superior to inferior over, let me feel where I am here. So for instance, now I feel I was actually getting a little bit too thin. So now I've noticed that. So I'll bring it down a little deeper. And once you're in the plane, the knife glides very easily. And we can see what we've developed so far. Yeah, let me try to get this in here. So I really try to make my dissections as perfect as possible. It really should look like an anatomy dissection. And you can see already, here's your platysma. This is going to be your underbelly. Now, if I want to give myself a little more room, I'll take the blade back. And you can just pull in the neck a little bit. So this will be releasing cervical ligaments. take this down as far as I need to. Thank you. Yeah, I'm sorry. I'm so used to doing that at home that I don't even realize that. And for instance, why don't you guys feel the flap for a second? I'll let you guys do this. Feel how even this is. You stick your fingers in. Go all the way deep. Do you see how even everything is so far? And I think this is, part of the reason we can make people look good quickly is being correct on the dissection. Now you have your reference, right? This is how thick the face is. We're already below the angle of the mandible. We can extend that further. The ligament doesn't dissect, but it does dissect here. And now we're in the areas that are less well defined. We have our reference point, which is the thickness of the face. So now let's continue on. Thank you. Great. Now it's a cadaver. It's not as obvious. So you see I'm being a little more judicious. If you get into a revision, or if you get into somebody with all this junk in their face, which you are. It's not if. But let's say, if you lift the tissue up and down, and your assistant's giving you good counter traction, which I'm getting, you can kind of just see where you need to be. Hold that, please. So I did a little bit, and I'm feeling again. Good. So far, so good. Okay. All right. As the guy who jumped out of the 100th floor is falling down, somebody in the 40th floor said, "How you doing?" He goes, "So far, so good." So I don't have good visualization. So you notice I changed the angle of my knife to something that hold that, please. Yeah, that's what I'll do. I'll just give the knife off like that. It's great to have terrific assistants, especially when they've never worked with somebody before. We've done some cadaver dissections that were so nice that people were surprised that the person passed away. It looks so good afterwards. It's like somebody died so young. They say, "No, we did a deep plane facelift on them." Yeah. Zero cost. Yeah. Yeah. Look great for the wake. See, now I'm over the buccal fat pad. Now I will take this medial. I do want to release everything in a sense of the mesoterracutaneous ligaments, which are right here, are significant on men. Usually with women, you can kind of push through them. I think you need to release them. Brian Mendelsohn says nerves run with them, and if that was the case, I would have paralyzed about 20,000 faces already. So I think that may not be correct. Okay, hold that again. But see, I keep on stopping, and I'm literally doing this like I would in surgery. Because you see now I'm all the way down to here. See how easily this dissects? And I've gotten used to using my fingers because I'm constantly feeling. Dominic was saying earlier how he doesn't even look at a lot of things. I understand that because I will feel, I'll look away and I'll feel, and I want my flap to be as even as possible. Now let's come back here. Just degoo myself. So here, now I won't dissect, I have the orbicularis edge defined, and I won't come over the orbicularis, and I kind of go straight for the ligament. This is where you can get into a little bit of bleeding. The other thing that Dominic said that I agree with is when we're in the deep plane, and this is similar to what Tim Martin says about when he's in the deep neck, is no one's talking. Can you take that, please? Everyone's focused on the face. Everybody's looking at the face for twitches. And if you see a twitch, it's fine. Just don't do that again. Like whatever you did. Right, exactly. Hurts, right? Hey, doc, every time I go like this, it hurts. So stop doing that. So here, so again, but you see my reflexes to feel the thickness of this. And I'm just used to doing it this way. And this is much more lateral, but I'm going to show you the benefit of being lateral once we get the rest of this dissected. Okay. Yeah, thank you. Thank you so much. So the muscle's not obvious yet. So I'm coming through here. Now, I'll show you something. So I just made a sweep. I'm not really that deep, but I saw a little fat bulge, which meant that I got to look to see if I just poke through the fascia, which is not a big deal. You just want to know you did it, and as a sign, feel the thickness, and then go back to where you were. And so I will give those hand signals of, went great, yeah, new knife, that's wonderful. I know. Can I just have them Tuesday through Friday? And you guys can have them the rest of the week. Hold that. But there's nothing wrong with just taking your time and developing. Now, in a person, it's actually easier because you can often just slide your whole paw in there and just dissect with your finger. But yeah. So we're still stuck by the zygomatic cutaneous ligament, but you see we have a pretty, I'll take the knife, thank you, and come a little bit lower. Your anterior dissection is limited by the facial artery. And then we're going to go over this area now. So you feel the flapping end, and you'll see it's just nice and even. Okay. Geez, we slop some hair in this guy. We're going to be doing all right afterwards. So we got a new knife. So this is the area where, when you're new at this, don't be afraid of being a little superficial. Here's my thickness here. So I just felt this. I'm a little superficial. You may not get the same degree of outcome as Mike would, but you're getting a great facelift that's better than any smaz. And that's how you get comfortable progressively getting deeper. Because the tendency will be to be superficial, which is okay in this area. Hold that, please. Now, when you get below the zygomaticus major, there's no more smaz anymore. So the retinaculum cutis is actually connected to the deep fascia here. Hold there, please, and I'll take that. Masseteric cutaneous ligaments, so I have to cut through those. And then we're almost there. This is when you also see your buccal fat pad in vivo. You'd be surprised at how, looking at it externally, you'll be incorrect a lot as to whether there's pseudo herniation of the buccal fat pad. Okay. And let's go over here and finish this off. So now I'm going to come over the zygomaticus major. I also agree that you do not have to you should have a little bit of fat on the muscle. Hold that for a second. So I was just feeling that. I felt like I was getting a little thin there, and I am. So let's go back. But that's the point. I just readjusted. Get a little closer so I can actually see. Hold that. Let's use this thing now. And come to just pull the corner of the mouth. That's great. Yeah. Thank you. Hold that. Okay, and knife one more time. Ironically, if you're a little thin on top of the zygoma, it's not that bad because you're not trying to move tissue from there. There we go. Okay, let's see if I... We're almost there. Let's knife. Thank you. Okay. So we still have just a couple little fibrous attachments. Zygomaticus major is right in here. It's being tented up. I don't know if you could see it. It's right here. Here's buccal fat. And these little releases that are left, take that there. Thank you. And then I'm going to show you the flap. Okay. So here's your basic dissection. So this is protomesenteric fascia. Do you have a grabber, please? Yeah, just a forceps or something. Here's your protomesenteric fascia. If this is intact, now I could release this, but I want to get you guys to dissect soon. If this is intact, your nerve is safe. You don't have to worry about it. Here's buccal fat. If we want to take buccal fat, you see when we push on it, I would make a nick in here and take buccal fat. We could try that. You want to just push there? Yeah, and I can do that. You can hold both. Right. And then, actually I usually use, let's see, a scissor. You know what, a scissor. Yeah, so you push even harder if you don't mind. And then you make a nick here. And you can actually usually deliver the fat. And if you push on it, you'll see it'll start to bulge. And then you grab the fat, you tease it out, and then we gently bipolar. If you happen to violate the fascia and you see fat, again, just stop what you're doing. Now here, I don't know if anybody wants to feel the flap, because then I'm gonna, you can take that off for a second. I'm gonna show you how we manage the flap, because I think that's very important. If anybody wants to get gloves on and feel the flap, no? Fine, okay. So let me have I usually use the 3-O-proline. Now, the strongest area of the face, and this is all in the evolutionary, embryologic, and clinical evidence that supports the deep plane facelift. The strongest area of the face is right here. And this is for anchoring for the diverse functions of the face that I'm not going to get into. So my first suture is here. Also, I agree with Dominic in the sense that, you just take those out. You have to choose where the tissue wants to move and where the hair is and where it's not. not just a preordained vector. So if I go like this, so I'll take the first suture. I'll do it righty, this one left. I know I'm confusing. Yeah. And now remember, the value of the lateral entry point is that you can use any part of the underbelly of the flap to put your suture. So if I want to put it right here, I mean, I don't have to use the edge. And then we're actually going to put a ton of force on this. So you guys see what I'm doing here? If you can do that. And let's see. Let's say I choose this particular spot here. So now you're going to rotate the flap like this, and sometimes you have to pull on the other side, push on the other side of the head so you get counter traction. Right. And I just use regular prolines. I agree, I don't use a braided suture. But this should be done with force because you're just trying to reduce soft tissue redundancy. And my assistant was a former rugby player. He's about 110 kilos. We feed him really well. And he can move this tissue. Yeah, just, you can cut that.
Is it male?
Yeah. So you see what the first suture, look at the neckline already. That's just one suture. Look how much tissue is moving. So if you don't mind loading that, we'll do it again. Now, the vector of my sutures, this is another thing that doesn't get talked about. The cervical ligament release we did here, its main purpose is not just to move the platysma back. We will do that at the end. The main purpose is to let the whole face and neck be one unit and move it up with these sutures and be as aggressive as possible. So what we want is our first sutures to be relatively vertical and they're actually somewhat medial. And then when we start to get to here, we're going to start to angle the flap to deal with all the soft tissue that's going to move to the temporal area. Oh, thank you. So this is the general pattern of sutures. Now the tissue gets thinner here. It's fibrous, but it can't handle the force of this. That's why the first suture's there. And then this is just like, once you've gotten 3 sutures in this, you've moved the whole face. Now you're concerned about your transition to the temporal area and why you want to start to angle your flap. So let's do it again. So pick another. And so again, so now I'll pick a spot. See how much I can get this flap to move without dermal dimpling. Okay, yeah, and you do that again. Let me just, yeah, that's great. But the amount of soft tissue that we can move is really impressive. And it's funny because Tim Martin said to me once, he said, you know, the face is not tight. And I said, I know, but having buttocks fat in the face is normal. So, like, I don't really feel making that arbitrary decision. But you see that suture is tight. You can cut it, please. But it's under the flap. We use prolines. And you can load one more up. So now look at the second suture. But notice that how, even on a cadaver, how smooth everything is. And look what the neck did. Notice the direction of the neck tissue. It doesn't want to go there. And then here, how much tissue we're going to be moving up to this temporal area. So now, we don't want to really move this vertical anymore because we're going to run into this. So here is where the lateral entry point, the purpose of it was. And sometimes I'll switch to a smaller suture here because it's thinner and I don't want any dermal dimpling. But I've skipped over a couple sutures, but watch, now I've lifted the face and neck. I would have put a couple more sutures in. But now I'm reorienting the flap without delaminating it. Just under the temporal hair tuft, where I can excise tissue above it, which I couldn't do in the temporal area. And this is why I changed the entry point. Not because of, yeah, I agree, you don't get the same swelling, you don't get hematomas, but that's actually the secondary gain. This was the gain in being able to be so aggressive here, but notice the minute that I rotated the flap at the end, which I would not have been able to do if I entered this medially, look at how now this will become manageable. Where if we just went straight up and had a medial fixation point, there's no way you're going to manage this temporal area. It's why we also do foreheads with all the women. Now, we haven't even been aggressive yet, and we've seen how much the tissue will move. So normally that takes about 1, 2, 3, 4, 5 sutures. Then we'll come down here, and I don't do exactly, the other thing that we are very aggressive with is we do treat the parotid, and what we do is we keep the capsule intact because we have to sew the flap to it, but I cauterize it, and the capsule really, really will shrink down the parotid with cautery, and I show that in the video. But you see this is more deep plane than we needed. I didn't try to fit the flap into the space. I tried to maximally move the flap, but I don't need this anymore. Just cut it away. And now you're making a transition to the ear. So that's why don't just try to fit your flap into the space. Move your flap as much as possible, and then if it turns out you're more deep plane than you need, trim it away. Because your sutures are here. Now, for the neck, what I'll do, which is different from a crevasse, but has similar characteristics. We have here's the platysma. And I'll take a stitch. And now we will work our way down. We will take the platysma here. Now we've released the cervical ligaments to move the platysma up. Right? Look at the neck. What did we do to the neck? Nothing. Now I will get inferior, and now I will just move this platysma. And because I'm going to put multiple sutures in this, I can control which ones have the most tension or the least tension. Like, you don't really want a lot of tension over Lebes's ligament here because it's very avascular. And then I could design this according to how I want my neck. And this will finish off your neck to the point where the tongue is sticking out of the mouth and the laryngeal cartilage is bulging. So now this is harder for the assistant because you have to get all the way behind this, all the way back here. Yeah, that's good. You're supposed to not know how to do this. Yeah, don't put even, but get a little lower here. You see where my pinky is? Yeah, good. Do that. Yeah, cut. So you see what that just did here? Can you see the jawline? And now let's do another one more inferior. And because we still have all this release. And I could keep on releasing further and further down. That's going to be case dependent. Here I'm subplatysmal. And we'll just do one more for just the illustration purposes. And if I feel that a suture is too tight in the sense that I'm seeing a little ischemia, I could actually take it out. I can put one inferior to it. So, and I can treat, and we do treat the parotid and create a gonial angle by carving it out differently than Ben does, but the concept in general is the same. Yeah, let me just get the edge of this. Yeah, then that's correct. Push. Yeah. And let me see under here. One more. There we go. And if the suture's loose, we do it again. But just to illustrate, but you see how even this whole flap looks? And then we don't do the forehead usually. One last point is once you do this, this is complicated. This is the toughest area of the face. Everything we did is not. So here, I'll extend this as long as they have hair, And I don't want to just follow a dog ear like this because you'll rotate, can I have a marking pen? You'll rotate the relaxed skin tension lines. The relaxed skin tension lines are following the lateral canthus. So if you, just some sort of picker-uppers. If you, subtle. So let's see. And by the way, this is always going to bleed here. It's a pain in the ass. But here, I want this to get to layer out. So I'll fixate here. I start here. This tissue often wants to spring away, so I'll put sometimes a little deep max on here. And I work my way. Now here, see this extra deep plane here. I don't need it. So we will fixate here and then go right to the temporal area and then work our way to the lateral canthus. Because sometimes you've moved so much tissue, if you're ever going to have a little bit of bunching, you want it parallel to the lateral canthus or slightly superior to it, because that's the way the relaxed skin tension lines go. If you follow this up and rotate this, you'll get a sweep here, and that's only because you've moved so much tissue. But that's essentially some of the insights. Okay? Thank you. Great job. Now you know your depth.
You have to
Yeah.
join the two spaces.
Correct. And so, but you can just go at it, keep on coming up a little bit, and then once you get to here, you can release a little bit. So now the other person has to pull from the other side to help. Correct. Because you want 3-point. Yeah. So here's your zygoma. So you don't want to go underneath the zygomaticus major. Now also this is in your way here. So you can open this up a little. If you lift up the skin there, you'll see the edge of the platysma in the neck, and you could just follow it and just follow on top of this fascia. And so to release a little bit more, to give yourself a little bit more room. So yeah, so that's good, the way you're holding it up. So now you could take your, correct, and follow that. And so open that up a little bit further. And a great trick is lifting the tissue and dropping it, and you'll start to see where you should go with your instrument. You'll see where the plane is. So keep on doing what you're doing. You can take this down right through here. Okay. Yep. Yep. And then here. You see how when I do that helps? You see the difference? You can see exactly where you need to. Right there. Exactly. You see that? That's the perfect spot. Right. Exactly. Right. Get the counter traction. Perfect. Perfect. The other thing is, don't let your assistant let up without you knowing. Good. Now you stop for a second, and then feel your thickness. Is your thickness similar to where you established the flap over the masseter? Because if your thickness is the same, you're okay. And you'll pick up if you're getting too thick. Because if you notice, when I was dissecting, I couldn't see well. I just kept on stopping and feeling. So
That's good trick.
Yeah, because you'll never go too far. And let's say you're making a mistake and you're getting too deep. You're not going to go too far. And it's very uncommon you're going to do one thing once and cut something. It's when you don't recognize you're too deep and you keep on going there. That's when you get into trouble. So, yeah.
Yes, exactly.
Right.
It's thick enough.
Right.
And I can see the fascia.
Correct. So now you can look at whatever you want. Like sometimes I'm releasing this only because I don't want to get into a tunnel. Right. So I'll start to release, around me so I don't just dissect in one tunnel. So if you want to take down the ZM, the zygomatic, the ligament. So here's the orbicularis. Right. And then pull in the corner of the mouth. Right. There you go. Good. Good. Great. And you want to go from superior to inferior because the nerve is coming from underneath. Is coming inferior underneath the muscle.
Right here is the zygomatic.
Yeah, correct. It's right there.
Okay.
See? Now, but then you stop and feel and say, okay, you're almost getting too deep. You're okay. But you see here, if you feel this and you feel past it, you just cut the beginning of the fascia of the muscle. But it's okay, you didn't do much. But if you continued, so feel here, see how this, yeah. Feel here, this is thicker now than this is.
Absolutely.
See?
Correct.
Now, so you see that what you did here was fine, just stop. You don't want to go deeper now.
All right.
So now get a little superficial on top. It's okay to have fat down. Right. Right, so you're reestablishing a different plane of dissection because you got a little bit too deep there, which is okay. It's only if you don't recognize it.
Right.
That's okay. And cadavers are harder than people. So you recognize that. I felt it. It's tough to see it in a cadaver. I felt it. It felt a little thick, and I saw a little fascial edge. You got a little bit deep. The same way when I was in here in the cadaver, I saw a little piece of fat pop out that I know is deep fat. Just adjusted. My next sweep was a little more superficial. You just have to recognize it. And if you're not sure, go by the thickness of the face.
Can I ask you a question?
Sure.
If you just like ride the zygoma,
Yeah.
straight medial,
Yeah.
you're safe.
If you theoretically, but it matters if you get a little bit too deep. Like when you're riding on the zygoma, you can start to cut through the insertion if you're not observing your thickness.
Okay.
Because this is the area, although people focus over the masseter, that's the easy part. It's over the zygoma because there's no obvious plane. So that's why over the zygoma,
So you can leave a little fat down
on the yes,
but as long as you're
on the ZM.
on the zygoma.
As long as you're on the zygomaticus major, you're fine, and you definitely will leave a little bit of fat on it because you almost don't want to take off the fascia that's on the muscle.
Okay.
So leaving a little fat is totally fine.
This is the question that always comes.
Sure.
Extent of release is by feel, not by a metric.
It's not by a metric. Feel the face and how it's moving. Look at how bad are the nasolabial folds. And a lot of times you don't have to go to the modiolus because once you pass the ligament and you dissect it some, you feel the face, everything's moving really easy, you're fine. If they have a bad nasolabial fold, you want to be more aggressive and go more medial. And every once in a while, if I'm not sure, I'll have my assistant stop retracting and I see the way the tissue bounces, and a lot of times I'll see, oh, the plane's right there. So I'll shift it a little bit. Good.
Well, that trick of feeling the thickness is really important.
Yeah.
And the smoothness of the muscle
Yeah.
underneath.
That's how you know, because when I started, I felt the underbelly of the flap was smooth. So even though I couldn't see the platysma because it doesn't have any color, it's a cadaver, I knew I was under the platysma because fat is not smooth, but the muscle is smooth.
Recap. On the zygoma, leave a little fat on the muscle.
Yeah.
Take
Correct.
the extent to where you get the most movement and
Correct.
placement of the nasolabial fold.
Correct.
And it's different in everybody.
Correct. That's exactly it. And if you're, and my point is that if you guys are doing it you haven't really done it. If you're a little superficial here, it's still a great facelift as long as you connect up the flaps, because the whole power of the face is here.
Right.
So don't lose the forest for the trees. You don't have to do it at my level or Mike's level when I came out in 1996, I was the only one doing deep plane, and it was better than anything else that was out there. And there was no such thing as advanced deep plane. There was no cervical ligament release. This was just a bare procedure then, and it was still more powerful. Do you see how much that tissue moves? And that's really what you got to do. You just look at aging as just a big soft tissue reduction procedure. That's all it is. You're taking a baggy pair of pants and making them fit. That's all you're doing. It's really not that complicated. We talk about vectors and all this stuff. I'm like, we're just tailors. We're just opening up the seams. We're taking away the extra fabric, and if the pants fit, you're fine. Yeah. Now, what happens is when you tent this up, and you tent this up, you'll see the edge of the platysma. Yeah, that's great. And you just follow this. And you can, whatever instrument you want, and then you release this as much as you need to see how much the neck will move. Now, in somebody with very compliant soft tissue, you could not have to do a lot, and you can move everything down at the sternal notch. Somebody with a stiff face that's non-compliant, you got to release more to get to your end point. If their aging changes are more toward the sternal notch, you need to release more. If they're not, you need to release less. Yeah. And over there, it's a ligament, so that you have to cut that. Correct. So those are the cervical ligaments.
Right here.
Yeah. So, and a matter of fact, you go like this because there's no ligament here, so this is easy to dissect. And then you see, if you go like this, you'll see it's right here, and just follow this, whatever instrument you want. And by the way, nobody uses a 10 blade in a deep plane but me, so don't ever think you should do that. Don't. Yeah, just don't. Yeah, but it's a cadaver. You could be bold there. So, but you see here, I'm also giving you traction here. Yeah, there you go. And now you're gonna have to cut some of that because it's ligament.
Like here.
Yeah, there you go. Right. There you go. And then you feel. See? Look.
Oh, perfect.
See? Now you're in the right spot. Now, again, feel your thickness. So right here, you're perfect. Feel this, what this feels like right where my thumb is. Feel how smooth that is. You see what that feels like? That's what you want to feel. That's exactly what you want to feel. Get all the way under there. You feel the smooth? See how it's different from feeling the fat? The fat is cobblestoney, the muscle's smooth. So even if you can't see, like let's say they have radius at the angle of the mandible, and they had energy treatments, and everything's glued, you'll be able to tell by feel. So much of this surgery I do by feel. So that should be difficult because that's ligament. But once you pass the ligament, you see it's easy because there's really, and now what you've done is you've made your face and your neck one flap, which allows you to move the whole neck by lifting the lower face. Now, a lot of times,
I prefer not to cut, but to spread the seams.
yeah, correct. Most people would spread here. You'd be amazed. Like I can use my fingers there, and a lot of times I could be very gentle with my fingers. And another trick, I'll show you something. When you're in an area where you want to be forceful with your finger, watch. I will do this. If I want to dissect, let's say over here, I will go like this with my finger. I'll roll it. Because I'm rolling, so I'm using a force, but I'm rolling my finger, so it's not, I can't tear something with that. So if I'm here and I want to do this, I'll go like this. I'll roll my finger, and then you look. Watch. Look, she's got the muscle right here. Look, that's a perfect, see? Because you got it in the right plane, and then I just bluntly dissected it, and I was using force by rolling my finger.
Excellent.
So it's just, these are little tricks. Yeah. Now also do one other thing while you're here. Notice where the ZM, zygomaticus major, is taking off, and where the body is. You see how if you feel the edge of the body and you go up about a centimeter, that's where the takeoff is. So let's say you're over here and you're not sure. I feel this, I know it's going to be right here because I don't want to delaminate this. I don't want to make a pocket up here.
But do you think that here we have more ligaments here?
Well, this is your masseter cutaneous ligament.
It's not completely free.
Correct.
It's free,
Correct.
there.
So the segment ligament's not
There,
released.
George.
What's that?
The ligament's not.
Well, this is released, but it goes down the whole inferior border.
Okay.
Has ligamentous attachments.
Over here. Over here. You have to
Right. And do counter traction.
This is to this. No.
And now you know you're playing.
Does you play? Do you play George? Wait, let me show you.
But get counter traction. There you go.
Because of the traction right here.
Right.
If you feel the thickness, get the thickness right here.
Right.
This is the ligament.
And what you're at now is the masseter cutaneous ligaments, which on women, you can just roll your finger and it just releases. On men, sometimes you cut it. It's a minor ligament. Now, let's say you make a swipe and you see fat pop out. You just cut through the fascia. It's not a problem. Just notice it and readjust. Yeah, just get a little more superficial. Or sometimes I've done it and I just sweep the fascia down off my flap. It's only not recognizing it that's the problem. And you need to get past the masseter cutaneous ligament because now you're exposing buccal fat. You know, a lot of times in the cadavers, the buccal fat's pretty atrophic. Now, you don't have to go far out there because you don't want to go by the facial artery. Now, another important thing, if for any reason you bang around the facial artery or the labial arteries and they bleed, do not cauterize them. Leave them alone. They're arteries. They're going to clamp down, pack it off, put pressure on it, it'll stop. That's because the nerves run right there. So, and you can, sometimes you get a revision or you get a little bit aggressive and all of a sudden the labial will bleed, or if you get into the facial a little bit, don't cauterize it, just pack it off.
Perfect.
Yeah.
Excellent. I think the dissection is pretty good.
Yeah, no, it's a very good dissection.
Here, you want to free up the...
Well, so here, where's your angle? So here's the angle, okay? So you made it, when you enter posterior to the angle, you make it a little more difficult on yourself because you're on the parotid and there's no plane there. And you know that, so let's say you enter a little bit more lateral than you needed. It's not a negative, it's just you'll see that you're trying to enter the deep plane and it won't open. I must be on parotid. But just keep on moving forward. Keep on moving forward. And all of a sudden, the plane will open once you get past the parotid. Because sometimes they have an island of parotid on their masseter. They can have aberrant pieces of parotid on their masseter, and you know that because the plane won't open. And if you see a little bit of parotid, readjust. So none of these things are bad things. It's only if you don't pick them up. Then, so here, now let's look. So here, by entering laterally, look what you could do, where your flap's going to inset. So that's going to allow you to be incredibly aggressive here, move the whole face, and once you've gotten, because remember, this is the strongest part of the face. This is the only area where smazes and the lateral band of septae attach. This can handle huge amounts of tension without distorting the surface. So that's where you're going to lift the face and the neck, and it's relatively vertical. It doesn't have to be perfectly vertical. What you don't want with your flap is your fixation suture inferiorly to be more posterior than the one above it, because you'll angle your flap.
Right.
So the irony is that what you soon find out is the dissection's easy, the flap's hard. Because the more you move the tissue, you have so much soft tissue, and if they have no hair, where are you going to put stuff? So here, this you could put huge amount of force on. Look, the whole cheek pad comes up. But once you get to here, you want to angulate so you get a fixation point underneath hair, so you don't have naked fixation in the temporal area. And that's why the original deep plane description, which had this as an entry point, was wrong, because this point would never move far enough. And that's why, if you look at whether it's Andrew's videos or whatever.
That's why you're going to use the cable suture.
Yes. That's why. But that was causing, which caused the face to fail, which is why he started doing the platysma back cut. Because when the face fails, it fails in the neck. The face, when you don't lift the face, because watch. Yeah. So a lot of platysma band recurrences are because you didn't lift the face.
So you don't do the lateral myotomy?
No, because we want to use the fact. Yeah, because right. If the minute you cut this, when you lift this, it won't move this anymore.
We don't want cable suture.
No, you want tight sutures. You want to.
But I mean the continuity between the platysma and the
Correct.
smash, you keep,
Correct.
You keep the continuity.
Right, because
you don't do the myotomy.
No.
So you have.
Because even a myotomy would move this way. I'm moving it this way.
And that's the way nature is anyway.
Correct. And you saw even on the cadaver how evenly the flap laid out, and you're respecting the way the tissue wants to move. And this is really one unit.
Exactly.
We call this the neck. We call this the lower face and the mid face. And the deep neck is the deep neck. It doesn't matter what facelift technique you do. The deep neck is its own issue. But this is really all one unit. And if you think of it as one thing, just take anybody to the mirror and lift their lower face and their neck comes
It
up.
makes sense to keep it as a unit.
We keep it as a unit.
As they are units instead of
And that's
making the
you're-
cut over here.
No.
Keep it as a unit. I think it makes a lot
it's
of
the
sense.
so it was only because that the original entry point created transition problems that the only solution was leaving cable sutures, which didn't lift the face, which caused the neck to fail. They thought of it was a neck problem, so they cut the platysma and tack it up here. But those faces still would fail. They would fail.
So once he started doing the Roski thing,
Yeah.
because he did that myotomy that Andrew does for a
Right.
while, and then that's where we saw failure here.
Right. That's exactly why.
Right. And now with this staying intact, there's no way for this to fail, right?
Yep.
Okay.
Yeah. And you can see how much traction you could put on that flap. That this flap, this is the area, and that's in my paper. This is embryologically the strongest area of the face, because this is an anchor for essentially food acquisition and facial expression. Remember, if you saw all this food 100,000 years ago, you got to be able to shove it in your mouth. So that's why this is a rubber band. This is made to distend and recoil. The only way that can happen is if there is a strong fixation here. So in my paper, I have a picture of Dizzy Gillespie. And if you look at the picture of Dizzy Gillespie playing the trumpet, you see how the face is designed.
Yeah.
All the pressure causes his cheeks to come out to here, but this doesn't move. This doesn't move and doesn't distort because this is so strong. So that's why the first suture should be here. That's why you wanted not to delaminate, because the minute you delaminate, you have a rubber band for a skin flap, and there is no such thing as a mobile smaz. There's no smaz here. So the reason why that's mobile is because your cheeks need to expand. If you actually had an aponeurosis here, your cheeks would tear. You wouldn't be able to expand you wouldn't be able to do that. So that's why it made no sense when they said the smaz was one sheet. No, these are all anchor points to allow this to distort. And that's, if you go into the evolution of the face and understand the functions of how the face is designed, then it makes sense how it ages. And then it makes sense biomechanically, what areas do you want to take advantage? So when they say, well, we want to be closer to this, the advantage of the force you can apply to this outweighs being closer to the point. That's why you saw how much soft tissue we move. I mean, that's why the flap's the problem. The problem is the flap because you've moved all this soft tissue and we look, where am I going to put it?
Why do you see horizontal lengthening of the lips like bad faceless?
Because once you delaminate, you basically, that skin flap creates distortion. Now, if you look at, so the soft tissue, we know as layers. You have the retinaculus cutum, which is from the first branchial arch. That's a scaffolding in a lattice. When you delaminate, you cut that in half, and you cut the natural scaffolding in half, and that's what helps to create a facelift look. Because the tension is superficial. Whereas if a composite flap, the tension here doesn't distort anything. That's why this is where you want to put the tension.
The flap is stronger as well.
It's stronger, you can move the tissue without creating distortion. That's why after I put first 3 or 4 sutures in, I don't need to lift anymore. Now I want to transition from the mid-face to the temple area. That's why suture, 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 my arc of my flap. So now I've not delaminated the flap and lost the biomechanical advantage, but still respected the fact you got to change vectors, and you didn't have to delaminate to change the vectors. Because you see how, like, if you're just moving the flap here, this is what's going to happen. But if you do a couple here, then you arc it at the end, because you've already lifted everything, see? You don't have to lift anymore at that point, because the value of getting this to lay this way, you can manage this. You can't manage this. You're not going to manage that. That's going to be a bad facelift. That's why they left loose sutures. Okay? Hope it was helpful. All right, guys.
Thank you very much.
All right. Okay.
We'd like to have you here.
Yeah, sure.
So, in the platismo, you only do medial myotomies in case of active bands, I imagine.
Yeah, I don't really deal with these active bands as such an issue. What I do, I really don't have to do very aggressive neck work. So midline, what I will do is I will take whatever is naturally redundant of the platysma. I'll go subplatysmal. I'll see that. I actually like an incision in the crease because it's already a crease. So I know, but it's already a crease. It's the easiest place to hide it. It's a crease. So whereas here, if you look at it when it ages, it'll scallop. So it's a natural place for an incision. So I actually don't agree with, but that's okay. I mean, everybody has a right to their opinions, and there's no perfect way. So I try to use a little incision. And so I could treat everything, but if I want to treat the gland, I can't use this little incision. And when I tell the patient that, do you know 90% of the time they say leave the gland alone? They will not trade off the bigger incision in my practice. And I can get to everything from a little incision. And I can get to the gland, but I can't control it because I'm in a tunnel, and I can't get instruments into there to actually, you know.
So they'll accept that little bit of residual fullness versus.
That's why in my lecture I said, what matters is the frontal view. If they have a big gland, but it's not obvious in the frontal view, they don't care. If it is in the frontal view, you got to deal with it. But you'd be amazed that most of the faces I do, we really don't have to. And now, if we have somebody who's flying to us and leaving in 12 days, I can manage this big flap. I can't have management issues of these people after 2 weeks. So that's why I'm very pragmatic, because what we're doing is so aggressive already, but it's a flap. The flaps heal quickly.
So even with the ligature, you're still seeing semiomas?
Well, it's more of a subtle leakiness that creates a boggy neck. It's not like a frank collection always. It's just that gland will leak. And no matter what you do, and it creates a bogginess in the neck. And they're calling about it and stuff. And it just doesn't, you know, if you're doing somebody who's on television, you're doing somebody who's in the movie, or somebody who's running a giant company, or, you know, they're like, they don't want to deal with anything. But they don't want a failed facelift either. So that's why what you're trying to do is be as aggressive as you can for the things that are predictable. And when you get to areas that are not predictable, be very careful what you do for an extra 3% of a result. Because this is as aggressive as it gets. I mean, we're gloving the whole face. We're aggressively moving the flap. Those sutures should be tight. And we're trying to get rid of all the soft tissue that we can that's redundant everywhere in the face. But that's, you know, I always say you have to understand your own demographic, your own practice, where you live, where your patients are from, and you have to do for where we are, essentially Manhattan, outside of Manhattan based. I just had it. We just said this week we had two billionaires, and we tell them 2 weeks. On day 10, they're like, we have to get out of here. I got to take my plane to Europe. I have a business deal, etc. So we told you 2 weeks. He's like, well, I don't have 2 weeks. So we're trying to get the sutures out. We put him in a hyperbaric chamber just so we can get the sutures out a couple of days early. So as amazing as it sounds for something that's a life event, the minute you cross 2 weeks with a recovery, you're going to drop off on who's going to book with you. You'll have people say, I'd love it, but I don't have a month. So that's why there's things we don't do. There's things we don't do.
What the patient shows to their relatives and friends.
Absolutely. That's why I was showing you the day after photos. You took the whole face off, and the next day they don't have a bruise. Their friends don't know you took their whole face off. They know if I look like that the next day, I could do that.
Yeah.
But when I showed,
if the patient looks like a monster.
yeah, and have a net, and the net scares people. You know.
Even if the final result will be
Correct.
3% more.
Yep.
In 3 or 6 months, it's not of value.
The minute it takes that long, you will drop off. You'll have 80% of your people say, I just can't do it. By the way, if I said to you, I have a fabulous thing for you, you will love it for the rest of your life, but you have to stop working for 6 weeks. Could you do it? Could you do it? So if we can't do it, why do you think the patients can do it? Who are our patients? You want the people that are successful people. They're busy. So that's why today's lecture was not just about this is great, that's great. It's like, how do you balance? You can't underdo the work either because it'll fail. So how do you be aggressive in areas that are predictable and be very pragmatic? And it's not that I'm against these techniques. I just know the minute you start squirting fat in face, there's no way they're looking good in 2 weeks. The minute you need a canthoplasty, no way that's going to look good quickly. So we manage those things very carefully. And the other part is what we do here with the parotid, because parotid hypertrophy, first you do is you take off the fat here, but do not take off the fascia of the parotid gland, and take a bipolar, and you can create a whole gonial angle because the fascia will shrink the parotid down. And then, because we need to sew the flap on the fascia, and you can carve this all out with a bipolar. And you don't even have to take off the tail. Okay? All right, guys. All right, my pleasure. Well, that's why I was, yes, but it's because you here. Yeah. Well, this is okay. Yeah. This is okay. And then when you look there, here's the body of the zygoma. About 1 centimeter superior is the root of the zygomaticus major. And then you look at where the corner of the mouth is. And then you'll see, do you have a retractor? Sure. So here, if you pull there, here you're right on the muscle, see? So sweep this down, and you'll release the muscle, because the muscle, you got, here look, here's the root of the here it is, here's the root, right here, the muscle. This is the root, so this is fine. And it's normal and appropriate to have fat left on the zygomaticus major. You don't have to get it down to the muscle fibers, because you actually want to leave the fascia on it. But here, if he pulls in the corner of the mouth, just keep on taking this down. Now, once you pass the major part of the ligament, you can bluntly dissect a lot of it. But now, if you can't, because you're still on ligament, so just take your scissors and continue where you are. You're doing well. And just pull the corner of the mouth. Right. It's really important to use your assistants. The other thing I'll do is, let's say my assistant is retracting, and I just want to see how the tissue is. I'll say, let go. And I'll see how the tissue bounces, and you can see the plane sometimes by just bouncing the tissue. So I'll do this. I'll say, you pull. Okay, let go. Now pull again. Now I can see it. It's right here. And I can see the spot I need to be. Now, if you start to see a little muscle fibers in your flap, you're getting too deep. Okay? Now, what I do, I understand why people spread, but I would take the scissors. This is, even though I use a knife, but nobody on the planet uses a knife. But I would just just keep that like almost like it's a peanut. And just go like that. Because the spreading could cause, I think, more problems. And you pull in the corner of the mouth. See? You can see where you need to be. and then feel. Now watch. Use your finger there even. See it's starting to dissect? Once you pass the ligament, a lot of times you can get it to dissect.
Yeah, it's soft.
See?
Yeah, sure. It's soft now.
Right, because you passed the ligament. There's ligamentous attachments on the inferior border of the zygomaticus major. They're minor, but you can see once you're there. And also, let's say it's not dissecting easy and I want to use more force. I'll take my finger and I'll actually push harder, but I'll roll it because it makes my finger a rounded edge. So I can put more force with my finger. So I've just gotten used to using my hands for the surgery. I'm always feeling the thickness of my flap. I can be aggressive with my finger. You know what it should feel like. And then I'm keep on feeling my thickness. And so this is, you've done well. And then here's the corner. You could take this as down. Now you could go back to using instruments. Sometimes you can't release it anymore, but look what you did. Pull that. See, here it is right here. And then whatever is still, ligamentously attached or fibrously attached, you take that down. And then you won't, if you don't dissect over, if you don't do a FAME, you're not going to get the periorbital edema. Because it's real. And when people get it, I showed one on a slide. And this was, the surgeon who did it has a fellowship. He's a good surgeon. He just was aggressive over the orbicularis, and she was 6 months out, and she had bad periorbital edema, and she was miserable. And the more stuff he did to it, the worse it got.
So what causes this deep depression that you see with some of the deep planes?
I've never seen, if you know how to do a deep plane, the problem right now, to be frank, is many people are calling whatever they do a deep plane. The minute you delaminate past here, it's not a deep plane anymore. It's a sub-SMAS. There's two aspects that make a deep plane. One being sub-SMAS and not delaminating, where the fibrous attachments of the lateral septae attach to the SMAS here. Because that's what creates the biomechanical effect that allows you to move the flap without creating any torsion on the surface. That's why you saw when I did the Cadaver didn't have any. There was no superficial irregularities. So it's only when, because the skin flap, the retinaculum cutis is a scaffolding that goes from the dermis all the way down to the fascia. When you delaminate, you're cutting that scaffolding in half. And it loses, the scaffolding is what allows the skin and superficial soft tissue to slide, glide, and distort and recoil. Once you delaminate, you cut that scaffolding in half, and that's when you start to get pull lines and things like that. So you have to keep that native structure intact. So that's why and the structure where it's biomechanically the strongest is right here. This is the only place there's SMAS. There is no SMAS here, which makes sense because if there was a big bucket of cookies there and we were hungry and you knew I was going to get to it before you could get, and you got it to it before me, and you went to shove all the cookies in your mouth, your cheeks have to be able to extend, right? For food acquisition. But then afterwards, they have to recoil. So the design of the face, if you look at a picture of Dizzy Gillespie, the trumpeter, you'll understand how the face is designed because he's putting extreme force. This area, once you pass this area, is made to distort and recoil. It's a rubber band. There is no such thing as a mobile SMAS. That's the paratomasseteric fascia, and it's full of elastic tissue. So it allows your cheeks to go all the way out, food acquisition, and recoil. But the rest of the face needs to be anchored. So if you look at the picture of the trumpeter, no matter how much force and his cheeks are out to here, this doesn't even move. Doesn't even move. That's why this is the only place of the face where you have the lateral band of septae that connect directly to SMAS. And that's the anchor of the face, which is why it can withstand all of that force and not distort. So that's why you don't want to delaminate. Now, up here, the reason you don't want to delaminate is for flap management. The secondary gain is they don't bruise and they don't get hematomas. But the real point of why I changed this in the year 2000 is Hammer's original description of entering here was flawed because this point will never come all the way out to here. So you had a fixation here, and you couldn't layer that out. So their solution to it was cable sutures, which defeated the point of the lift, which would fail in the neck, which is why Jacona started doing a platysma back cut, because the face was not failing in the face, it was failing in the neck. That's why when I write, I say the face and the neck are the same thing. The superficial face and superficial neck are the same thing. That's why if this is all connected as one flap, you lift here, the whole neck comes up. And there's very little direct neck work I have to do to the superficial neck, because it's all one unit. We've artificially called this either upper phase, lower phase, mid phase, or neck, but it's all the same thing. You take somebody in the mirror. If you lift their face where the masseter is, lift up, the whole neck comes up. If you go behind the ear, the neck doesn't move. So the advantage of the cervical ligament release is not to move the platysma backwards, is to move the platysma up. And then once you've done this with a couple of sutures, now your issue is how do you prevent this? And that's why you start to rotate the flap at this point, because you've lifted everything. That's why my pattern of suture fixation, I had it in my video, but we didn't have time to show the video. I was showing how I do the flap. So early on in doing deep planes, the challenge is the dissection. You'll get the dissection. The challenge is a flap. So the reason in the year 2000 I changed the entry point to a lateral entry point is to have control over your flap. You can put your flap anywhere you want because you have deep plane to suture anywhere you want. And I realized I needed a fixation point close to the ear. This wouldn't allow me. And I didn't want to leave loose sutures because it defeats the point of the lift. So I changed that in the year 2000. I just didn't name it anything.
And you leave it just 1.5 centimeters from the border of the ear, right?
Well, what I do is you have to think, if the face is thicker, you got to trim it down. Now, when you move the flap and there's extra deep plane, your sutures are here. You cut away the extra deep plane you don't need. So you can never err by being too lateral. You can only err by being too medial. Yeah, because that's why they're suturing at the edge of the flap, because you can't go any more lateral than that. So let's say you misjudge and you enter too lateral and the whole deep plane is going over the ear. Just cut it away. You don't need it. It's giving you options of where you could fixate and how you want to angle your flap. It's controlling how you want to use your vectors. Like if somebody has only hair out to here, you got to enter really lateral to get this to go to there. If somebody has a stiff face, if they're a revision. So the reason I changed the entry point really had to do with revisions. I was doing SMAS revisions at the beginning of my career. You'd open this up, everything would pull away. I needed to get a fixation point close to the ear, which means I had to enter so far lateral because I had big soft tissue deficit and recruit tissue. And that's why I changed the entry point. I know I did it in 2000. The latest was 2000 because we just redid a face from 2000 and I see her sutures were right here. Yeah. And so when I did this, the preservation aspect was just the secondary gain. It was the flap management was the primary reason to do it. And that's not in anybody's papers. It's in a couple of my papers. But yes, preservation, you're not going to get hematomas and things like that. But the real power of it was controlling your flap and not having to leave loose sutures to manage it.
So you recruit it. That's why if you go too medial,
yeah,
then the tension is too...
Well, if you go too medial, you can't, if you're aggressive with your suturing, your flap, you're going to get this.
Right.
That's the problem.
Yeah.
The more you move this, the more where you're going to put it. And you see how much tissue we move. I mean, we have a lot of tissue that gets moved. So you're trying to manage this amount of tissue in this amount of space. And that's why you need to be able to have points of fixation that if you have this, the only way you get rid of this is if you had an incision above it to layer that out. But there's no place you're not going to have an incision here. So the only way you can manage this, here's where your horizontal incision is. It's where the temporal hair is. So I got to get my flap underneath that. So because if I move my flap like this, I got this problem. If I move my flap like this, but then arc it, now I can manage that. I can't manage this. So that's why the art is the flap.
So when you lift your flap over the nerve, you don't worry about that at
Well, it's not over the nerve because your flap is lateral. It's,
Over here, it's crossing
no.
Taney's line.
Well, your dissection is crossing,
Yes.
not your flap. Your flap is fixated out here, but your dissection is.
So when you're dissecting this part
Yeah.
here,
I just fillet it. Yeah. This fascia, there's a layer. There's the same deep fascia protecting the nerve. It's the same thing. You feel. Because what you want is a cuff of tissue, and that cuff is not that strong. That's why the lifting is coming from down here. This is just an anchor point to layer it out. If you have somebody that has very elastic, stretchy, soft tissue, you need a point of fixation very close to your incision because of Hooke's law. The only way you could achieve it is if you had a very lateral entry point. So that's where that was developed, 25 years ago.
And do you use a straight line to go inside, or do you do a pattern also?
Well, it's basically, it's relatively straight. Yeah, so here I would say, okay, so let's say this is where their hair ends. I'd feel their face, see how redundant they are. This will be standard. And then I would look, and let's say I would enter here, and then this would come like that. Because I want this point to come under here. And then what I do is I'll open this up and just define the edge of the orbicularis. I won't delaminate that. And here, I've got the thickness of my face. This will be a little thinner. And, you're just careful. You have somebody give counter traction, and you could see, I just take the 10 blade and fillet it, make it nice and even until I get to this point here. And that's what gives me that cuff to sew to when I move that flap. Now, let's say the hairline was all the way out here. I wouldn't have to be this far lateral. I could be over here. But I'm always more lateral than hammer. But this will vary. That's why when Ben wrote The Sailboat, he figured out afterwards I'd already published this, but I didn't call it anything. I called it a lateral entry point. But it's not static. It varies based on the face. Sometimes it's a little more lateral. Sometimes it's a little more medial. It's always much more, it's never this anymore. It could be this. It could be this. This stays the same. And that's your entry point based on, so your dissection, when you're doing your dissection, you're already thinking of your flap closure. You're designing your flap based on how you want to close it, knowing where your flap's going to go. And that's why I say get used to feeling the face. Feel how much redundancy there is. Feel where it is. See how the face moves. And you'll see, this is a stiff face. It's not going to move a lot. I need to be more lateral. Or this is a thick, heavy face. It's really compliant. I can be a little more medial. Because let's say the edge of my flap, my deep flap is all the way out here. I don't have to suture at the edge. I can suture anywhere I want. So if here's the edge of your flap, I don't have to suture at the edge. I can suture all the way over here if I wanted to. Where I'm going to place my suture is where I want my suture to end up. And then what I'll do, I bring this down, I take away the fat, expose the parotid fascia, and then I carve out the whole preauricular space and gonial angle by bipolaring the parotid fascia and shrink the whole parotid down. And then I don't have to take the parotid out, and I don't have to worry about saliva leaking. And you could really carve that down pretty well.
Flap management.
It's all flap management. I'm saying, at first, when you start, it's a dissection. And then you realize the dissection you could do. So when I see revisions from very good surgeons, it's always flap management. They didn't screw up the dissection. Or the dissection was only wrong because they didn't dissect in a way that allowed them to manage the flap appropriately. It's always a flap management issue.
And what would you say is the most common mistake?
The common mistake,
The vector of the pool?
or that they were too medial in their entry point,
Right.
and now or then the left cable sutures, then the facelift just fails. Then a year and a half later, they need another facelift. Or they created bunching here. And that's why this tissue moves so well. That's why we need to do their forehead with it. That's why yeah.
If they go too medial and you come back, you can go more lateral.
Yeah, because I just redo it. You just redo it. And then what happens is the scar tissue reestablishes the majority of the structure. They're easy to fix because usually they have a pixie ear because there's a SMAS lift. And a SMAS lift because you have two you took one composite flap that had huge advantages and now you made it to two crappy flaps. You have one flap that's a skin flap, which is a rubber band, right? Your cheeks go like this, and then they go right back. You can't tighten a rubber band. It's just gonna go right back to where it was. And what you call the mobile SMAS is not SMAS. It's basically deep fascia, and it's got a lot of elastic tissue, and it's very friable. So you can't put force on the deep flap, and your superficial flap is totally gonna creep. It's only to distort. So you really can't move tissue. That's why you can't delaminate. The lack of delamination, yes, you will make patients look good quicker and they won't have complications. That's not the reason I changed it. It's because you can harness the power of the flap by not delaminating it. This is where you want to keep it not delaminated. And that's why I said, just look at a picture of the trumpeter. So when deep planes, I redo deep planes because they had loose sutures. And as I said, my sneakers aren't loose, your belt isn't loose. I mean, it's delusional that people think they do. Also, ligaments are holding things up. If you release a ligament and you don't move the tissue, you'll make it worse. Like when you release the cervical ligaments, the platysmal will go forward. Ligaments are holding things up. So, this concept of I could release and not do anything is delusional. The release is allowing you to move the tissue. You make it really simple. It's just a big soft tissue reduction procedure. The whole face. It's not about anything else. Youth is the soft tissue, fits your bone structure like a fitted pair of pants. Aging is your pants are made of leather, they're elastic, and you're just a baggy pair of pants. And we're just tailors. We're just degloving the whole face, taking advantage of the biomechanics of how the face was designed embryologically based on its evolutionary function, moving the tissue as much as you can, get rid of as much of the extra everywhere in the face. Same with the forehead. I'm not trying to position their eyebrows. I'm trying to get rid of the soft tissue redundancy that's there and leave the arcus marginalis intact and our eyebrows restore without even trying to design them. So if you just look at it as a big soft tissue reduction procedure and take advantage of the embryology of the face and be aggressive in moving a flap because it doesn't distort by doing that. That's why you saw when I did the cadaver. I mean, the cadaver didn't distort at all, and that's a cadaver. So, and then it just becomes management of all the redundancy. When you don't move the soft tissue, that's when they start to talk about, I like this vector or that vector. Like when you see in SMAS procedures, they're like, well, I really want to lift this, so I'm putting a suture here and I'm going to imbricate like this. If they really move the tissue, they should get bunching here. But they don't. Why? Because it goes right back. Like mobile SMAS, because the face is designed to distort. If you had an aponeurosis over your cheek, you would never be able to do this.
Yeah, it would be stiff.
It'd be too stiff. Yeah. It would tear or be too stiff. So that's why when Minnelli wrote about where the SMAS was and where it wasn't, I was like, has anybody looked at a picture of a trumpeter? It's pretty obvious there's no SMAS here. Like, get away from looking at the dissections, look at the function. And so when I studied the evolution and the embryology of the face, the minute you understand that once we became primates, you had multiple functions. You had nonverbal animation, you had vocalization, mastication, and food acquisition. And you can see the evolution of the face from fish, which is why you have the first arch, and then the second arch incorporates into the first arch, and that's why you needed a plane, because you had to separate mastication from food acquisition and facial expression, right? You could chew and move your face. You can only do that if there was a plane that separated those functions. Fish don't have a plane because they don't have facial expression. So their retinaculum cutis is glued right down on their deep structures. We as primates have separation of function. And that's why this is susceptible to gravity, because it can't be fixed on anything and it's got to be elastic. So this behaves like a rubber band. So that's why the only place that it doesn't behave like a rubber band is if you don't delaminate and take advantage of the strength of this area to move all the soft tissue. So even if theoretically you'd rather pull a little here, this is a rubber band, they'll never stay. This is the place you can really put the force on. And that's essentially why a deep plane works. And that's why a sub-SMAS dissection isn't the only thing if it delaminates. Once you see people delaminating to here, and then they go sub-smaz, it's just a sub-smaz smaz. You've literally broken a sandwich. Think of the design of a peanut butter and jelly sandwich. You could take it by the bottom bread and move the whole sandwich and the top bread doesn't distort. If you take off the top bread and separate from the bottom bread, you have two separate layers that don't influence each other. That's how I explained it to consults. A deep plane facelift, I have a pad, and I said, look, this is a deep plane. You're a sandwich. You have peanut butter and jelly, top bread and bottom bread. I lift up the top. I go, you can't really grab peanut butter and jelly. It doesn't do much, right? Now you're pulling on it. Okay. Deep plane, take the whole sandwich from underneath. Now move it anywhere you want. The surface doesn't change tone. And then they understand it. So that's why the deep plane works, and that's why the procedure, in my view, and things I've written about, should be done in this manner, because that gives you the best ability to create outcomes that will hold up over time, but yet recover quickly at the same time.
Do you feel in male patients you have to be more aggressive with your traction? Or do you
No, sometimes you have a problem because you can't do their forehead and they have no hair.
Right.
So I often don't even dissect this. And what I'll do is, I don't want to move this tissue because I got no place to put it. So I'll change my dissection. So I'll just release the ligament a little. I will not open this up. And I'll come down lower through here. And then I'll arc my flap a little differently because I don't want to move too much tissue to the temporal area because I got no place to put it. They have a recessed temporal hairline. You can't do their forehead, they're bald. So that's all flap management, man.
And that way you get what they want, which is the...
Correct, the neck. Correct. And if a guy complains about his nasolabial folds, saying, well, it's not that I can't do it, and I'll take him in the mirror and go, look, that's going to move to here. I would need an incision right over here. And we actually do that sometimes. It's called an anterior extension because it actually heals very well. But then they understand it. So you can communicate with them in the mirror. So with the male, I'll change my dissection and I'll change my vectors a little bit, because what's the point of bringing all this tissue in here? You get no place to put it. Because if you mismanage the flap, to the consumer, it's a bad facelift. Like, they don't know that you did a great dissection. They don't really care. They just know it doesn't look right. And managing these issues, the difference of something being invisible versus, yeah, you did a beautiful dissection, but the face looks unnatural because it's bunching and pleating. I mean, we see so many celebrities. I showed in my slides, celebrities going, this guy did a smaz here, cored out the deep neck. She's lifted here, and she's like this, and her cheek pad's hanging over here. It's hanging right over the rest of her face. So, but that's some of the insights into this stuff.
That's awesome. Thank you.
All right,
Thank you
my
much.
pleasure.
Thank you. Thank you so much.
Yeah, but just go at it stepwise. Don't, it's like anything else. Don't look further than the rest of your hand. You did a good dissection. Never worry about how much time it takes you. Use what I said of the thickness of the face is your guide to safety.
Yes.
And then do the best you can with the flap. And you got to get an assistant to really, like when you saw them just like tying a knot, you're not moving any tissue. My assistant's 110 kilos. He was a rugby player. We feed him a lot of food. And he's like, with the flap. He really is moving the flap. And that's one, because it doesn't distort. And once you get the first suture or two in, you're fine. The rest of it's just layering it out after that. So much less than 5% of the time. If you see it in the mirror, in the frontal view, if they have bulges here, I treat it. And I can, because I use a little tiny submental incision, and I can get to the fat and the digastrics very easily, but I'm in a tunnel. So I can get to the gland, but I have no control. So it'll bleed, and I have no control. I can't get instruments in there. I say to the patient, I can give you this little incision here, but you see this here, I have no problem taking care of it, but your incision is going to be like this now. They always say, leave the gland. The minute you tell them, and I also do, here's the other thing, is, I'm not talking about complications, but the stump of the gland always leaks saliva. Their neck becomes boggy for a while. And the most important thing in a practice like mine, they have to be back at 2 weeks. And 60% of them fly to me. how am I going to manage? I can't inject 5FU in their neck when they flew 5 hours to get their surgery. So I can't have management issues. And we could be so aggressive with the neck without doing it.
Yeah.
So that's why we're very pragmatic about, and that's why I said I'm not against anything. I'm just saying in my world, we're already doing an incredibly aggressive procedure, and it's rare that that honestly is an issue. Buccal fat, we do that, we see it in vivo because it's easy, and you'd be surprised how many times your pictures are wrong. You think someone's got buccal fat and you get in there, it's not. And but I see it in vivo. If the buccal fat pad, if they're in this position and the buccal fat pad is higher than the masseter, we treat it. The other time we're aggressive in treating it is in older people who've, what happens is their bone structure is starting to shrink and their deep fascia is getting loose. They don't have the tone in the deep fascia. So it's kind of like a lake. It's not like a discrete bulge. Those people we will, right here, what'll happen is this, is so you have this dissected, and this is what your assistant does. They push here. We put like a gauze in here, and he pushes here, and it pushes the fat. See, it's right here. And make a nick in the fascia, and just tease it out. We always have people looking at the face, and then we just take a bipolar and go boop, boop. I don't just go zzz, because by the time my foot's coming off the bipolar, if they twitched, my foot's coming off already. You're never hurting something once. By the way, we never get twitches and take the buccal fat. My big thing is I don't want to get a bleeder that retracts into there. But you know, we're formal. Like Tim Martin's very formal. When he's in the deep neck, everybody's quiet, everybody's focused. When we're in the deep plane, everybody in the room is looking at the face. Nobody's talking. Everybody shuts up. And you don't let any of your staff. To this day, we've been doing this for 29 years. We respect it the same way we did it the first day. The minute where nerves are, just everybody's staring at the face. And if I catch somebody going like this, you're out. You're out. You're getting a timeout. That's not to be tolerated. So, but we just don't, you don't have issues because you respect it, and it doesn't matter how many times you do it. It's all fine until it's not. You're only as good as what you do tomorrow. What you did yesterday gives you a chance to do it again. So, yeah, but we probably take a buccal fat at least 50-60% of the time. It's an in vivo diagnosis. You can have a thought. A lot of times you know it's buccal fat if their jowl is worse than their neck. But you'd be surprised, and you don't need to guess. The other advantage of taking it through a facelift is you're getting the anterior lobe versus the posterior intermediate lobe, which you get intraorally. So you're actually getting the lobe that's more cosmetically effective. And you don't have to take a lot. You just don't, if it's bulging, you don't want it really indented either.
And you close that little cut?
No. Just tease out the fat. Sometimes the fat's very friable and you can't, it keeps on, falling apart. Sometimes it's very easy, it pops right out. And you just take it that, if here's your masseter, and let's say you see this, okay, I gotta take it because they're supine. And then I just wanna bring it to just about here. I don't want it coming all the way indented because you can create a crease if you take too much out. It's an adjunct. You don't have to do anything too aggressive. Those are all adjuncts, but it's an in vivo diagnosis.
Awesome.
All right, guys.
Thank you so much.
Okay.
It may come into the mandible. Okay, so you want to have a good exposure. Now, after that, you do your infiltration and your cutting. What do you want to see? You want to see the platysma. That's the first structure you want to see. By seeing the platysma, you know the plane to dissect. You're dissecting on top of the platysma, leaving subcutaneous tissue on your skin. You can delaminate that skin afterwards. That's subcutaneous. You can address that tissue afterwards. If you address previously at the beginning with the hook, you will be addressing with tension. Addressing it with tension is going to damage the subdermal plexus and the vascularization of the skin more. Then at the end, you just cut according to your artistic decision of the neck and how the neck shape is going to be. So first, you go to the platysma. find the platysma, which normally is a little bit lateral, because in the middle, you have a space in between normally. You can have a decussation, obviously. And you find the platysma, go on top of the platysma. And then you open that platysma. Okay? You want to do it? You want to do it?
Sure, let's do it.
Yeah? Go on.
You want to do it? You want me to do it? Okay, go. I'll do it. Okay. So I'll make your...
So normally I prefer to do it from above.
Should I?
Okay? Okay, and you've seen already that the patient is slim. Okay. Okay, keep this, the whole skin incision. The whole skin. Yeah. Yeah. Downward now a little bit. Yeah. Yeah. Yeah.
Sorry, I got rid of my headlight.
Oh, sorry. I was looking at the forceps. No. You want to find the platysma. Look at the colors. You see a little bit of orange, so maybe you have something. Let's go on. Go on. You do it with the, yeah. It's easy there. It's very slim. Yeah, there it is. It's easy to damage the platysma. If you damage the platysma, you're compromising that tissue that you want to suture, that you want to apply some plastis, right? Okay, now that's good to hear. Yeah. Perfect. On top of the platysma. This is the first important part. If you damage the platysma, besides compromising the result, you'll be nervous and you'll compromise the rest of your steps. So you need to take as much time as you need. Once you have the platysma open, and you will do it at least 3 or 4 centimeters each side, you're going to go upwards. You're going to release the crease. Sorry, I'm taking the light out of you. Okay. Let me just.
Sorry, I came and took mine because I wasn't wearing it.
What size you want?
You can stop if you want, and then we'll move to the when we address the glands and the subplatysma. No need to do the whole thing. Counter traction is important.
So thin, this guy.
Yeah. So what I normally do here, for the subcutaneous dissection, I do like this. I put the skin hook. Somebody stretches, and then I use this. I see the plane, you see, and then. So now we're going to open vertically the platysma at midline, right?
Yep.
So you can address the deeper structures. Again, the first structure you're going to want to analyze, so you're going to open vertically here. Yeah. Then you lift the platysma one side and the other. You want to find the digastric muscle. Okay, not in the midline. You're going laterally now. Because in the midline you can have subplatysmal fat and interdigastric fat, right? So you want to check it laterally.
Would you usually just open that diastole?
You can use with a bovie. You can use with the blade. Now below the platysma you have the first cervical branch of the facial nerve is coming superficial, so laterally it's deep, near the cervical, deeper than the cervical retaining ligaments in the anterior part of the sternocleidomastoid, and then it starts going superficial. Now the first branch of the cervical facial nerve is the one that most often will produce the distortion of the lip, of the lower lip. Okay? Okay. Okay, now to the other side, the same thing. Okay. Higher. Higher. Yeah. Okay. So this white structure you see there, that's the anterior jugular vein, which you can cut it, But normally, if it bleeds, it's annoying. But you can cut. You need to cut it. That's a gland. That's a ganglia. Yeah.
I need to cut this.
Yeah. Take that from your vision, because you want to see the digastric muscle, right? Okay. Now we're going to assist you like this. Okay. Now you want to follow you want to dissect better the digastric muscle. Don't go inside it. Okay, good. Now you want to go and follow it obliquely to the corner of the lateral horn of the hyoid, right, and the tendon. Okay, so now you can put a needle holder, because we don't have a mosquito. Put a needle holder here and let it fall. Okay. Now see, maybe you should come this way. I'll go that way. Okay. So let me just try this. Okay, and then we can use this. So you want to follow it down. Yeah, right. Still here. Yeah, cut. It is. Cut. Okay. Yeah, you can palpate to see where the hyoid is if you have doubts. Okay. There you go. Yeah, just go lateral. Just release more the platysma from. Let me change the head a little bit. Release more the digastric from the platysma. If you have difficulty in finding the gland, what you'll do, you may put a suture like a nylon 3-0 between both tendons of the can you grab there, please? Both tendons of the digastric, and that will pull the gland medially, which then you may release that suture at the end. Okay, I think we have space for me to put this one. Okay. Now, do you have more? Yeah, so okay, so the gland shouldn't be that far down. Release more the digastric here from the platysma.
Release more.
Yeah, then the digastric. Okay. Now you need to start looking for the gland now. You got the gland? Perfect. Now let me put this more into facing you. Can you assist me here? Have the gland there?
Hi. Here's the posterior belly.
So it should be higher up. Yeah. Higher up here.
So if somebody's submental gland is this hard to reach, would you just leave it?
Well, you have to have a pre-op diagnosis, either only clinical or together with the ultrasound. Check where the mandible is. Mandible is here. So you don't want to go inside the mandible. Below the mandible, I mean. And it should be closer to the platysma, not that deep. Once you find the gland, you open the gland with a bovie.
Way over here. Oh yeah, that is it. Yep, yeah.
Yeah? Okay.
Way out. Oh wow. Sit down.
So once you have the gland, you open a little bit the capsule.
Get on the medial surface. Yeah. Open the capsule.
open the capsule, grab the gland with an Alice clamp. And then with a mosquito, you go within the capsule.
So I'm going to use a needle driver.
Yeah. Okay. So what do you want to do? You want to go inside the capsule and you want to release the entire gland. And you got to do it with time. It has to take time. Okay? When you're cutting the gland, whatever cut you do on the gland, the direction of that cut, the posterior part has to be cleaned. You get it? So you want to cut the gland like this. This is your artistically way of cutting the gland in order to produce the result that you want to produce, right? So you cut it this way because it's protruding from the mandible, right? You want to cut it like this. Behind, posteriorly, you have to have this cleaned, because if it's not released from the capsule, you may have the facial vein behind or the facial artery. So if you don't have that area released, so change the angle of excising the gland. So you do it more so, because here you have it, right? So whatever direction of the cut, you have to have a freed posterior part. And once you do that, you will see the stump of the gland behind with more space, more visibility, and then you release it and you cut. Now, if it bleeds, there are 3 basic steps you got to do. First, don't release the traction. By applying pressure, the vessel is not completely open. If you release it, the vessel can retract and the vessel will flood your field. So don't release it and continue it with the Bovie. Okay? You have to have a Yankauer suction device. If you're not controlling it, you just put your finger in and wait. Ask for the anesthesiologist to lower the blood pressure. You relax. The team prepares to that more stressful part. You wait a couple of minutes, and normally the bleeding has come down, but it's still there. So then you do, and you clamp it. Clamp it, and you coagulate. Simple surgical rules. If that doesn't give you enough, it's not enough, you put your hand inside the mouth and press downwards. That will make the gland protrude, you make pressure, and then you see the vessel in your camp. I have never needed to do that. Okay, but keeping calm is the most important thing. Okay?
So from this view,
yeah.
When we're looking at it this way, where is the duct of the gland in relation to
the duct? Yeah. Oh, the duct is high.
Like if I don't,
no, there's no problem. The duct is above the mylohyoid.
Okay.
The duct is above the mylohyoid. You're never going to cut it, okay? Don't worry. So releasing everything, starting to cut. You can use the ligature, or you can use the Bovie. I use the Bovie. Okay? And by using the Bovie, as long as you're doing it calmly, you have everything released, everything's going to be okay. And then it's an artistic decision of whether that is enough or not enough.
We're going to be concluding the second annual Facial Aesthetics Deep Plane and Beyond course. I'd like to thank you all for joining us on the webcast. It's been an amazing course, great faculty. I'd like to thank all the faculty and those who attended this year. We'll probably have this course again in summer of next year. Another in-depth course focusing on the great aspects of facial aesthetic surgery.
So I also want to thank you all for joining on the webcast, and I would encourage you, if you have the opportunity next year in person, we'll do it next summer. Not exactly sure the dates yet, but summer. It's an incredible facility. The events have been fantastic. The city's fantastic. So either join us on the webcast or consider in person, because it's a great experience.
I'll mention one more thing too. We're going to be sending out a survey after the event, and I'd greatly appreciate if you send in your feedback, what you liked and disliked. We definitely use this information to make judgments about future courses. So,
all right, all the best.